Good morning. It's 7:57. We will be starting promptly at 8 o'clock. 8 o'clock. Morning. It is 8 o'clock in the Bahamas, and we are going to get started. I am Dr. Francis Williams, and I will serve as your moderator for this session. Welcome to UWI School of Clinical Medicine and Research, the Bahamas Postgraduate Careers Seminar 2021. The challenges of postgraduate medical education for Caribbean nationals, planning a career in postgraduate medicine, when, where, and how. This morning's session is entitled Planning the Journey, and we have two exciting speakers, Dr. Charita Moxie and Dr. Robin Roberts. Our first speaker, Dr. Moxie, is a physician. She's a certified public health specialist and a fellow of the Royal Society of Public Health. She has served in numerous leadership roles at regional and international health fora. Notably, she was the vice chair of the Strategic Advisory Group for PAHO, with responsibility for setting the health agenda and roadmap for the region of the Americas for the period 2020 to 2024. Dr. Moxie has been a principal investigator on numerous novel population-based research. She was the champion for advancing the conversation and policy consideration for revision of the National Health Breadbasket. She is currently the lead for the Health Policy and Planning Unit of the Ministry of Health. She has authored the publication titled The Bahamas Physician Workforce Today and Tomorrow. She is a wife and a mother of two. Dr. Moxie's presentation this morning is on physician human resource needs and projections in the Bahamas. The floor is yours, Dr. Moxie.
Thank you so much, Dr. Williams. I will just ensure that everybody can see my screen.
Yes, we can.
Okay. Okay, just give me one moment so that I can get into presentation mode. Okay, again, thank you so much, Dr. Williams, and a beautiful morning to all. It is a pleasure to be with you today in this virtual space. We know that COVID-19 has certainly changed the way we live, the way we love and stay connected with others, the way we learn and acquire information. Before we get started, though, just wanted to give a little disclaimer. I have nothing to disclose and I have no conflicts of interest. For most of you, obtaining your general medical degree took at least 5 years. To play ball in this medical market, however, more than just a generalist degree is required. And most will dedicate at least an additional 2 years for residency to obtain specialization. At this junction in your careers, there is much excitement on the milestone that has been achieved, but there is also, and understandably, anxiety about the road ahead. There are several decisions before you. Should I specialize or not? If I specialize, what should be my area of focus? Does my specialty interest have utility in New Providence and Grand Bahama only, or can it serve the entire archipelago of our family of islands? This conversation today is fashioned to give you the context to inform these and other questions and decisions. I will share, as Dr. Williams would have said, on the national physician needs, projections, and priorities from the perspective of the National Health Authority, which is the Ministry of Health. The former Director General of the World Health Organization, Dr. Margaret Chan, made the unequivocal pronouncement that there is no health without a health workforce. As health authorities, both nationally and globally, rethink approaches to health systems and health service delivery, additional dimensions have been given to the health workforce. These dimensions speak to the optimal number, the optimal mix, the optimal competency or skill set, and the optimal distribution or availability of the health workforce. The Bahamas' National Health Services Strategic Plan, specifically Goal 4, the strengthened health workforce, reflects these dimensions. So as we move on and look at the physician landscape in the Bahamas, we note the fluctuations in the pool of physicians over the last 2 decades, with the total physician numbers trending upwards over the last 5. There are currently 1,048 physicians available in the local Bahamian market, and this translates to a physician density of 26.2 per 10,000 population. For high-income countries that fall in the region of the Americas, which the Bahamas does, the desired density is between 21 to 29 physician per 10,000 population. So from a right number or optimal number perspective, the Bahamas seemingly does not look too bad, but we will touch on this a little bit later in the presentation. There are 2 important points, though, to garner from this graph. The first is that residency programs became available locally in 2002. And second, the seeming increase in physician numbers between 2000 and 2008 might be attributable to the BMC register reflecting active, inactive, and deceased physicians. So, what are the factors influencing physician demands? And this would be true for the Bahamas and other territories. Population growth is certainly one of them. The Department of Statistics estimates that the population has grown 12% over the last decade, from 2010 to now. Our epidemiologic profile: the burden of disease for the Bahamas is greatest for NCDs and injury due to violence. These demand factors also take into account health literacy and patient expectations, health governance and the model of care, health delivery and utilization patterns, and physician factors. As we look at physician attrition, either as a result of retirement, relocation, or death, these are certainly components of the physician factor that influence physician demand. This graph underscores that as physicians are added to the national numbers, that variables such as physician attrition must be incorporated in our modeling estimates. Using 2015 as a baseline, it is estimated that the pool of physicians available would be reduced by 101 over a 20-year period as a result of retirement alone. But I highlight the fact that this is not just a numbers game. The goalpost is having the optimal number, the optimal mix, the optimal skill set of physicians that are available to meet the needs of the country. So what is that optimal mix? There are currently 379 active physicians listed on the specialty register of the Bahamas Medical Council, and this accounts for 36% of all physicians who are registered and active. Within the specialty grouping, 174 or 45.9% are females, and 202 or 53.3% are males. The majority are age 50 or older. Currently, the 10 most saturated specialty areas as reflected on the screen are family medicine at 47, obstetrics and gynecology at 37, peds at 35, internal medicine 26, radiology 20, ophthalmology and anesthesiology 19 each, general surgery 18, psychiatry 17, cardiology 16, emergency medicine 15, and orthopedic surgery 13. Taking a closer look, though, at the demand factors that we spoke of earlier, in combination with the population distribution, it becomes apparent that high numbers does not necessarily translate into population needs being met. Against this backdrop, then, what are the skill sets or specialties that are in highest demand for the country? And here we have it from a Ministry of Health perspective: ENT specialty, emergency medicine, family medicine, geriatric medicine, internal medicine, physicians with public health, masters in public health training, urology, oral maxillofacial surgery, and this is as a result of what we call a single point of failure in country at present. We have one such individual in this specialty, and that individual is approaching retirement. Additionally, the highest in-demand specialties are peds, psychiatry, and radiology. The Ministry of Health has used different modeling approaches to forecast how many family medicine specialists, internists, pediatricians, and psychiatrists the country will need by 2030. The different approaches give different results, and the results suggest that by 2030, between 60 and 96 family medicine physicians will be needed. Between 81 and 102 internal medicine internists will be needed. Approximately 60 pediatricians will be needed. And between 24 and 73 psychiatrists will be needed. The number of physicians with the right skill set positions the Bahamas to better respond to the health needs of its people and to make strides towards the ambitious 2030 Sustainable Development Goals, which have no doubt been slowed as a result of COVID-19. There are 17, and this is for your knowledge, there are 17 Sustainable Development Goals. Goal 3 is specific to health, and within Goal 3, there are subsets of goals. But germane to our conversation today are Goals 3C, which targets sustainably increasing health financing for the recruitment, development, training, and retention of health workforce. Goal 3.2, which speaks to ending all preventable diseases, preventable deaths, for those under the age of 5. 3.4, which speaks to reducing premature mortality due to NCDs and to promote mental health. And 3.8, which speaks to achieving universal health coverage. But again, it is not all about numbers. It is having the right physician with the right skill sets in the right location. Primary health care is the cornerstone of universal health access and coverage. The January 2021 edition of JAMA highlighted a cross-sectional study of physician density across the United States. The findings showed a high density of primary care physicians and specialists in urban compared to rural counties. This rural-urban gap is mirrored in the Bahamas. And unfortunately, the medical training and orientation in the Bahamas continue to be very Nassau and hospital-centric. Our family island populations continue to experience chronic shortages of physicians. And compounding this is even on islands where a physician is present, the physician has not had postgraduate or specialty training in family medicine or internal medicine. As we look across the archipelago, excluding New Providence and Grand Bahama, there are 10 family medicine and internal medicine physicians on other islands. Within the public health sector, though, of the 5 physicians, for example, on Eleuthera, only 1 is family medicine trained. There are no publicly engaged family medicine or internal medicine trained physicians posted on Andros, Exuma, Cat Island, Eleuthera, and the list goes on. Moreover, outside of the capital and the second city, there are no resident pediatricians, internists, or psychiatrists on any family island. The optimal number in the optimal location with the right skill sets. So that is the context and the backdrop. If you decide to specialize, then what is the process? No doubt you have to qualify yourself. You have to seek national endorsement, and depending on whether you are employed with the Ministry of Health or with the Public Hospitals Authority, that national endorsement would look slightly different. And then, of course, you have to consider funding. And we will get a little bit into steps 2 and 3 on the next slide, which is the last slide. So eligibility criteria for in-service awards. An in-service award is defined as paid study leave granted to serving public officers to pursue a course of study that is of priority to the ministry or the institution. We see that there are several criteria. For both the ministry and the PHA, you must be a Bahamian citizen. In terms of age, the ministry has set the criteria that you must be less than 50 years. You must be permanent and pensionable for the ministry to be considered for an in-service award. For the PHA, you could either be permanent and pensionable, or you can be on contract. We know prior to 2006, physicians would have been PNP, and post that time, they would have been on contract. For the Ministry of Health, again, the eligibility criteria is that you must have served at least a minimum of 3 years within the service. And for PHA, that service requirement is 1 year post your SHO appointment. You would have had to serve at least 5 years. The duration of the in-service award for the Ministry of Health is a maximum of 5 years. And again, both require that your area of pursuit be a priority area for the country. We talk about submission deadlines, and then we get to the type of award. For the PHA, the successful applicants will only receive a paid study leave. With the Ministry of Health, the options are a bit more varied. The individual, if he or she is successful, can be awarded a full in-service award, which includes retention of your salary, approved leave for the period of study, full tuition, training allowance, round-trip airfare, and you also have, sorry, that's one round-trip airfare per academic year. There's also such a thing as a limited in-service award for the Ministry of Health. And
1 minute,
this,
please, 1 minute.
thank you. This could be either you retain your salary, or you retain your salary and get 2/3 tuition, or you retain your salary and they provide full tuition, or you just get tuition alone. So in conclusion then, at the end of the day, it is your personal choice. However, that personal choice requires that you fund your own postgraduate training if the area of choice is not aligned with the institutional or national priorities. Regardless of the specialty you choose, it must be emphasized that we all play a role in disease surveillance, patient education, and also the pursuit of all public health matters. And with that, I thank you and I end my presentation.
Thank you so much, Dr. Moxie. Very informative presentation. And bearing the time in mind, we will take questions at the end if time permits. And that is after the next presentation if time permits. Our next presenter is Dr. Robin Roberts, who is no stranger to any of us. He graduated from the University of the West Indies and did his specialist training at Dalhousie University in Canada. He holds an MBA from the University of Miami. He is currently the director of the University of the West Indies of Clinical Medicine and Research in the Bahamas and chairman of the board of the National Health Insurance Authority. Dr. Roberts' presentation this morning is Statement of Purpose, the SCMR Bahamas Experience, Challenges, and Outcome. Please, Dr. Roberts. Dr. Roberts, the floor is yours.
Good morning, everybody. I'm just trying to load up my slide here. Here we go. Okay, good morning, everybody. I share with you this morning our experience, challenges, and opportunities in the teaching and learning of undergraduate and postgraduate medicine in the Bahamas. In my outline, I intend to visit our milestones, address the issues, are we producing too many doctors, explore the new frontier of medical education, and explore our challenges and directions. We have come a long way, but we learned that direction is more important than speed. We have passed many milestones. We have come from a 1952 colonial facility to an upgraded critical care block with a state-of-the-art operating room and an adult and pediatric intensive care unit and laboratory services, ideal for teaching. From a 6 main hospital services some 40 years ago, highlighted in yellow, when I was an intern, to over 40 specialty and subspecialty services manned by board-certified specialists. From a rudimentary small reading room with a once-a-week clinical case presentations in the 70s, and now 20 years later, to a teaching hospital with undergraduate and postgraduate training programs under the auspices of the UWI Faculty of Medical Sciences. From 6 in 1980, our largest UW class size of Bahamian national medical doctors at that time, to averaging 30 to 40 students per year in the new millennium with the birth of our local UWI medical school and faculty. Since our first graduating class in 1977 at SCMR, it's been a steady exponential growth. We have produced 513 medical doctors, of which 94% are Bahamian nationals. We must now ask the questions, are we graduating too many doctors? I argue no. Dr. Moxie just outlined the issue of attrition, meeting our future demands, the issue of deployment, appreciating that Nassau is not the Bahamas, meeting our population demands, both for family medicine and non-family medical specialists. I just wanted to highlight that now, since our development, we have one ENT surgeon on our PMH staff. And then, of course, there's the now increasing brain drain, the external demand for physicians, which we never experienced before. But first, we must recognize the need to reform the way we train doctors. The new doctor for the millennium must be competent to manage the issues of affordability, defining a new curriculum, changing the teaching and learning environment. We all appreciate the increasing cost of technology and pharmaceuticals, the high utilizations as we age, and the need for us to manage our limited resources. We realize the massive increase in new knowledge that happens every day. The whole issue of rote learning is gone. Computer access and simulation is in. We have a learning environment with increasing patients being managed in the outpatient versus the more critical, sicker patients, those smaller volume inside the hospital. And then, of course, we must be cognizant of our new changing patients. They are better informed. They want to participate in their care. We have the issue of informed consent, and they are much more prone to sue their doctors. And then, there is the issue of the Libby Zion case in New York in 1987 from the overworked and undersupervised resident, and the implementation of the Eastern European Eastern Time Directive and the need to reduce physician hours. We must provide for better quality patient care and quality of life for physicians. We must study the impact of an increasing female physician population on residency choices and time demands. So I submit we need to employ more doctors. In fact, as far as I'm concerned, all we can get. So let's look at our challenges. The one thing that's certain, Dr. Moxie beautifully outlined, the completion of our first medical degree is not enough. We need at least 4 more years. Specialty training is now required for independent practice of medicine and the delivery of quality care. To do that, we need to rid ourselves of the old system of house officer grade doctors as career jobs. Every medical graduate gets a turn to become a specialist in the postgraduate arena, and it's very competitive. We need that equilibrium. Doctor in, new interns, and old doctors out. The interns come in, they do postgraduate training, and they leave. Government owes the opportunity. Government does not owe us a job. With our small numbers at the school in the Bahamas, we have the capacity to do that, to meet our needs. If we look at where we have come from since we started in 2002, we have produced some 105 specialists. Almost 50% of them are family medicine doctors. And we can accommodate some 40 new graduates. We can accommodate our 40 new graduates or so that come from our school. We are also looking to expand with another 3 specialty areas that have made a request. There's radiology that's been banging on the door for the past 2 to 3 years. There's orthopedics, and now we have anesthesia. So I think that we have every reason that we can meet our specialty needs, at least most of them locally. But I think it's important for us to encourage diversity. So the purpose of this presentation today is that we also encourage our students to look elsewhere, to go to Britain, North America, to be able to get that new information and knowledge, a new way of doing things, and to come back and cross-fertilize our new strategic plans and better the healthcare in our country. But again, well outlined, it introduced that we need to recognize our specialty and subspecialty service needs. We need to be able to match our training to our service needs And we also must be mindful of our non-clinical specialty needs, such as management and public health, okay? Yes, there are great benefits in training locally, and I encourage that. But I think that one thing I want to admire, particularly the Department of Surgery and the efforts of our head of department, whereby we are seeking, when we finish our DMs, that all of our graduates go and do a postgraduate training. Again, they go and do a fellowship, and then they come back and to enrich our fold. And so I encourage all the DMs that it is not the end, that when pediatrics, we need to look at all the subspecialty areas. We need to go forward and do the fellowships. And that is where we need to go as we move this to the next level. Of course, we must incentivize them to look at the available jobs and the places that we like them to practice. And the fellowships are within service. I'm glad that she outlined for our young doctors where the great needs that the government see in planning the budget. The second challenge that we have is the backlog. A backlog of physicians, some 300 identified house staff doctors, some of whom have been in the system for 15 years as house officers. The lost tribe of doctors, mainly undersupervised and untrained. This backlog translates to no jobs for the young physician graduates, and it translates to some $17 million a year from the government's coffers. But we propose that our diploma program in family medicine, I'm very pleased to see that the Medical Council has now fully accepted it, and that this program, based in primary care ambulatory curriculum, I feel can best do this. That ambulatory community-based curriculum also allows for increased training capacity in the private sector through mentorship and teaching modules. And we propose that such an initiative is more progressive and produces a better graduate than an earlier proposed foundation program. I think that there is definitely, we have the same objectives. We want to get on the same platform. And I think that we can partnership to provide us to have better doctors for the future, not just numbers. But here is our main challenge at this time. We have some 80 to 90 MBBS students enrolled currently in our 2-year program, a similar number of DM students enrolled in the postgraduate program. We only have some 6 full-time lecturers in the MBBS program. We have no DM lectures in the postgraduate program. It is very clear that we cannot continue on the backs of our associate lecturers alone. We need to increase their remuneration. So all in all, we need money to do this. And it can't be from increasing our tuition. I believe that we have the National Health Insurance Plan, of which I'm proud to be a part of. And we look at this new primary care transformation initiative where we are trying to amalgamate all the silos of primary care being produced in the private sector, in the public health arena, in the Public Hospitals Authority, that we are able to put them under one umbrella to maximize efficiency and effectiveness and using a one country electronic health records. And as we look at doing this, we are looking at saving some $55 million over the next 5 years. So I think what we are looking at is potential funding for our medical school as we seek to fund the healthcare human resource needs, as Dr. Moxie has so beautifully outlined prior. And finally, I think that we must be very mindful that the delivery of healthcare today is a team effort. We talk about the healthcare team. We have an acute on chronic shortage of nurses. We have an acute on chronic shortage of allied health staff. I feel very strongly that our University of the Bahamas has yet to meet these needs. There was a time when a couple of years ago, we actually had more medical students graduating than we had nurses. And so we cannot, as a physician body, not advocate and be a part of whatever efforts are needed in order for this to happen. And so we're in a position that I see where there are some of these jobs that require less than 2 or 3 years to be professionals. So we really should not be in a position where we have an unemployment rate of some 1 out of every 3 of our graduates from high school. COVID-19 has come upon us and has slew the world, and the world has collapsed and it's in crisis. But I strongly believe that we should not waste this crisis. We need to embrace the physician career opportunities that are available to us. We need to look at the fact that while there is an issue of brain drain, you will see that we've been able to get our Bahamian diaspora to be a part of this program. I think you will see at the end, we one of our guest speakers, Professor Ren Holness, who while his total time that he was in Canada, probably made a bigger impact than anyone else that I know in terms of meeting and assisting in providing the human resource needs for the Caribbean, including the Bahamas. And so we look at this time where in North America, I think they're opening the doors because of the needs, the same in Britain, that we need to take opportunities as well to seek for postgraduate training abroad. And so I'm hoping that our students would take advantage of the individuals who they will be exposed to during this forum. And of course, I look forward to them returning, because there are still a number of specialty areas and within specialties where we can't do it alone in the UWI, nor do we want to do it alone. And so we need to look at the international arena as well. At the same time, we harvest the benefits of doing our local training. And this is where the cross-fertilization becomes so much better as we seek to ensure that we have the best physician healthcare resource that we can provide for our country. And with that, I hope we have enough time left for questions. Dr. Francis?
Yes. So thank you so much, Dr. Roberts. We have surpassed 8:30. However, I will allow for 2 questions. So if there is 1 or 2 persons who wish to ask a question, please feel free at the moment. We'll allot 5 minutes for this. Are there any questions? Comments? Okay, well, I think that the information shared this morning was very informative, certainly enlightening. And I think that certainly it was quite crystal clear in terms of what Dr. Moxey and Dr. Roberts offered. If there are any questions at a later time, you can feel free to put them in the chat and we will seek to get your questions answered. I would like to thank you for allowing me to be your moderator for this morning's session. And the next session will be moderated by Dr. Corinne Sinqui. Dr. Sinqui, please. Good morning.
Good morning, everyone. And I'd like to congratulate Dr. Roberts for putting on this symposium yet again. And this is not the first time he's done so. And he's very masterful in putting together a fantastic set of speakers. And he has done so again this year. And I think that the Bahamas is unique in the possibility of having persons trained from all over the world. And because we have such a cadre of physicians, we are actually very receptive and open to training elsewhere. And this is unlike some of the other Caribbean countries. And I think that this is great because it allows us to be able to mix and mingle and have ideas. And, you know, it just broadens our views. Our first speaker is Professor Upton Allen. And Professor Upton Allen is actually a UWI graduate, person that I met in the 80s. And this was while he was here as an intern and then an SHO. So he actually has a special part of his heart here in the Bahamas. And he went off to do pediatric and pediatric ID. He is now the director of the program in ID at Sick Kids and the University of Toronto. And he's always looking for opportunities to give back. And he has done so in the form of partnerships with Jamaica, the Caribbean, and we have definitely benefited from his expertise here in the Bahamas. Of special note, he was recognized for his work and awarded the Order of Ontario in 2018. And we are just so proud of Professor Upton Allen, and would like to hear all of his comments with regards to Canada, requirements, challenges, and realities. Professor Allen, please take over.
Good morning, Corinne. Thank you very much. And thank you, Robin, for inviting me. This is really a very special session. And of course, I had no hesitation in accepting the invitation to present for a few reasons. One, I never say no to Robin, but also I heard that you're going to have Jean MacDonald on the panel. So of course, with Jean being involved, I have to be involved. Of course, my friend Corinne as well. So thank you very much. I wanted to focus on the Canadian perspective. And this is, in essence, what I'm going to talk about in the next 10 to 15 minutes or so. Main points are preparation in medical school, relationship building, and so on and so forth. I have put an asterisk against some of the key items that trainees really need to be aware of way in advance so that they can plan accordingly. I will make some reference to some of these as we go along. Let me just start with working from the top in terms of the key points. I'd rather focus on how to be prepared and how to be competitive in getting into postgraduate training in Canada, in fact, in North America, for that matter. And the first relates to preparation in medical school. And I mention this simply because we have seen situations where individuals have come into the system for postgraduate training, and they're competing for positions alongside others from around the world and including in North America. And one area that always comes up is the extent to which they have been engaged in research and scholarly activities during medical school. We recognize that this represents a challenge for many individuals in the Caribbean, but it's important to recognize that that's an issue. And so the way that I know some students have handled this is during their electives, they've done research projects, they have highlighted the nature of their exposure to research as it relates to the courses that are taught, and again, emphasis on projects. So I want to just highlight that because that I see has come through time and time again. The second bullet relates to relationship building. And Robin eloquently described the relationship that existed between Rain Holness and the Caribbean, and their personal connections in that regard. Recently, well, in November, the Canadian chapter of the University of the U.S. Indies Medical Alumni Association hosted a special forum, very similar to this one, but focused on how to inform people of what they need to do to get into the Canadian system. We had a plastic surgeon, we had a pediatric subspecialty director, and several other individuals, neonatologists. And one of the things that came out very clear, crystal clear, was that particularly on the surgical side, there was a feeling that one of the challenges was that while they recognize how solidly clinically competent graduates of the University of the West Indies are, what was often not clear is the extent to which they would function effectively clinically alongside their North American colleagues. And so the surgeons would say, well, simply, we just don't know them. And so we said, well, how do you address that issue? And the plastic surgeon said, well, you have to start early to build a relationship so that we know who trained you, who you're working with, and that we get to know you. So that's a really important point to remember. Now, the asterisk points are important. One needs to be aware of the Canadian entry exams, the immigration issues, and then the entry pathways. Now, with respect to the exams, and I myself always have to look this up, so I would suggest prospective trainees do look this up way in advance so that they know exactly what is required. And so in the case of Canada, the Medical Council of Canada exams, there are two parts, as you can see. First, the MCQE. One is a multiple choice exam, and then there's the NAC, which is on OSCE, which is on hold now because of COVID. But the key is to become acquainted with the exams and also recognize the fact that there's often a minimum duration of time between when the exam has been written and successfully passed versus when one enters the program. So really important to become familiar with those exams. With respect to immigration, this varies, across provinces, but there are some general principles, and the variation across provinces has more to do with the extent to which a particular institution will go to bat for you to get you into the system. And so for some provinces, it might be a bit easier. So one needs to be aware of where you're applying to and the ease with which you can get into the system. Next are entry pathways. Very important to be acquainted with this. And this one gets a little bit tricky because I'm just going to speak of Ontario. There are similarities across most of the provinces, but in general, the individuals who are coming in, for the most part, would be defined as clinical fellows. And this represents an opportunity for physicians to obtain advanced training or to acquire focal specialized expertise during their particular training. And this means that these individuals must have been recognized as specialists or family physicians. And so essentially then it is a short-term educational experience, and it doesn't lead to a specialist certification by the Royal College of Physicians of Canada. And so one needs to be aware of the pathway that one needs to activate so that one gets the Royal College certification. So it's really important to know which pathway you're following. Now, the other point to bear in mind is that there has to be eligibility to be licensed as a clinical fellow. And this is a loaded word, eligibility, because what does that really mean? Well, it means that the postgraduate program at the particular university has to give the green light to the college to give you an educational license. So in this case, the University of Toronto authorizes or gives an authorization that the college acts on, and the college will clearly state that we have a right to say yes or no. But generally, they say yes. And so the trigger for this recognition might vary across different countries. And in that regard, for example, there are categories along the pathways that people enter. So for example, in the case of the University of Toronto, there is an arrangement between the University of Toronto and a number of countries around the world, such as countries in the Middle East, for example, where there's a special sponsorship by those countries, and so fellows can enter through that pathway. But doesn't necessarily mean that if there isn't an established relationship, the trainee can't enter through a sponsorship pathway. It means that the particular country, so in the case of the Bahamas or wherever, that the sponsorship is done at an official level by the Bahamian government or a designated institution. The key in that regard stems from a recognition that in most of the Canadian provinces, and certainly in Ontario, one has to follow certain manpower labor laws. In that regard, you can't just have a fellow come from a particular country around the world and volunteer and do the same work as a Canadian and doesn't get paid exactly the same. And that was the case many years ago, but now that has changed. And so essentially, a sponsored fellow who's coming into the system has to show that they're going to be paid exactly the same amount of money as their Canadian counterpart. It doesn't work out to be exactly, but close enough. And so that's the prerequisite in Ontario. And so one needs to be aware of that in planning your sponsorship. Now, I recognize that there are several other factors, and I just want to go back and touch on a couple of others. One is, again, in preparing, is the letters of reference. This is really so important to ensure that one has solid letters of reference. At this forum that I mentioned that we had with the training program directors in Canada, sponsored by the University of the West Indies Canadian chapter, what came out very clear was that they preferred when trainees didn't see their letters of reference. That's number one. Number two, you should choose referees who you know are going to write a really good letter. If they write that you're average, if you're average, you're average. But if that's what a letter says, then you might not be as competitive as you'd want to be. So really do bear that in mind. It's really important to have strong reference letters. And I pause for a moment to think of my own experience and when I was coming to Canada and getting letters from Gomez and Ronnie Knowles. And I remember a letter, somebody told me about it afterwards. It might have been, I can't remember how I found out about it. But this, in the letter, it said, one of them, I can't remember if it was Ronnie or Gomez, said, I write this letter with the utmost sincerity. Those are the letters that make a difference. If you write a letter that is average, it might not make the cut. You want letters that are really clearly, sincerely over the top. And so I really do appreciate Ronnie and Perry in that regard. Now, the clinical experience is important. That's where also the reference letter can speak to that. Because you want to ensure that the person who's coming into the system is going to be able to function effectively clinically, both from a medical perspective as well as a surgical perspective, but clinically alongside their North American colleagues. And so it's good if the reference letter brings out the person's clinical training and what they have done, because I think that's really important. Now, some programs like if a person has some Canadian experience, and for that, we're talking about opportunities to do electives if you can. I think that's would be an asset. And then, of course, scholarly activities. Now, I made reference to preparation in medical school. I'm coming back to scholarly activities, where if you look at the average postgraduate trainee leaving a Canadian medical school, medical undergraduate program and going into postgraduate training, they all have, a bunch of research papers and presentations. So it's really important to identify what are some of the things that you can do to make yourself attractive as this relates to research and scholarly activities. Doesn't have to be anything amazingly fantastic, but just to show that you've been involved in case reports, in case series, in review articles. You're presented at your local medical conferences. Do bring out the scholarly pursuit, because you'll be competing alongside others who would have been doing that. And again, the training programs directors with whom we met brought that out very clearly, that it's really important to reflect to the fact that you have been engaged in scholarly activities. So with that, I will stop, and I thank you very much. It's a pleasure to be with you today.
Thank you very much, Professor Allen. And we will move on to our next speaker. And our next speaker is Dr. Don Major. And he is also a UWI graduate. And I think Dr. Roberts handpicked him to give the second talk. And the reason for this is that Don is the first Bahamian graduate for the DM surgical program locally. And we're very proud of him. And he went on to do a fellowship in oncology surgery and hepatology. And, it's really heartwarming to see that Don has moved on. I remembered him as a medical student, and now he is a fellow consultant. So I'd like to go ahead without any further waiting time and and ask Don to go ahead with his talk.
Good morning, everybody. Thank you, Dr. Sinkri, for that kind introduction. Just now looking to share my screen. Just bear with me a second, please. Here we go. Share. Can everybody see my screen?
Yes.
We can.
Thank you. Thank you. Okay. First of all, I'd like to start off by thanking Dr. Roberts and the organizers of this talk for allowing me the opportunity to just give some insight in my fellowship there in Canada. My name, as introduced earlier, is Dr. Don Major, and I did my fellowship in hepatopancreatic biliary surgery, as well as surgical oncology at the University of Calgary in Canada. Presently, I'm a consultant HPB and surgical oncologist at the Princess Margaret Hospital. So how did I get there? How did I get to Calgary? And I think the number one reason behind me getting to Calgary was having a strong mentor. And I really believe that that is important because entering the surgical program, I came across various specialties. And what I realized going through those specialties was that everybody had some subspecialty on top of their surgical training. And the majority of them would say, well, are you interested in plastics or are you interested in cardiothoracics? And if you're interested, we can get you a fellowship or we can get you some international training somewhere. So I felt that that was a common theme there in surgery department. So one of the things going forward, I decided that I liked general surgery, and I decided that I would stick with a mentor that was willing to get me some form of international training, or at least get me in the door. And when I say get in the door, that's where the elective comes into play. And I did my elective in the 4th year of my surgical training. And it's here where I first was introduced to Canada and its cold weather. Another thing that you want to be as a resident, you want to be hardworking, you want to be able to work well with others, you want to have some dedication to your craft. And I think at the bottom line, a bit of it is some luck also involved. So a bit of my timeline, I actually graduated medical school in 2009 from UWI Bahamas. I completed my internship in June 2010. I started general surgery residence in June 2010 and completed residency in November 2015 at UWI Bahamas. I started fellowship in July 2017, however, and I completed fellowship in June 2019. So it's almost a 2-year gap between my completion of my residency as well as my commencement of my fellowship. And what was happening during this 2 years? So actually during this 2 years, I traveled to Calgary on 3 separate occasions. The first that I told you about earlier was an elective in which I spent 6 months in the surgical oncology department, which I met some great people. I was able to operate with some of the lead surgeons in surgical oncology up there in Canada, and I had a wonderful time. The second trip was when they actually brought me back for an interview for a fellowship position in surgical oncology. At this interview now, I was from the Bahamas. Again, with respect to what Professor Allen was saying, I didn't have as much in the line of research. I may have had one paper, but I presented at multiple different conferences. And I was told that I actually made it to the final 3 candidates, but I was not selected for a fellowship spot. This, at that time, was pretty disheartening. So I went back to the Bahamas, trying to figure out my next step. And my mentor at the time, Dr. Wesley Francis, he wouldn't let me get down by this. And he said that we would figure this out. So the following year, I actually went for a third trip to Calgary. And this is where I did another elective in hepatobiliary surgery. And this allowed me to actually get in the door and do some HPB as well as surgical oncology training. This is some pictures from the hospital and the view from the hospital with respect to my elective. As you can see, I'm there in a pretty thick jacket in minus 10-degree weather. Never experienced anything like that before in my life and hope to never experience that again. The other issue was immigration. Now, my paperwork didn't come in until January, and I was starting the actual fellowship in June of that year. And I put in for the immigration or work visas in February, and it didn't arrive until actually just prior to me leaving. So one of my things would be to, if you are actually planning on traveling to Canada for a fellowship or any other training, try and get in for your immigration applications quite early because they tend to take a bit long. And there's really no one to call. Anytime you call the number that they have at the bottom of the screen, it's always an automated teller, and you never really talk to any people in general to help you. But once I got through the door and I got my fellowship, I was able to rub shoulders with some of the greats. Here in the picture below is Dr. Mack. He's our program coordinator, along with Dr. McKinnon, one of the senior surgeons. We also had some skills labs. Here I'm training with some 10-0 sutures and trying to master my microsurgery. Warning, these are some pictures of some of the actual surgical procedures that I may have performed. And another benefit that I found going down for fellowship and why I was so happy to do it was that you're operating quite a bit. From a surgical standpoint, yes, PMH, we have quite a few cases, but we usually operate once, maybe twice a week. But at fellowship, I was operating at times 6, 7 times a week. Almost the entire week we're operating, Monday to Monday. Some weeks it'll be slower when I'll attend clinics, but the majority of the time we're operating, we're getting in cases. So this is one of the bigger cases that were done. This lady had a anterior thigh sarcoma that we resected, and you see the white conduit going there. We had to resect the artery, and we did a vertical rectus abdominis muscle flap to kind of close that defect. Another one showing a ginormous spleen. This is one of the biggest spleens that I've ever taken out. It weighed about 10 pounds, 20 ounces. And these were the kind of cool cases that I was exposed to that not necessarily I would have seen here in the Bahamas. And basically, if these were to come through the door today, I'd be a bit more comfortable with managing them. Again, it wasn't all about work. We did have some fun at the time. These are some of the guys from the hospital taking me out mountain biking. I always thought it was easy to ride a bike, but mountain biking is a totally different experience. Again, I took my family with me. So my wife and I, we went to see Oprah while we were there. She came down for a conference. Again, one of the other fellows, Dr. Tom in the bottom red, he took myself and Dr. Taylor out to kind of go and learn how to shoot a gun. Never shot a gun before. So these are some of the things that I kind of picked up during my time there in Calgary. Again, we would have regular team dinners. And these are some of my colleagues that I met. At the bottom left is Dr. Wally Temple, one of the world-renowned surgical oncologists. He wasn't practicing as much when I got there because he was in retirement mode and he was writing books, but he's still great to be around and fun to learn from. We did also go to conferences where I presented at the AHPBA in Miami, Florida. These are some of the other fellows. We're just out having a good time after the presentations. Went to San Diego for another conference for surgical oncology, again, where I presented. I met some prominent figures there in Hollywood, President Barack Obama and Clint Eastwood. Actually, they're wax figures. And then we learned a bit about dinosaurs down there in Drumheller. So again, it was a good time. And I think that having the right people at the right time kind of set this up for me. And again, like I say, there was a bit of luck involved because I did try on multiple occasions to get through. Also, touching a bit on what Professor Allen said, I did have an opportunity to interview incoming fellows. On my 2 years that I was there, every year they had interviews. And what I would see is that, like he said, they would have 50 to 100 publications where there'd be maybe 20 first authors, 30 assistant authors. And here in the Caribbean, it's not something that, at least here in the Bahamas, is not something that we can truly compete with when they're putting out papers every week. So I think from a surgical standpoint or from a resident standpoint here in the Bahamas, you definitely want to have some form of paper printed in a journal, as well as presentations elsewhere at international conferences, and you can have that on your paper. But a lot of it is who you are as a person. And when you go down there and you have somebody put in a good word for you and you're hardworking and you're actually assisting with the program, assisting with the residents, and they see this, these all kind of go towards a good standing with the program coordinators. And even at my time there, my short 2 years, I was able to get 2 other fellows from the Caribbean in the door, and they were able to do fellowships, one in transplant surgery and another one in HPB. So it's trying to get in the door, doing work, and opening the avenue for those individuals that come behind you. Thank you. If any questions, you can always feel free to email me.
Thank you very much, Don, and I'm very proud of you. And I think that you mentioned something that is very important for persons who do go off to train elsewhere, and that is you are going to be the ambassador for the next set of students or next set of physicians who will come from the region to go and do a fellowship training or residency training in the place you work at. So thank you very much. I just want to pause for a second and see if there are any questions before we move on to the next region, which will be the UK. So do we have any questions for Professor Allen or for Dr. Roger? I actually have one question for Professor Allen, and I just wanted you to mention about the possibility for board certification in Canada after completion of residency or fellowship.
Thanks, Corinne. It is possible to have that. The key, though, is to ensure that you start to prepare early and that you identify the pathway that leads to certification, because not all pathways lead to certification, Corinne. And so years ago, it was a lot easier. Then it became difficult, and it's becoming easier again. So it can't be too specific, except that it is possible, but one needs to ensure that you are on the right track, and that you don't end up, unless this is what you want to do, you don't end up getting a certification that is at the university level as opposed to at the Royal College level.
I see where they actually allow fellows to now take the specialty board examination, and I presume you'll get a certificate to acknowledge you're passing it, but I don't think that it allows you board certification in Canada without having done the specialty training at the residency level. Is that correct?
Again, it depends on the pathway and the discipline. So I would say that it'd be too difficult to be very specific, except that as there are some that will allow you to be certified at the Royal College level, and we use that as opposed to the term board. But you may also get a certification that is more at the university level, that essentially says that you have done everything, and that is equivalent to what the Royal College Royal College certified person had, including your exams.
Okay, thank you, Prof. And I see a comment or a question from Galaxy in the chat, and she says that she wasn't quite clear about the immigration status needed to work to do postgrad in Canada, not a fellowship. I know it's different in various provinces, but are there any specifications?
Yeah, it is variable across the various provinces, but the key thing is that an educational license will allow you to get a work permit for purposes of training. Now, that is totally separate from the immigration status that would be required for permanent residency. And so if you became a permanent resident, more options, more pathways are open for you. If you're on an educational license, it's pretty limited, and it is a work permit that is tied to your educational license.
Okay, thank you very much, Prof. And Don, I just have one question for you. Okay. I recognize there was quite a bit of culture shock with regards to the temperature and some of the sports. I just wondered if you could mention the difference in the environment for learning in Canada compared to training in the Bahamas.
With respect to the environment for learning, I mean, I kind of felt it was pretty similar, especially at the fellowship level. At the residency level, they did have Thursdays were their dedicated days for teaching and study time. After 12, they would all leave whatever it is that they're doing and go to their dedicated teaching sessions. But for the fellow, it's more or less you just working, operating, going to clinics, and then the majority of it was more self-directed learning in your free time. So I kind of found that that was pretty much similar to my experience in the Bahamas, where we'd be working, not necessarily dedicated free time for study, but once work is finished, then you find your time to kind of reread what you did for the day and prepare for the next day. But if I could comment on that Royal College, because I actually had inquired about that when I was there, coming from the Bahamas and being a fellow. There was actually a fellow that was there probably about 3 or 4 years before I was. He completed his fellow in HPB, and he wanted to stay on board in Canada. He was from Brazil, but what they required of him was that he had to actually redo the final 3 years of his general surgery training there at the hospital. And once he was finished with that, then they would see if he was able to kind of go ahead and sit the Royal College exam. And if he had passed that, then he would be able to practice there in Canada.
Right.
So we kind of
Thanks.
make you do some stuff over in order for you
Yeah.
to do that Royal College exam.
Thank you very much,
Well,
Dr. Butler. We're going to move on to a different area of the world, and that is the UK. And our first speaker is Dr. Jean McDonald. Now, Dr. McDonald, clearly you are very close to Dr. Robin Roberts and Dr. Upton Allen, and I see where you were in the Bahamas for some 9 years before headed to the UK, and I think that is really fantastic. And I'm sorry that I didn't have the opportunity to have crossed paths with you. I know you are practicing neurologist and very involved in training young doctors, and you are at North Middlesex University Hospital. So without further ado, maybe you could just mention for us about the postgrad medical training in the UK.
Right, can you hear me?
I can.
Okay, good. Well, thank you ever so much for asking me to actually be a part of this absolutely brilliant symposium. It's so important to let the graduates know exactly what they have to do and what opportunities are available for them. So I'm going to talk a bit about postgraduate medical training in the United Kingdom. I can't move the screen. Can you see? Yes, okay, fine. Just to tell you a little bit about me. Oh, I'm having some problems with this now. I've missed out the first slide. I can't get back to that. Just bear with me 1 minute. Oh, it's going the other way. Hang on. What's happening now? Some gremlins in. I suppose it's because we are all in mourning, as you know. Sorry, let me just see what I can do about this. Okay. Right. Let me just see. Right. I think I'm on track now. Now, I graduated in 1973, probably a long time before any of these graduates' parents were born. And I did an internship in Kingston, 6 months, and then I came to Nassau. And then I had various positions in the Princess Margaret Hospital, and I actually worked there for 8 years. You may ask, why did I stay in the Bahamas for 8 years without doing any postgraduate training? And the reason was I didn't know about it. I didn't know what to do at all. And then it just happened that I was working in surgery, and one of the consultants said to me, "Oh, Jean, if you want to do surgery, I'll tell you about what you can do and where you can go." And that's how I came to the United Kingdom. So I did the FRCS Part 1. And then I stayed up in Edinburgh because I went to Edinburgh and I got my fellowship in 1982. And then I did various jobs at the SHO and registrar level, and then got a diploma in urology. That's all they had at that time. I don't know why this is giving this trouble now. Oh, I don't know. I'm having such problems with this now. And then I was appointed a consultant urological surgeon in 1995 at the North Middlesex University Hospital, and I'm still working there. At that time, I was the first Black female consultant urologist in the UK, and it was 20 years before we had the second Black female urologist, and that was one of my trainees. I work in a 5-consultant unit serving a population of almost 500,000. And for many years, I was the clinical tutor for the Royal College of Surgeons of England. And I've had lots of different posts. One that is quite near to my heart is the trustee for St. Luke's Trust, which is looking after members of the Anglican clergy. Now, why work in the UK? The NHS is a well-developed system that provides high-quality care, which is accessible to everyone. There's cultural diversity, good working conditions, a supportive environment, and there are many training opportunities. We work as a team, and it's usually a multidisciplinary team, and the pay is reasonably good. And of course, we have our weather that you all know about. Now, working as a doctor in the UK, there are certain requirements. You have to get a Tier 2 visa, and that applies to all trained health and social care professionals. And then you have to pass certain exams. There is the Professional and Linguistic Assessment Board exam called the PLAB, and that is in 2 parts. There are various places in the world where you can do the first part, Nigeria, India, but I haven't seen anywhere in the West Indies where you can actually do it. The second part, you usually have to do it in Manchester. And as I mentioned there, it can be quite costly. After that, you have to have GMC registration with a license to practice. And that is possible without PLAB if you actually have sponsorship from one of the Royal Colleges. I note that the GMC recognizes only one UWI post-graduation qualification, which is the Doctor of Medicine in Anesthesia and Intensive Care. GMC registration, you have to be on the medical register. And this is an online list of doctors in the UK, and it shows the type of registration that a doctor holds. And the register is there to give confidence that any doctor practicing medicine in the UK has the training and skills needed to meet the standards that patients expect. There is recently what has been happening is that all the medical qualifications have to be verified by this ECFMG, which is for all medical graduates, and they check your qualifications. So it's been outsourced to that body. There is provisional registration and full registration, specialist registration, and GP registration. Now, the good medical practice, that's the whole thing about the GMC, the duties of a doctor. And there are these different modes: knowledge, skills and performance, safety and quality, communication, partnership and teamwork, and maintaining trust. Now, where do you find jobs? There are various websites where jobs are available, and I've put down a list of all the various places here on the websites, and I hope that I'm sure Dr. Roberts will be able to give you all these websites, so you'll be able to have them afterwards, and you can always have the presentation. There are shortages in emergency medicine, radiology, age-old psychiatry, and pediatrics. So really, those are some of the areas that if one wanted to have a career in the United Kingdom, that you could go into. Normally for our graduates here, there's a 2-year foundation program where, equivalent to what you have the internship, it's called the foundation year 1 and 2, and it consists of hospital and community-based training placements. And it's structured and supported with a training portfolio and regular work based assessments. It's equivalent to your internship, and it prepares you for specialty training. You get full GMC registration after the first year. And then you apply for jobs. UK graduates are given priority, but overseas graduates can apply for vacant posts. And there are standalone F2 posts available, which require full GMC registration. And you get a foundation program certificate of completion, which entitles you to specialty training. Now, what is specialty training? It's a priority for applicants who've completed the foundation programs. Others are required to submit a certificate of readiness to enter the specialty training, and that's signed by a consultant who has supervised them for at least 3 months within the preceding 3.5 years. And it outlines the competencies, which would be equivalent for what you would achieve at the end of a F2 year. You have some programs which are run through, which require initial 2 to 3 years of core training before subspecialty training. And the run-through specialties are pediatrics, obstetrics and gynecology, ophthalmology, radiology, cardiothoracic surgery, and neurosurgery. And all of them include an annual review of competence progression. Now, just to look a bit at the competition. Now, looking at how many posts were available and how many were actually filled. Now, you can see, if you can look at this whole table, and you see that in specialties, you have all the different specialties, because I thought I'd give you a good overview of what you can apply to and where there is sort of more chance for one getting into that particular specialty. Now, for the training pathways, you have training pathways in acute internal medicine. And for that, you have this 2-year core medical training, and then you have specialty training. Core training in urology, you have 2 core years as well, core surgical training, and then 5 years of specialty training. In obstetrics and gynecology, again, 2 years of core training and another 7 years in total of training. And then there is clinical radiology, year 1, core radiology training, and then up to year 5 in specialty training. GP training has a run-through of 3 years, and you're covering numerous essential specialty placements. And they're heavily focused on non-clinical skills as well, like caring for the whole person in the wider community, working well with organizations, knowing yourself and relating to others. And this they do much more than the other specialties do. There are non-training posts, which are more flexible without the pressures to adhere to training programs. And you haven't got to relocate, so going from one hospital to another. And it allows you to gain experience in the given specialty at your own pace. And you can develop competencies required to join the specialist register. And there are different ways that one can do that. So there are different grades: trust doctor, clinical fellow, staff grade, specialty doctor, associate specialist. Now there are also locum posts. This is when one is coming and getting experience, but they're flexible, they're well paid, but you have to travel around the country because everyone has to have study leave and annual leave every year. So they always need a locum to replace it. There's no job stability. You're working in an unfamiliar environment. There's no real career progression, limited training and supervision. Now, the Royal College has various membership exams. You have to apply. They apply to most specialties. They can be quite demanding and you may have to do them more than one. There's more than one attempt. They're costly and a membership fee is usually required. And they allow you to progress then to more senior jobs. Now, what we have over here is an appraisal and revalidation. So every year we have to have an appraisal to show what you've done in the last year, and you have to have goals for the next year. And it's compulsory for every practicing doctor. The annual appraisal is usually incorporated into the training program, but non-trainees also have to make sure that they have regular appraisal. And these help doctors to monitor their performance, evidence that you're up to date and fit to continue to practice, and they enable reflection on the supporting information they have collected. And then we have revalidation every 5 years. What happens is we haven't got an age that one has to actually stop working here, but you have to be revalidated every 5 years to make sure that you're actually keeping up to date. What's happening after Brexit? This mainly affects EU candidates who used to have their primary medical qualification automatically recognized. And now the evidence required by the medical register depends on qualification, not nationality. Therefore, candidates from outside the EU now have equal rights. So in summary, moving to the UK provides plenty of opportunities for overseas doctors. You'll receive a warm welcome depending on where you are. Non-EU graduates are no longer disadvantaged, and careful consideration of a career plan and timing your move is something that can happen. But it is expensive when you're coming because the exams tend to cost quite a lot. So there's some useful websites that you'll be able to go to, and they have a lot of information about what's happening. The GMC has loads of information talking about overseas graduates actually coming to the United Kingdom. You have the foundation programs, Health Education London, the BMA, and the individual Royal College websites. So there are lots of things that one can do in London, lots of iconic places. And when the sun is out, it's quite good. And it's not as bad as one might actually think. So thank you very much. And I do apologize for the problems that I've been having with the slides.
Thank you, Dr. McDonald. And we'll go on to our next speaker and then just take a question or two on the UK afterwards. Our next speaker is Ms. Colette Thompson-Real, and she also is a UWI graduate and has had the opportunity to practice in several of the Caribbean islands in Jamaica, St. Vincent, and was even here in the Bahamas. I'm sorry, I do not recognize her name. You know, I feel like I've been an old icon here myself. So I'm sorry, Colette, that I do not recognize the name. I see here that you're practicing in the UK now, having moved there in 2014. And you are going to talk to us about your personal journey. And I'm so sorry that you are not able to continue your love of traveling, you know, where you have visited over 40 countries. And I'm not sure that it's going to be as easy now that COVID is here. But Colette, can you take over, please?
Okay. Shall I share my screen?
You can.
All right. All right, can you see and can you hear me?
We can on both.
Okay. All right, excellent. So good afternoon, everyone. It's afternoon where I am anyway. So good morning to you there in the Bahamas. I'd like to thank Dr. Roberts and the organizers for inviting me to speak today on my personal surgical journey in the UK. I'm Colette Thompson-Real, and I work at the Norfolk and Norwich University Hospital NHS Foundation Trust. It's an acute tertiary care teaching hospital located in Norfolk in East Anglia. And with a staff of over 9,000, over 1,200 beds, and serving a population of over 1 million. It's one of the larger hospitals in the United Kingdom. I graduated from UWI Mona, and then I did my internship at UWI. I then went home to serve as a surgical senior house officer back in St. Vincent for about 2 years before returning to Jamaica to do postgraduate studies in general surgery. And I was not successful in the exit examination, but when one door opens, when one door closes, another opens. So on the 3rd, whilst working as a surgery registrar at Spanish Town Hospital, I successfully completed my MRCS Part 1 examinations. And I did that in England. You can do it in any of the UK countries, whether that be Scotland, Ireland, or Wales. And I particularly just chose England just for the sake of choosing. It costs about £550 these days to do it. And I prepared by reading MRCS books and doing online revision MCQ websites. The websites that I used particularly was the EMRS website, Pass Test, and On Examination. But there are many, many others that you can find online. And the good thing is that they all give you sample questions that you can use to determine which one will suit you best. Now, I traveled to the UK to sit these exams, but they can be sat in other regions, particularly Asia and the Middle East. I then went to the Bahamas to continue working, where I was a surgical registrar for about 3 years at Princess Margaret Hospital. At that time, I completed my MRCS Part 2, and nowadays days it costs about £1,000 to do that. I prepared for that exam by doing MRCS online revision websites similar to the ones I did for Part 1. I looked at lots of YouTube videos, and I also taught medical students. I found teaching medical students consolidated and reinforced what I'd studied. Now, although the MRCS exam content and principles are no different from UWI's, the format of the presentation varies. So I found that taking the preparation UK OSCE course about a month or so prior to the exam was quite beneficial to me. It provided mock exam practice, and I was actually given guidance on how to properly prepare for the exam and told exactly what the criteria was that the examiners were looking for. There are various UK OSCE courses available, and they range from £600 to £1,500. The course I went on was for about £1,000. Again, I traveled to the UK to sit that exam, and I tried to have the exam scheduled about a month prior to my actual exam. I had the course scheduled about 1 month prior to the exam. So it gave me some time so that I can adjust whatever preparations I needed so that I can do the exam. And it was beneficial. Now, here in the UK, I've worked at 2 hospitals, including my current hospital, where I started out as a clinical fellow in colorectal surgery before moving on to my current post in emergency general surgery as a specialty doctor. Now, how did I get onto the UK? I entered the UK on a spouse visa that allowed employment in the UK. Now, this was in the pre-Brexit period where hospitals had to ensure that there was first no eligible UK applicants, then no eligible EU applicants before offering a job to any other nationality. So you can see how important it was that my visa equated my status in the UK to that of a UK citizen. However, now that it's post-Brexit, after UK applicants, it's a level playing field for EU and other nationals once you have your Tier 2 skilled workers visa. Once I got to the UK, I had to secure certain documents. The most important was a current GMC full registration for license to practice. I did this by completing an online application and submitted several documents, including my IELTS certificate. And once you do internship at UWI at that time, there were these papers of completion of rotation that had to be signed and stamped. I really highly recommend that you keep those, because those show proof of rotations during internship, which was required for my application. I also submitted my medical school degree, a certificate of good standing from the Jamaica Medical Council. I used my current passport for proof of identification. And I was also required to provide proof of work from time of completion of internship to the time of application. And I used my job contracts for that. Now, once I had my documents, I went job hunting, and the website that I used was the Jobs NHS website. But as Ms. McDonald alluded to, there are several others that you could choose. And you can tailor your search via the surgical disciplines that you want, or if there is a specialty-based hospital that you're particularly interested in. And I've listed a few here, just for general interest. Once you've decided where you want to work and which area you want to work in, you can then choose what particular post that you qualify for or you would like to have. And you can go along the line of formal training, or for me particularly, I went along the line of non-training. And I've highlighted those posts that I've had since I've been here in the UK. Now, this slide is just to allude to what the salary, the basic salary is like here. And I'd like to just highlight that those posts with an asterisk will come with additional pay for extra work, such as when you do on-call or locum shifts. Currently, my post is one of autonomy, where I essentially work like a senior registrar. I conduct ward rounds with the surgery team. I do clinics independently, and I run theater lists to which trainees are attached, and I train. My duties also include a weekly single 12-hour emergency shift, which I love. This is as compared to my previous post held here in the UK, where which are similar to that of a UWI registrar. And during those posts, I just mainly supported the consultant. Professional integration, I think, although not compulsory, is definitely beneficial professionally, developmental wise, and it's a great bonus for your CV. So I'm a instructor for the ATLS as well as the BSS programs for the Royal College of Surgeons. I'm the PEC lead at my hospital, and I am also involved in research at the hospital. I participate in the training and teaching of the trainees, and I'm a member of surgical societies here in the UK. Generally speaking, there are so many things, so many benefits here in the UK. Some of these general benefits include that you actually get time off in lieu for working weekends and holidays, something I particularly like compared to my days when I remember working in the West Indies. You do get dedicated study time off, and you have access to budgets to substitute your training. If you go on courses, if you want to do research, you can get permanent contracts. I am on one, and the salary is not bad. Personally, I've had training in laparoscopy, endoscopy, Halo RAR training. That's one of the newest ways of doing hemorrhoidectomies. And I've also gotten support to apply for my FRCS exams. Now, that's particularly important because you require at least 3 senior surgery consultants, one of whom must be the head of your department, to vouch that you have the ability to be eligible for a consultant post. And I was very pleased and blessed that I had consultants who I worked with who were happy with my work and actually have signed my reference letters in this regard. And I'm also currently getting support for my CSER completion application, which I'll allude to in a little bit. Now, what training routes are there? There's the formal training route that my colleague, Ms. McDonald, alluded to, or you can have the non-training route. Now, the formal training route follows a structured program similar to UWE's DM program, where evidence is systematically collected and filed. You have to successfully complete the FRCS exit exam, after which you will then get a certificate of completion of training, which will allow you to be added to the UK Specialist Register and make you eligible for a consultant post. For the non-training route, which I'm actually on, you have to have similar evidence, but as that of a trainee, but you have to now collate it yourself. Now, in order for you to go through the non-training route, you have to have at least 6 months of being in a UK formal training post, or a MRCS, or some equivalent international qualification. And you need to submit at least 1,000 pages of evidence to show you have equivalent experience as that of a trainee. That sounds a little bit daunting just hearing that, but you're not asked to do anything other than what a trainee is doing, except that because they're in a systematic program, they're producing this in a particular way. So you will have to be really organized so that you can get that information, and it is possible to do that. Success at the FRCS exam is optional using the non-training route. And once you have all of your evidence and submit it, and it is accepted, you will then have a certificate of eligibility for the specialist registration called the CSER. You will then be added to the UK register and eligible for a consultant post, just like any other trainee in the formal training program. So my advice is that the UK is definitely an option for training and professional development. And I'll recommend, if you can, to take the MRCS exam prior, because it will open so many doors. I mean, you won't have to do the PLAB exam, so that's one less exam and expense that you will have to undergo. You'll qualify for GMC full registration. You will be able to start working at a registrar's post with all of its benefits, including a better pay scale. And you would have a more directed training and professional development route. I will say you have to be disciplined, and it is best to have a plan with a reasonable, realistic deadline, as that would give you the most directed and shortest journey with the highest degree of success. You will have to be organized, as I've alluded to earlier. You need to stay focused, and I would highly advise that you keep records, preferably digital, because they will go a far ways towards any of your, if you want to go to your CSER or any of your applications to come here. Records could include from your logbooks to any achievements or any of your experiences. So in my opinion, learn all you can now. Every bit of experience counts. Keep your eye on the prize. Never give up. You will have to save up because you will need a startup fund for applications, courses, exams, for travel and accommodation. And remember, as you can hear from many of the people who've already spoken here already, when one door closes, another opens. So be prepared to bolt through at the next opportunity. Good luck, everyone. And thank you.
Thank you very much. And I see in the chat, persons who would have encountered you while you were in the Bahamas have sent you all congratulatory messages. And so I allow you to read them at your, moment. And thank you again.
Thank you very much for having me.
Okay. Are there any questions from the group with regards to the UK training? I just have one for Dr. McDonald, and that is ultimately, how long is the journey from starting your training, let's say for surgery, to becoming a consultant in the UK?
Right. It varies depending on where you actually come in. You're talking about someone who is actually coming in from after just having finished medical school, you mean?
Yes.
Because if they've just finished medical school, what happens here is that you would have your 2 years of foundation training. Then you would apply for core training in whichever specialty you wish to go into. So you'd have 2 years foundation, 2 years core training, and then you will have about another 6 years, and then you may have even another year of subspecialization.
So it's a long journey, and it's a long journey no matter where you are, but definitely not an easy journey. And for Ms. Thompson-Reel, just wondered if you could just mention with regards to the qualifications of MRCS and FRCS, and whether or not these are qualifications that allow you to apply for a consultancy post. I think from both your presentation and Dr. McDonald, I think the important thing is the CSER that you need in order to be able to get a consultant post after training. And I just wanted you to clarify that, because I know that persons in the Caribbean have considered MRCS and FRCS to be exit examination qualifications. Just want you to clarify that, please.
Okay, so your MRCS, or membership of the Royal College of Surgeons, that's what you need to start specialist training. And the FRCS is actually the qualification having completed successfully specialist training in a training program. Now, if you want to have CSER, you don't have to have that exit exam. You just have to show enough evidence that you meet the you have what it takes to become a consultant in whatever specialty you're in. So you do not actually have to have CSER. Well, you can actually have CSER, which means you do not necessarily need to have your FRCS exam, but just have enough evidence to show that you do have the criteria, experience, and knowledge to be a consultant. Alternatively, if you just have your FRCS exam, so if you're able to do your FRCS exam, you can become what is called a locum consultant here, which means that you will be on a temporary contract with a hospital. But once you then additionally have your CSER, you can then get an appointed post, which is a permanent contract. I hope that answered the question.
It does. Thank you very much. And thank you very much for both for the input on the UK journey. Our next speaker is Dr. Williams, and Dr. Mallory Williams is a proud alumnus from Morehouse College, and then he went on and served as a presidential scholar for the NIH MARC scholar. He did further training at Wayne State, and I think that is how some of our own Wayne State graduates may have made connections with him. And he has done quite a bit with NIH, and he's currently at the University of Maryland. And you know, when I have not met Dr. Williams, but I know that our surgical colleagues speak very highly of him. So the next time he comes to the Bahamas, I'll surely make sure that I make my contact with him then. So I'd like to invite Dr. Mallory Williams to speak on the US journey.
Well, thank you so much. It's always a pleasure to come and visit with UWI. I like to do it in person, I really do. But if it's got to be by webinar and Dr. Roberts is the inviter, then I got to do it like that. Now, he was a little bit scared this morning because he didn't see me. I'm in New York and I have to run on the Hudson every morning. And so we were a little bit delayed. If you would allow me to share my screen, that would be so kind of you.
You could go ahead.
Thank you so much. So let me see here where we at. I believe this is the one. Share. And let me see if I can't get this all the way back up.
Yeah, we can see it now.
Nowadays, it takes 30 minutes. Yeah, we got to get it to where you got to get, okay, now let me put it in full mode for you. Can everybody see those slides?
We can see it.
Can everybody see those slides?
We can see.
That's a wonderful thing.
Yes.
And so I want to talk a little bit about, you cannot see?
Yeah, we can see it.
You can, okay.
We
Oh,
can.
very good. That's wonderful. You should see Eddie Murphy and Wesley Snipes if you confused. We want to talk a little bit about postgraduate training for minorities and international medical graduates in America that may be coming from offshore schools. And I'm giving you a little bit of my insights as a person who's been training all residents for well over 2 decades. My disclosure is this: I'm a very biased supporter of international medical graduates. As a professor of surgery at Howard University College of Medicine, I train many UWI students, I train many international medical graduates. And so the quality issue is not a focus of mine. I'm here really to kind of show you what the challenges are in this system and try to kind of give you some insights on how to navigate those challenges. In that picture, you will see 2 international medical graduates, and they are operating on a rather large cystadenoma of the abdomen. The reason you do not see me in that photo is because I'm off to the side taking it because I have confidence in my residents to be able to operate without me being at the table. So the one to your right screen is Adil Shameen from the Haqqan University in Pakistan. And the one to the left is the female surgical resident, Kibblary Williams, of course, from UWI Trinidad, and a Guyanian. And so doing a quite splendid, excellent job as they always do for us. And, you know, I would hope that you can recognize at least a few people in this photo, but it would be remiss of me if I didn't tell you that our president, Wayne A.I. Frederick, of Howard University is from Port of Spain, Trinidad. And so there is a heavy leaning toward the Caribbean and UWI in itself. And the other person in the photo, well, she's just a senator. At least she was a senator then. She's now Vice President of the United States, Howard University graduate, of course, Kamala Harris. When you look at Howard University surgery residents, and you look at the UWI connection, it is a profound connection, but I don't want to just emphasize the connection. I'm here to talk to you about pursuing and attaining excellence. And so in that third column, when you see fellowships that our graduates who've come from UWI have gone on to obtain, you will see them placing and matching into some of the most competitive fellowships that we have in this country. So there is no doubt that you will do quite well here. The question is, how do you begin your journey and how do you develop those first steps? And that's what this presentation is going to be about. Here are more UE students, and I probably could even put more in there if I was to stretch it out a little bit. And when you look at our incoming interns, I think it says a lot. You see Frementia, of course, there as an incoming preliminary intern. You see Jed Harris from the University of Guyana, incoming PGY1, and you see Addis Adaba, of course, and you see Ross University, you see Edward Villacombe. You see people from everywhere, not just allopathic medical schools, based on the quality of the candidate. Now, what I will say is quite interesting. You say, where did this slide come from? Well, I'm a trauma surgeon. And one of the things that the United States and the Caribbean share is trauma. But none of your graduates want to go into trauma surgery when they get through. They want to do pediatrics and plastics and all of this glamorous stuff. You know, D'Angelo wants to be a plastic surgeon. I keep telling him, that's great, but you know, you could actually put some meaningful time into your life if you did trauma, but they're not into that. So they are really chasing that American dream, something kind of special. What does the 2021 National Residency Matching Program show us? Well, it was 7,500 international medical graduates, and 3,152 of them were US citizens. And I really think you have to look at those IMGs a little differently because they have citizenship. I don't like to mix the numbers because I think that gives you an unfair representation of what's really going on. If you really look at our foreign nationals, it was 4,356. There was an increase in about 134 IMGs being matched despite us suspending the clinical skills examination. Now you got to understand the clinical skills examination was our screening mechanism for communication, for the ability to do clinical work, which all UE grads genuinely excel at, but we suspended that because of COVID, and we will be getting rid of that exam going forward. I think that's a lost opportunity and that may hurt. If you look at the overall IMG match rate, it was 57%. But again, when you look at the US born versus the foreign national, really the number that would prefer most to the people on this webinar is 54.8% or 55%. I want to point out fellowship match highlights because I think this is something that goes overlooked and we're not understanding it good enough. We have 11,767 positions that were offered, and when you really look at them, 10,400 or so were filled. That's an 88% match rate. You say, well, why is this important if I'm just trying to get started? It's important because the most often start for international medical graduates will be the preliminary year. And you'll do a PGY1, you'll do a PGY2. Sometimes you'll get to flip around and do another PGY2. And you'll have these 3 postgraduate years and you won't be matched into a categorical position yet. Oftentimes with that amount of wealth of experience, you can do a critical care surgical fellowship or a hand fellowship or something like that if your visa will, if your J1 will allow that. And so it's important for you to understand that there are certain surgery fellowships in America where you do not have to have completed all of the PGY categorical years. You just have to do 2 or 3. And so you want to be able to leverage that. Now, I'm going to say to you, if you don't have your cameras, get them out, put photos on, because there's some websites at the end of these slides that you should just take a picture of, and there's going to be some tables, some data that you want to take pictures of as well. I'll give this whole slide set to Dean Roberts, so he will have it available for him. So what do you need to be a U.S. training requirement? You guys know this. You need your step 1, 2, and 3. So we're going to get rid of clinical skills. That one, you need your ECFMG, a J1 visa. The H1 is not so much offered these days. You can get it, but it's difficult. J1 is really what we're talking about. And you gotta focus on those awesome letter of recommendations. And I could talk a whole talk on what a good letter of recommendation is and how I read a letter of recommendation. Credible training you have, and that is most authenticated by your former graduates. And then the clinical observerships, which allow other people here to see that, yes, you are very well trained, which you are, which is why I put plus minus. If you're coming from you, I don't need you to do a clinical observership. I know you know skin from fat and fat from fascia. Now, what your core strategy is, and this gentleman right here is Dr. Wesley Francis. When you see Dr. Francis, please remind him that he is my junior resident. And when you do so, you will attract from him a very memorable look, and just know that just tell him Dr. Williams told me to say that. You need outstanding credentials and clinical skills, which you're coming with. But the professional relationships are really what you're navigating once you start talking about training in the US. You got the adaptability, and obviously you're very determined. You got more determination than my kids over here. But it's really those professional relationships. You know, how do you know where to go and who to talk to? And that's what we'll deal with a little bit in this conversation. Just to orient you, the Northeast is the IMG corridor. This is where most international medical graduates will gain opportunities in this country. And those of the states, New York being the king of all states for those opportunities. But there are other states, and we're going to talk about some of the other ones that have opportunities for you and where those opportunities are. This is going to be a surgery heavy talk because I'm a surgeon, but I will touch on the other specialties as well. When we look at the US general surgery match data for general surgery, if you're talking about coming to the United States as an IMG, you're really talking about an 11% categorical match rate. And that's not UE, that's not the Caribbean. It's probably going to be lower than that. That's all comers. And so you've got major competitors in there like Ross University, Aga Khan, American University Caribbean. I could go on, but that's still a low rate when you start talking about matching directly into categorical positions. What you really are talking about, where the odds become even, is when you match into the preliminary spot. And really what this is a trial opportunity for you to show your wares, for you to actually show the strength of your clinical training from UE, which you all have, and you all do show it. And actually, a lot of you do go on to gain categorical positions from the preliminary positions that you initially occupy in surgery. And if you don't gain positions in surgery, you gain positions in emergency medicine, internal medicine, obstetrics and gynecology, radiology, interventional, it goes on and on. So let's talk about some of the programs, and so I can point you into some directions if you're on this webinar and you're interested in surgery. Well, Fred Kaysen, my good friend, is now the program director at San Joaquin General Surgery Residency in California. It's affiliated with the University of California, Davis. He's an extremely strong clinical surgeon and surgical oncologist. He was the former program director at the University of Toledo Medical Center, where your graduates have certainly been. I think you're going to hear from Dr. Higgins, who's now a vascular surgeon, who was my resident when I was at the University of Toledo Medical Center. He's also the former program director at Morehouse School of Medicine. But I point him out because here's someone who's really focused intensely on the clinical skill set. Okay, he's someone who's going to appreciate that great training that you get in UE and really look to bring you in and be a part of his program. This is a person that you've got to know. If you don't know, this is a person who you've got to link up with and make relationships with, and I'm happy to facilitate that, because when you look at wherever he's gone, he's trained very strong clinical residents, and certainly UE has that. I don't have to give you an introduction on who Shanita Johnson is. Now, they say she has roots in the Bahamas. When I looked at this program and didn't see her name on it, I began to doubt that. But nevertheless, she is the program director now at the general surgery program in Morehouse School of Medicine. She's affiliated with one of the busiest urban hospitals in this country, Grady Memorial Hospital. She's robotically and minimally invasive trained bariatric surgeon, outstanding in what she has done, has built a robotic program at Morehouse in conjunction with Grady. And if you look at her program, she has a resident from UE Jamaica. And so again, it's not just talking the talk, it's actually bringing residents in, and like those charts that I showed you in the beginning, and demonstrating that you're willing to train well-qualified residents. And so I don't have to talk about Shanita. You all know her and probably have good relationships with her. This is one of my mentees, Mohammed F. Osman. He is a graduate of Khartoum University, which is one of your competitors on the international medical scene. And so in Sudan, Khartoum is an absolutely excellent training program. He came to me when I was at Toledo, and he's the associate program director at Toledo now. Excellent endovascular surgeon, trained at Cleveland Clinic. Very strong interest in public health, completing his MPH now, also has completed his MBA degree. This is the program that graduated Amal Higgins. This is the program that graduated Candace Shaw. These are Bahamians that I'm talking about. And so while Candace is an American grad at Meharry, you know, we have strong connections with the product that you produce. And so Mohammed is a great friend of mine, a mentee, and is someone who we need to probably reach out with and develop some relationships, because you will find a hospitable training environment there that I think will allow you to thrive. Not that you don't thrive in all environments, but it's a lot easier to do it without 100 pounds of bricks on your back, if you know what I mean. Now, this is an interesting story. Here we have Darwin Ang, who is the chair and program director at Ocala Health right there in Orlando. Now, they tell me UE residents, they don't like to get too far away from that sunshine. So the farther you go up north, you know, it gets a little cold. But here we have somebody right down in Florida and his associate program director, Jason Clark. And I don't know what the connection is, but when you look inside of their program, which is affiliated with the University of Central Florida, you're gonna find several outstanding international medical graduates, and yes, several graduates from UE, particularly UE Jamaica. One was our graduate who left here and went there for a categorical position. And so they have shown with absolutely no trace of ethnicity in their governance of their program that they're still open to training international medical graduates and members of the Caribbean. Now, y'all I have to nuance that often, guys, because just because you're going to train somebody from Ross University or American University of the Caribbean doesn't mean you're taking UE students. So I look to make sure you're taking UE students, and yes, they are. And so they just deserve our attention because they have stepped up to the plate and been willing to look at the excellence that you provide and bring you in as surgical residents. So I told you that the Northeast was the corridor for which international medical graduates most highly enter into allopathic programs. And so let's go through a couple of these programs for more than just general surgery, because there are people who want to do GYN that's on this webinar, psych, peds. This is where you need to get your camera out. Okay, these are the programs that have ranked Caribbean students at the highest rate in New York. So when we talk about general surgery, there's no question there. Harlem Hospital, Brookdale, Jed began there before we grabbed him out of there at Howard, just pleased with him. Bronx Lebanon Hospital has done very well by us in New York. One of the curious things to me is that SUNY Brooklyn has 9 categorical spots and has never really trained Caribbean residents. And I don't know what's going on there, but maybe, you know, I need to look into that. Obstetrics and gynecology for those who are interested. Isn't this interesting? If we were to look at programs rankings for different reasons and ask why is obstetrics and gynecology so partial to Caribbean residents? That's an interesting story. Look, you got Hofstra, you got Flushing Hospital. If you were to ask me who would be the least partial, I would probably say surgery and obstetrics and gynecology, but obstetrics and gynecology across all of the hospitals has been very favorable. And so here are the 3 highest participators in your product. Internal medicine, God knows this is the workhorse for international medical graduates. And, you know, simply because there's more seats here than anywhere else. But for Caribbean residents, it's been wonderful too. I mean, you know, Brookdale University Hospital, certainly Lincoln in the Bronx, 149th and Concourse. I know that place very well for its trauma. SUNY Upstate Medical University, kind of cold, but it's still in the same, doing a good job ranking and accepting you guys in internal medicine. And when we look at family medicine, we see the Bronx, you see the University of Buffalo and St. Elizabeth's Medical Center inside of New York, also ranking Caribbean students, Caribbean trainees very highly in the allopathic programs. And when we look at pediatrics, Lincoln Medical and Mental Health Center, again, SUNY Health Sciences Brooklyn in pediatrics is stepping up and recognizing the excellence that's in the Caribbean, and Bronx Lebanon Hospital. And finally, when you look at psychiatry, which is probably one of the most up and coming specialties in this country for many different reasons, Interfaith Medical Center, Lincoln Medical and Mental Health, and Harlem Hospital Center has recognized your excellence through ranking your residents. Let me just say this and plug. If you look at Alzheimer's disease, if you look at the neurocognitive disorders in this country, and I'm a surgeon saying this, there is no greater shortage of doctors going into the future than in the doctors that are in the neurocognitive disorders. And so that internal medicine, psychology combination that's been floating out there is a hot choice that's not being recognized by a lot of our American graduates here. So let's talk about the undiscovered destination, because I always like to talk about the future, and I'm about to finish up here, Dean Roberts. Many of your non-Caribbean IMGs, okay, your counterparts, your competitors, enter surgical residency and other residencies via their relationships through research. There's no doubt about that, okay? UE graduates primarily are leveraging strong clinical acumen and work ethic with some relationships, okay? If we look at the future and how these corridors and pathways are going to remain open to the University of West Indies, at some point in time, the obvious move on the chessboard is the development of a robust clinical outcomes research enterprise inside of UE. Okay, it makes your graduates unstoppable because it combines their clinical strong work ethic and clinical acumen with now the ability to generate the research product which most programs are looking for. Okay, and that can be done in partnership. You know, Howard University has a robust clinical outcomes center. I mean, I publish 20-something papers a year. There's no reason why we can't get together and talk about how to do that with cancer registries, trauma registries, et cetera, because that really now puts that final chip in the hands of your graduates as they enter into allopathic training opportunities. Okay, so we can now talk about a revised course strategy. I talked about these 4 prongs in the beginning. We can now talk about adding a research skill, particularly in clinical outcomes research. I apologize for misspelling research. I was on the move this morning. This is what my former teacher, Cornell West, is a truth teller. Justice is what love looks like in public. You should not expect, as people of color, to find too much of that in America, but we are still striving to become that nation that can provide that. That is part of your responsibility when you get here. And I spent a lot of time training UE graduates. I have to reverse some of Her Majesty's educational doctrine and give you all a more radical aspect of what you ought to do as physicians in terms of social justice. Nevertheless, I don't want to digress too far from the topic I was asked to speak on. These are 2 years ago, my graduates. I think you're going to find a whole lot of Caribbean in this picture, particularly in the center of the picture. If we go from the left to the right, you got Adil Shameen, who's from Aga Khan. You then move to a great Howard grad who is a member of Rashad Majid, who's a Guyanian. Then in the center is Christine Nimhart. That's UE Jamaica right there smiling at you. Not only has she graduated, not only has she finished her colorectal fellowship, but she's back here on faculty with me at Howard as an assistant professor. So yes, one of your graduates sits as my colleague at Howard University. And right next to her is Navin Shangor, who's also a UE Trinidadian graduate who finished his colorectal fellowship in Orlando. And then the final resident on the end is George Washington, who's a Howard grad, who's now doing a plastic surgery fellowship. By the way, Rashad did a vascular fellowship, and Adil did a minimally invasive fellowship. So these are all fellowship trained surgeons. When you look at what I do for my residents, when they finish up their awesome training, I take them to New York and we have a steak dinner First, we go to the top of the World Trade Center. That was the first picture. That's them in the elevator. And then we go to dinner because they have accomplished a great deal. And these are the same residents that you saw in that elevator now sitting around fine dining with Dr. Williams, about to have sober conversation. I want to thank you for the opportunity to come to speak to UWI. It's always my pleasure. And I also want to thank Dean Roberts for his vision, his leadership for making this happen. It's my pleasure to stay for any questions.
Thank you very much. And you know, that journey was fantastic, telling people about the opportunities in the US for postgrad training. And we do recognize that even though we do a fantastic job at UWI in training undergraduates, we are unable to fill the capacity needed for postgrad training. So it is important for us to be able to look beyond the borders, in addition to which it also helps to have a diversity of experiences to come back. And I think that is what strengthens us here in the Bahamas. I will ask if there are any questions that you can type it in. And I'd like to emphasize one of the points you made, and that it is about relationships. And just to say to all the persons who do enter postgrad training, that once you get through the door, it is important for you to keep that door open with your strong work ethics, with your performance. So I thank you immensely for your talk, Dr. Williams. Are there any questions? You did a fantastic job, Dr. Williams. I do have one question. I know you didn't mention anything about the possibility to have a year or two waived in your training, depending on the experience and exposure with regards to prior training, for example, in the Caribbean. Can you make mention of that, please?
Yeah, you know, that is governed heavily by what we call our RRC, Residency Review Committee. And so when we want to advance residents beyond their categorical years in allopathic training, we have to actually apply to do that. And we have done that for individuals, not because of their previous training in the Caribbean, but because of allopathic years that they have spent training in the US before they ranked into whatever position. For example, it is not uncommon that you will spend 1 to 2 to 3 years in preliminary slots before you match into a spot. Now, you may actually match into a 1 spot and could likely easily be a PGY4, or you may match into a 2 slot and could likely still easily be a PGY4 based upon your experiences today. What we do is we use your postgraduate years that you spent in America and advance you if there are spots available. And we try to do that because we need you out working, doing the Lord's work to change a lot of the disparities and inaccessible care issues that we have all over the globe. We don't need you here at Howard with me. That's just a starting point. And so we tried to do that, and we did that this year with a resident. It will be very unlikely that you will be advanced based upon international medical years. That will be a very unlikely thing. And now, let me say this. I always believe that we have to look to the future. We cannot look to the day only. As we look to the future, it's important to understand that international collaboration is the way that postgraduate education has gone in this country. So many surgery residencies, but all residencies are developing international partnerships. And that time that American grads are spending in those countries is counting for accredited training time. That's good news. Because if that time counts for accredited training time, then that means that is the slither, that is the crack in the door that will then lead to international medical years counting as training time for your graduates. And so I believe that we're heading in the right direction.
Thank you very much. There was just one question in the chat asking about which ER fellowship ER program is IMG friendly. If you could just make a quick mention on that.
Sure. And so, if we look at where there has been Caribbean influence in emergency medicine, the biggest name will be Adrian Tyndall, who was my classmate at the University of Maryland. He is a Guyanese. His dad was the former ambassador for Guyana, and he came up to a place called Brooklyn Hospital Center in Brooklyn. He was the program director there for some years before he moved to the University of Florida. When he moved to the University of Florida, he was such an outstanding individual that he became interim dean. He's still there as head of emergency medicine. And so someone of your region, someone whose daddy was a governance structure in your region, has actually served as a dean now of a United States medical school. Thank you.
Thank you very much, Dr. Williams. I don't see any other questions for you, and thank you very much. We're going to give you honorary Caribbean status, okay?
I really appreciate that. and at about 40% off of Malia or one of them resorts or something like that.
Okay, see you in the Bahamas soon.
All right.
We're going to move on to some experiences from persons who trained in the US as well. So our first speaker is Dr. Medaya Hepburn. And, I must be here long because I've interacted with these persons from medical school days. And Dr. Hepburn had an outstanding medical career here in our school. And she won the overall university prizes during her time with distinction and honors performances. And then she went on to do her residency training at the University of Missouri in neurology, and now has completed her training in neurosciences at Cleveland Clinic, neurosciences and critical care. So I'd like to welcome Dr. Hepburn, and congratulations on your recent marriage.
Well, thank you. Thank you so much, Dr. Sinqui. Thank you for inviting me here along with Dr. Roberts. I have to say that I would not be where I am today if it wasn't for the great letters of recommendation by people like Dr. Sinqui and Dr. Roberts, to get me here in my career and other consultants. So I'll just hit my share my screen here. So this is a picture of a synapse, and this is a picture of the beach that I wish I was on, but I'm here in Cleveland, Ohio currently. So, the reason I chose to go down to the US route was because of the directness of the route. So I always knew that I wanted to do neurology. Well, I kind of knew I wanted to do internal medicine, and then at the end of medical school, I realized all the cases I liked, all the pathophysiology I liked was neurology. And so then I started basically looking around to see, how can I accomplish a neurology residency? Because my initial research kind of in the Caribbean looked at basically doing a whole DM first and then going on to do specialty in neurology. And then I found out that here in the United States, neurology was a standalone specialty where you can basically in 4 years obtain your postgraduate training and become fully specialized and board certified in neurology, so I thought that was like the best way to go for my career goal. The good thing about the United States system is that it's direct, and it's a timeline. It's like a machine. It's a timeline that exists every single year. It really doesn't deviate. You always see, this month in March, you saw all the posts on social media of all, the students matching and, on that match day. But the preparation to get to that match day is pretty much a timeline that doesn't change. And so the key for us to be able to navigate going from a UE timeline and MBBS timeline, going to a US matching timeline is basically doing the research and finding out when to take your exams and the best timing for your studying. So I kind of did a hybrid. So I actually started studying for both USMLE and MBBS around the same time at the end of my third year, going into my fourth year. So I actually completed about half the exams before I finished MBBS. And in retrospect, when I look back at it, I actually wish I had carved out the time in order to study for my USMLEs, which are, your step 1, step 2, and your step 3, so that my timeline could have more easily matched essentially my completion of medical school. But nevertheless, it really is about time management and about knowing your own self and your study timeline, because step 1 is all basic sciences. And it really is more ideal to do that at the same time when you're in medical school doing, essentially basic sciences things. And then step 2 is kind of like, going toward the, more clinical application. And step 3 is basically anyone who's done, a 12-month internship in the Bahamas can pass USMLE step 3 quite easily, because it really is just full-on application and management, which is why most US students, residents, take their step 3 during the first year of residency. So you really have to know what is your timeline and how you're going to best utilize your time, and you have to be disciplined. So sorry. Oh, sorry. So yeah, so I graduated from U in 2012. I did half the exams before I graduated, and then I completed the last half of the exams basically, and during the time that I was an SHO for about 2 years. And I do remember a conversation in the hallway with Dr. Sinque when basically I had one more exam left to do, and Dr. Sinque asked me, "So why haven't you done it yet?" And I said, "Well, I don't know. Let me just go and book it." So I actually went out and booked my step 2 and did it within 1 month, and applied for the match that year. So I matched in March of 2015, and I went to the University of Missouri, which is in Columbia, which is, by the way, a state that I had never been to. But I pretty much got a bunch of interviews, and I saved my money, and I went around, and these were the people that I really enjoyed on my interview. And it became a city that was, although very flat, has become very endearing to me. And these are my co-residents. This is not last year, on basically the day before graduation. And so once you decide that you want to do neurology, neurology is 1 year of internal medicine, and then after that, 3 years of just pure neurology. And then after that, you can decide what subspecialty you want to do. And it's really interesting because you can become a neurologist that reads EEGs or do neuromuscular tests and have a pure outpatient practice, 9 to 5 hours, and essentially no call and no inpatient hospital work. You could be that neurologist. My friend here, Tracy, that's the kind of neurologist he is, and he's awesome. But you can also decide that you want to do only inpatient, take care of all the sick patients, and basically take care of like large neurological emergencies, which is essentially what I trained to do. So I'm currently at the Cleveland Clinic finishing up my neurocritical care fellowship, which is 2 years. And this is what the Cleveland Clinic looks like on paper. This is what it looks like in the winter. So that's kind of where I'm living right now. And then, so I do 2 years, I'm doing basically a neurocritical care fellowship. And the way I describe neurocritical care is an integration of the brain and the body. And it's a really neat hybrid specialty because it takes the internal medicine of neurology and combines it with a lot of procedural things from neurosurgery without actually having to stand up in a 10-hour surgery. So I really enjoy it. So this is one of my co-fellows, this is one of my attendings, and this is an RT we work with closely. This is actually, a picture from our unit as we're basically taking care of a patient who has both stroke and COVID and ARDS, and getting ready to prone him. And then, as a result of, going down the road of neurocritical care, I found out, the kind of the wide applications of how we can treat neurological emergencies. So I learned to do invasive monitoring and non-invasive monitoring. These are invasive monitors that we place within the brain for monitoring things like intracranial pressure and cerebral oxygenation, microdialysis. And then we also doing, using non-invasive methods like, transcranial Doppler and, electroencephalography in order to basically, treat our patients and, and improve clinical outcomes. So, when I first came, I was amazed because I would take patients with these large intracranial hemorrhages, and then because of the, working with a multidisciplinary team, we take them from that moment of, resuscitating them, in the emergency room, resuscitating them in the ICU, working closely with our neurosurgeons, taking them for early evacuation, and then basically monitoring them in terms of their perfusion pressures, intracranial pressure, and in order to basically optimize their care. And we save people like these, which I never thought was possible. And these patients we're saving, I mean, they're going on with with decent quality of life, which is a really big change in our field, compared to 10 to 15 years ago. These are, and I would have never thought about a specialty like neurocritical care without that first step of going into a neurology residency and becoming exposed to the many different specialties, the many different ways of practicing neurology. I guess my whole point is that the US pathway is a pretty direct pathway, and there's lots of different ways to skin a cat. If you think about what you want to do, these medical students in the United States, in their medical school, I mean, they're like in second year and they already know what specialty they want to do, which has its pluses and its negatives. But if you really kind of think about what you want to do, if you want to do surgery, you want to do internal medicine, if you want to do a subspecialty of internal medicine like neurology, or physical medicine and rehab, look ahead, because a lot of those residencies are standalone residencies, so it can really cut down your time. Save your money, plan for the exams, and look at your timeline. Some persons will feel, hey, I need 6 months to study for one exam. Some people will say, you know what, I only need 3 months. But at the end of the day, I think we need to do a better job of essentially looking ahead, making a plan, and organizing our time, so that we can have our timeline match up with a lot of these residency timelines, so that you can get you can have an efficient transition from medical school into postgraduate training. I would say look ahead at what you need for the visa requirements. If you don't have a green card, you're going to have to get a J1 on H1, and it really depends on what the school will offer, and do you have the qualifications? Have you finished all the exams required for that visa? I can't emphasize this enough. Medical school away electives. If I could think of one thing that I could have done during medical school that would have helped my application, it was to take one of my electives, save whatever money I could, ask for all the gift money, and take that one elective and go away during medical school and do a U.S. clinical elective, because it has more weight on the application than if you try to do one after medical school, what they call an observership. This one is also a freebie that I wish I knew about when I was a student. Join the professional society of your interest, the American Academy of Neurology, American College of Surgeons. They all have student rates, and sometimes very, very reduced student rates. And then if you join them, you get a lot of their emails. You can join their committees for trainees, so that you can have actually an ability to apply for scholarships and affect change, and even get like grants to visit, to go to the society meetings. And a lot of the speakers so far have talked about research opportunities. There's so much low-hanging fruit, that we can use. And UE students and and DM students, they do quite a bit of research. And at the end of the day, what makes a research matter a lot of times is publication. So get it out there, And then this is where having links and connections to people who have published before will allow you to see what is publishable, what is needed in the field to publish, and what else can you, what can you do to help to affect change and boost your resume? Because, after now basically 6 years of sitting on essentially, application boards where I read through, these CVs and, from the residents that are applying from the US, IMG and non-IMG, and I'll say one of the biggest differences is that the US grads, they know how to sell themselves on their resumes, on their CVs, on how to describe, something as simple as a poster presentation that they did at a local conference to make it into a positive. So, look for those research opportunities that are really simple. A poster presentation on an interesting case on the medical school section or training section is usually going to get accepted. But you just have to look it up and look at the deadlines and be organized about it. And then reach out to the other UWI alumni who've already paved the way. Send out, I sent out my CV widely to lots of other, UWI graduates, and I just got feedback on it, my personal statement. Like, do that and do that early and get that feedback, because the only way that you can improve your application, one of the only ways is that you let other people who have been involved in the application process read it and give you feedback on it and be open to it. And then one other thing I would say, that if you have a particular specialty that you're interested in and you're trying to make the links in, myself, I was interested in neurology, so I reached out to Dr. Ramming and I said, hey, I'd never met him before, actually. And I said, sir, I'm interested in neurology. My name is Madiha. Can I come to your clinic? And in medical school and in internship, I just used to go to his neurology clinic in the afternoon and got to know him. And at the end of the day, I was able to ask him for a letter. And I have to say, my letters of reference were all from doctors who worked at PMH, and everyone that most of the interviews I went to, they commented on the depth of the letter, how good the letters were. And so I would say letters of reference really make a difference. But the only way that you can get a good letter of reference is that you have to reach out to the people and become involved in that specialty. And so, just making a phone call or email can go a long way to make new contacts. And then the last thing I'll say, because I know I'm running short on time, is that, some neurology fellowships, the specialty fellowships, are open to DM internal medicine candidates, even without a US residency. So things like movement disorder and neuroimmunology. So it's something to think of. So I really like brains and cats. There's my email. Please feel free to send me emails about brains or cats.
Thank you very much, Madiha, and I wish you all the best, and I know that you will continue to give back to the Bahamas. So I look forward to when you do so. We have two more speakers, and I'm going to ask your patience and indulgence for us to forego the coffee break. And I promise you, at the end of the two speakers, I'll let you stretch and then move straight on to the other session. So our first speaker is Dr. Jonathan Amal Higgins. And Dr. Higgins is somebody I actually know and trained as well. I must be really getting old. And Dr. Higgins is another UWI graduate, and he did his internship and SHO year here before he went on to the University of Toledo Medical Center to do his general surgery residency, and then went on to a vascular surgery fellowship at Eastern Virginia Medical School in Norfolk. I understand that he is in Florida, and I understand that he and his brother are looking back to return to the Bahamas in some way to give back. So I'm very excited about that. Dr. Higgins. And by the way, I mixed you up with your brother yesterday and was very disappointed you didn't recognize me. And he said, no. Please go ahead, Dr. Higgins.
Can everybody see my screen?
We can.
Yes, we can.
Okay, hold on. Let me get the presentation going. There we go. All right, thank you, Dr. Roberts, for inviting me. Dr. Sinqui, that is a problem that I encounter all the time with my brother. People walk up to he or I and say, hey, do you know me? I'm like, don't recognize you, you're confusing me with my brother. But today, I just want to talk about my journey. I'm going to take a slightly different approach than the other presenters. So my goal is to do three things in this 10-minute presentation. Is to inspire you, to inform and empower the residents, the students, on how they can achieve their goals as it pertains to getting to residency in the United States of America. It's important for me to give back because I truly believe that you are the future of the Bahamas in terms of healthcare and in general. But what I'm going to do is also tell you why it's important for you to have paid attention to the speakers that have come before me and the speakers that are coming after me, because what you're going to learn here are certain things that are going to allow you to advance your career in medicine, but there are also some themes, if you peel back the layers of the onion, that will allow you to be very successful in life. So I wanted to be a doctor ever since I was about 7 years old. It was after a conversation with my father. And I wanted to wear a lab coat. I wanted to be a scientist. And my dad said to me, listen, you can't sit still. You're not focused. Why don't you go and you can't work in a lab all alone in a basement. Why don't you go and become a doctor like your Uncle Philip? Now, my Uncle Philip was my favorite uncle. He rescued me from drowning when I was 4 years old. My dad never found that out, but he was my favorite uncle. So when he said, become a doctor, at age 7, I knew I was sold. I'm going to be a physician. My grandmother gave me a book entitled Gifted Hands by Dr. Benjamin Carson. When I was 9 years old, I read that book. And so from the age of 9, I wanted to be a neurosurgeon. I wanted to be a neurosurgeon. I wanted to go to Yale. I didn't do that. My brother did that. But I said, look, I'm going to be a neurosurgeon. And then I met a gentleman when I was 16 who probably each and every one of you know. And if you don't know in the Bahamas, you probably live under a rock, is a one Dwayne Sands. He had returned home. I had the opportunity to meet with him, rotate with him. And from the age of 16, I wanted to be a cardiothoracic cardiovascular surgeon, as did 2 others before me, Dr. Wesley Francis and Dr. Brendan Curtis. None of us, unfortunately, have become cardiothoracic surgeons, but that's a story for a different day. So I knew what I wanted to do. I went into med school. I wanted to be a surgeon. And then I came back, did my internship, finished med school in 2002, and I stayed here until 2006. What happened? And I contrast that to my colleague, Dr. Omar Felix, who was Jamaican. He had gone to UWI, graduated the same year that I did. And in 2004, we finished internship, which was mandatory in January. And in July of 2004, he was gone. He was off into his residency. And I couldn't figure out what happened to me. Why didn't I get off? Well, it wasn't enough just to have this dream or idea to become a surgeon or a cardiothoracic. You actually have to set goals. And the goals have to be specific, measurable, attainable, realistic, and time sensitive. So I said, hey, Omar, how'd you do it? He said, listen, I just set the test. And you heard Dr. Hepburn talk about her conversation with Corinne Sinqui. She said, just take the exam, set the exam. You have a specific timeline, it's measurable. And I figured if Omar Felix could pass the exam and many others have done it, it's attainable, I could do it. And so now it's time sensitive, I had a date. So I'd love to tell you that the end of 2004, 2005, I matched. Big fail. That didn't happen. I passed the exam because that was my target. My target was pass the exam, take it, pass it, you get into surgery. No. What happened was I didn't prepare. And you recognize that proper preparation prevents poor performance. And I performed poorly. Again, Dr. Hepburn talked about the difference between the timeline at UWI, the difference between the timeline that the US residency spots go along. The residency training for the medical students, getting prepared for those USMLEs was entirely different from what we've been used to. I set my exams. I took my step 1, let's say in February, then again in March, I took my step 2, and then April, I did my CS. And guess what? I thought I'd done my best. I did well. I didn't have great scores, but I did my best. But here's the deal. When your best isn't good enough, you have to do what's required. And you have to know what the requirements are to get into school. And that was my downfall. I didn't know what the requirements are. And so this topic that we're talking about today is more about your mindset, your planning, and your preparation, more so than just here are the steps. Dr. Mallory Williams has alluded to the fact that some of the steps have been removed, but here's the deal. The basic science exam that you have to take is your USMLE step 1. That's the United States Medical License and Exam step 1. It is basic science heavy. And the people that have been most successful are the ones that take this at the same time that they're doing their early preclinical years, because the knowledge is fresh, the knowledge is clear. They take that and get it done. But you have to prepare, you have to plan that well in advance. Dr. Hepburn mentioned this. What was her biggest regret? I regret not having taken the exams at the appropriate time. Imagine me. I took them all in the space of 6 months. So of course I wasn't going to get the high score that was necessary. Step 2, you have to take the clinical knowledge. That is the clinical knowledge test. That is the regular stuff that we do each and every day as University of West Indies students. We perform high and extremely well on this part, but it's not the only thing that's necessary. Step 2, Dr. Malley, clinical skills. We could examine the business out of a patient. We could figure out things that CT scans, MRIs can't figure out in the United States. We outperform them, but guess what? Dr. Williams said the lack of the clinical skills, the lack of demonstration of our ability to communicate is going to hurt us. So you need to prepare. So here's the part that really messed me up in 2005. There was this thing called Educational Commission for Foreign Medical Graduate Certificate that was a necessary part of matriculating and being accepted. So, you know, I put up my application and guess what? It was an incomplete application. So I'm telling you about my failures so that you can be successful. Many of my mentors have said you learn more from your failures than your successes. The key thing with failures, and Winston Churchill said, listen, success is moving from failure to failure without loss of enthusiasm. We have to understand, we heard Dr. Thompson Reel earlier on say that she didn't do well on an exam. Guess what? Look at where she is today. We heard Professor McDonald talk about the fact that she spent 8 years at PMH. Again, she didn't even know about it. There wasn't a goal. So understand, these are the clinical pearls. These are the tools that are going to make you successful. So I took my USMLE Step 3. That was the final licensing exam. You have to do that. That gives you an unrestricted license. That is key. And you can do that. That's very easy. So once you do that, once you have a complete package so that you can apply, it's very easy now to go online. You apply through Electronic Residency Application Service. And there are 2 types of openings in terms of surgery. There's a categorical, which is the holy grail. You saw the statistics from Dr. Williams. It's an 11% chance of you getting into that as a UE grad, and that is all comers. You know, he mentioned Dr. Muhammad Osman from the University of Khartoum. They don't even apply for their United States residency unless you have a 250 or above. I mean, you don't even show up. We had a professor of surgical oncology, Dr. P.K. Chaudhry, Prabir Chaudhry, Dr. Williams will remember affectionately. In India, he says, listen, we start taking USMLEs in the 3rd grade just in case you want to do medicine. So this is the level of competition that you're going up against. So categorical, the first year I applied to categorical and prelim, I applied to about 175 programs, didn't get a single response, but that was on me because I didn't prepare. Second year, I recognized that categorical was off. I only applied to prelim. I applied to about 120 prelim programs. I got accepted. I got invited for 5 interviews. Dr. Hepburn, Dr. Williams have mentioned the importance of professional relationships. The places that I got invited to interviews had a connection with people that I worked with. They had a connection with people that they had worked with. If you can imagine Dr. Williams, the program director's task of going through 400 applications for 5 or 6 spots, he has to figure out what's the force multiplier. How do I weed through all of this? Yeah, you got the secretary to help screen through such and such, but now you've got 30 good, strong candidates. How are you going to get to the next level? You have to have a professional relationship. You have to have mentorship. Those things were available to me, but I didn't leverage them. So back to this prelim spot. So attack the low-hanging fruit, the preliminary spot, 41% chance. That is where you have the opportunity. When I went up for my interview at the University of Toledo, I met one Joseph Zafera, who happened to have graduated at Wayne State University with Dr. Dwayne Sands. The interview went pretty much like this. Dr. Higgins, your USMLE scores are terrible. He said, but listen, we can get you a guaranteed prelim spot, but here's the deal. If you want to transition from prelim to categorical, you have to get in the 95th percentile in your ABSITE. That's the American Board of Surgery in Training exam. So again, not understanding what was happening, I had a target. It was specific. When I joined in July, I knew that in January, I would take a test. So, there were guys that were ahead of me that had achieved this mark. So what did I do? Other than just working hard, I dedicated specific time to work with these guys. One guy from Sudan, Mohammed Margani, another guy from Nigeria, another guy who had done, Mohammed Margani had rotated at Mayo Clinic prior to, again, 240s, 250s and above USMLE. A guy by the Mario Castillo Sang from Panama, 250s and above. He had done a previous rotation, a prelim spot in New Mexico. A guy by the name of Barbu Gochiman from Romania. He'd done a PhD in genetics. And again, 240. These are the level of people that are competing. They were 2 years ahead. They were a year ahead of me. I studied with them. They'd all gotten 99th percentile on every single exam that they'd taken. Fortunately, I got 97th percentile. The rest is history. So you have to shoot for the prelim spot. That's my opinion. If you're a superstar, D'Angelo Ferguson was very fortunate. He prepared appropriately, did the exams at the right time, leveraged the pre-existing relationships. You go for your interview, you sell yourself. Dr. Hepburn mentioned that the American students can make, they can sell themselves so wonderfully well. That is a skill that we have not developed, I don't think. But it is a skill and it takes practice. You have the match and the scramble. The chances of getting in on the scramble are very low. The match is where it's at. That's where you want to be. I recognize that time is winding down. And what I want to say to you, the most important thing is you have to develop a mindset. It has nothing to do with just these steps. I can give you the steps. And as Jesus mentioned in the parable of the soil, I figured I could get away in the Bahamas using a biblical reference, in a medical talk. He went and sowed the seeds in the soil, 4 types of soil. So that's a 25% retention rate on a talk. I'm not as good as Jesus. I'm not even gonna pretend to be. So maybe my retention rate is about 10%. My prediction is that 10% of you or fewer are going to act on the words that you've heard here today. 10% or fewer. I hate to, say that, but it's true. So what do you need to do? Again, you know the steps, whether it's the UK, whether it's Canada, whether it's the United States. So you need to plan, then you need to do. Because just planning on words, I'm gonna do this, no, you have to do. And then when there's a failure, you study why it went wrong. And then you need to act again. And if you do this in medicine and in life, you'll be extremely successful. And before I close, since I got Dr. Williams on here, it was actually Dr. Williams who put me on the pathway to personal development. After he came to the residency program in my final year. These are the 21 irrefutable laws of leadership by John C. Maxwell. So I would say thank you very much. It has been a pleasure. I'm here and available.
Thank you very much, Dr. Higgins. And I know that we're running a little bit late, but everybody's so passionate and excited about sharing the information. So thank you very much. Our last speaker for this session is Dr. Higgins' brother. So Mikhail Higgins had a different path. He did not go to UWI, and we won't hold it against him. More importantly, we're very proud of his achievements as well. He went to medical school in the United States. He went to Wake Forest University, and then after that, went on to do his residency at, let me just see where this one is, University of Pennsylvania for his radiology, and then interventional radiology at the University of Virginia. And you did mention that he has some training at Yale, and that is in healthcare administration. And I understand, like you, he is wanting to come back and give back to the Bahamas. So we're looking forward to both Higgins coming back. Dr. Higgins, please take over.
Awesome, terrific. Thank you so much, Dr. Sinqui. Thank you to Dr. Roberts for just an exceptional symposium. Thank you to the organizers. And first and foremost, thank you to my co-speakers, Professor
everybody has just been offering such amazing light and wisdom and just the commitment to excellence and commitment to inspiring the next generation of physicians and specialists to be, for me, is just very heartwarming. So it's very, very difficult to go after certainly my brother, Professor Williams, Professor Hepburn, and offer anything new. So I'm going to take a little step outside of the box. And I was always told that when offering any words, you should have 3 goals. The first is to be funny. The second is to be brief, and the third is to be heartfelt. So my partner and anybody could say I am certainly not funny in any way, shape, or form. So there goes that first goal. The second, being brief, I think Dr. Roberts gets the credit for offering me 10 minutes. So he gets the credit for that. But the third, I can certainly accept humbly, which is to be heartfelt, which I certainly will be. So in order to not cover what has been covered, I want to step outside of the box. And my brother made it very clear that the journey begins in your mind and ends in your mind, which is where my focus of my talk is going to be. The battle, obviously you see Professor Williams and fatigues. It is a battle, it is a fight. It begins in your mind and ends in your mind, hence the focus of our discussion today. So I'm going to begin with a story and a quote. I'll start in reverse. And so the quote is from Abraham Maslow, who is a great American psychologist. He said, in any given moment, you have 2 decisions. 1 is to step forward into growth, or 2 to step back into safety. Okay, so as you reflect on what you've learned today, I want you to ask yourself, in any given moment, what are you doing? Are you falling back or are you falling forward? Are you leaning forward or are you falling back? So the story. So once upon a time, about 20 so years ago, there was a young man in the Bahamas. He was at Queens College. He was there doing extremely well in high school, did everything that his parents asked him to do and worked very hard, was a very independent learner. He had colleagues that had SAT tutors and did extremely well in the SATs. He himself didn't have an SAT tutor, but he did very well himself. He had colleagues that had guidance counselors that essentially provided them blueprints in terms of how to get in school. And at some point, he saw that students that were in his class who were sort of not where he was, which is at the top of the class, were getting into schools, Yale and Princeton. And he just marveled at how it could possibly be. But his parents said, you know what, as long as you do well, good things will happen. Unfortunately, at the time, he had a brother who also went on to University of West Indies and did extremely well. And he felt that he should follow on that path too, but he knew that he had a unique journey that he needed to trod. He ended up having a little bit of an altercation with his father, who said, if you want to do medicine and you live in the Caribbean and you want to serve Caribbean people, you go to the University of West Indies. It is not only cost effective, but it will train you to become the best clinician or surgeon you could possibly be. Unfortunately, he had other plans. He wanted to study Spanish. He played the violin. He ran track and field for the junior national team. He was all into these things, and he felt the liberal arts education was where he needed to be. And so he decided at the end of high school, when he didn't get into any school because he didn't have a blueprint, and all his colleagues who were graduating sort of at a lesser space in terms of sort of ranking in the class. He was his Gentleman of the Year. He was the Alpha Phi Alpha valedictorian for the convocation, and he had nowhere to go. So he ran away to Jamaica to hang out with his brother, started growing dreadlocks, and decided this is the life. Okay, screw the world. And unfortunately, or fortunately, got a call at the end of the summer, and his mother said, you need to come back to the Bahamas. She said, you got 9 A's and a B on your BGCSEs, which is the graduate secondary education exams, and you got the second highest results in the country. You need to come back. He said no. She said, yes, you need to come back. She said, the College of the Bahamas has offered you a full ride. You need to come back. This is your start. This is your bird in hand. And he said, you know what? I feel like I'm too good for COB. I'm not coming back. And she had a long talk with him. He humbled himself and he remembered the words of Benjamin Franklin, which is to succeed, you need to jump just as quickly at opportunities as you jump at conclusions. And so he did just that. He moved back to the Bahamas, and he used that year as an opportunity to finance and find ways to fund his education, since his father had said that he was not going to do so if he went to the US. He also found universities, colleges where he felt that he could thrive in the way that Dr. Mallory Williams said, that there are environments in which we thrive, and there are environments where we thrive with the weight and resistance of 1,000 pounds. And so ultimately, he had Macalester College, which was a school where Kofi Annan, the former UN Secretary General, had went. He had the school Macalester, where Christian Campbell, the second Bahamian to achieve and to be awarded a Rhodes Scholarship, had gone and didn't do too shabby for himself. So he focused then on that school. And then Northwestern and Emory came into the mix. Northwestern was in Cole, and then he realized Minnesota was where Macalester was, so that was off the list. And so he settled on Emory. And about a week before he was getting ready to fly off and getting ready to give his father a hug and say that, you know what, I did it, got a call from Emory, and Emory said, "I am so sorry, sir." And the young man was like, "Well, why are you sorry?" He said, "Well, we misclassified you." "Well, how did we misclassify me? I'm so confused." They said, no, we misclassified you as a domestic student. And I said, no, I'm a Bahamian. I'm an international student, the young man said. And they said, "Well, no, we realized that." And they said, "But that kind of affects your financial aid." And so he proceeded to say, well, how so? And they said, "Well, you know, we gave you $35,000 in financial aid, and unfortunately that has to be revised." I said, what do you mean it has to be revised? "Well, we can't give you anything." And so the man cried, went back to his mother, felt that it was karma for not listening to his father, and ultimately called Macalester College, and they offered him a full ride. Went to Macalester, froze his butt off for 3 years, and really humbled himself to ensure that he took this bird in hand, and he ensured that this opportunity, he made something of it. About a week into applying for medical school applications, somebody broke into his room and stole his computer. His secondary essays and everything that he was going to hand in the following day were stolen. And so he ended up only getting 4 interviews. Out of those 4 interviews, again, feeling that this was karma, got into one school, at school in the South. And I would be lying if I said it wasn't easy. I would be lying if I said that this young man didn't have patience that said, "You can't touch me because you're Black." I'd be lying if I said that this individual did not experience people that said, "You know what, if you have dreadlocks, you shouldn't be a doctor." I'd be lying if I said that this person, a year after being awarded a scholarship, they stopped offering scholarships to international students, and he had to figure out how to make it happen. So this young man, unfortunately, focused on relationships, focused on competence, focused on managing his distractions, and ended up becoming the first Black male resident in history of the University of Pennsylvania in radiology. Subsequent to that, went on to become an assistant professor where he directs medical education at Boston University, founded the Radiology Intervention Safety, Quality, and Complications Symposium, which is a Society of Interventional Radiology endorsed global CME course and forum, and is the former fellowship program director for his field, of which he is the first interventional radiologist. So, of course, you figure this out. This is me, and I share the story not as a means of being braggadocious in any way, but to approach this in a way that Kobe Bryant approached the question of greatness, which is that greatness is not an isolated act. It's not something that you do and you enjoy, for selfish benefit. It is something purely designed to inspire somebody else to do the same in a unique way that rings true and resonates with their purpose in life, okay? So it's not to create a mold that only you can fit into, but a mold that others can fit into and create and adapt it for their purpose in life, okay? So I have 4 pearls and pitfalls that I want to share with you that for me has been important in my high performance journey. And it's not meant to be prescriptive. We physicians tend to prescribe. It's meant to offer you a buffet. And you can take from that buffet what serves you, and you can leave what doesn't. No more, no less. That's the deal. So the first is to know your why. There's a gentleman by the name of Simon Sinek. He wrote a few books. And the first book, which is what I'll speak on, is Start With Why. He's written most recently The Infinite Game, Leaders Eat Last. But Start With Why is my favorite. And it's my favorite for this reason. His hypothesis is that in any great undertaking, before embarking on it, you have to know the why. And the why has to be so clear that it substantiates the sacrifice, the effort required to both achieve it and sustain it, okay? To go a little further, I would say you need to know your purpose. All right. So I know if Professor Williams came to the Bahamas and Dr. Sinqui offered him that 40% off at Milia, and he was to get on his connection in Miami and jump on Bahamas Air. Bahamas Air said, boy, we got a flight here, but I can't really tell you where it's going, but we're going to fly over the Caribbean and, we may or may not land in the Bahamas. I will tell you 40% off or not, Professor Williams will be off that flight. Okay. So in the words of Thomas Carlyle, a man or a woman without a purpose is like a ship without a rudder. A nomad, a waif, a wandering generality, okay? So even Rick Warren, who is the pastor of the Saddleback Church, which is among the top 5 mega churches in the US, in his book, A Purpose-Driven Life, what did he say? he said that each of us, when we were born, we were given a purpose. It was infused in us. It's as unique as our fingerprints. It's as unique as our irises. And it is our relationship to our non-physical self that animates that unique purpose, that gives it life, that actualizes it, that allows us to do something in this world that's impactful and unique to us. So what is your purpose? And we remember from the words of Proverbs that many other plans in a man or woman's heart, but it's the Lord's purpose that prevails. So what is your purpose? The second thing I ask you is, what is your orientation to distractions and what is your orientation to failure? Dan Ringo wrote in his book, distractions come purely to test your commitment to your why. So if you don't have a commitment and you don't have a why, oh boy, when it comes time to study for step one, oh boy, when it comes to apply, oh boy, when it comes to manage those relationships that are going to be instrumental in your journey, oh, you're going to fall off, because those distractions are testing your what? Commitment and your why, okay? The second thing is, what's your orientation to failure? You know, Tony Robbins, says, you have, the question for you is, do you have a healthy and unhealthy relationship with failure? So when you win, do you party? And then when you lose, do you ponder? Because that, my friends, is a healthy relationship. Or do you, when you party, when you win, or when you lose, do you cry and try to avoid and cover and be like, oh boy, I didn't do that, So what you need to have is a growth mindset. Carol Dweck in her book really says either we fall into two mindsets. Either we have a fixed mindset, problems help me be better, or a growth mindset, problems help me be better, or fixed mindset, problems highlight my deficiencies, okay? And so the goal is to be in the former group. And we often need to remind ourselves is that the stones are smoothest in the stream where the stream is the roughest, okay? That comes from being weathered, being beaten, being battered, okay? And we are in the face of failure. You need to know that failures are meant to not tell us who we are and not to highlight our deficiencies. This is to tell us what not to do. It's meant to inform us on how to be better. So the question for you is, what's your orientation to failure? The third point is to believe. And, you can have people that believe in you, Dr. Sinqui, Dr. Roberts, but if you don't believe in yourself, it's going to be very hard to proceed. And, we have to go no further than Abraham Lincoln, who said that the reason I am successful is because I had a friend that believed in me and I did not have the heart to let him down. So their belief in your success is extremely important. And the fourth and final point is on the integrity. And integrity is in terms of alignment and honesty. So Dave Chappelle made it very, very, very clear. Success can take you where your character might not sustain you. And I'll repeat that for everybody in the room. Success may take you where your character may not sustain you. So we have to look no further than 20 years ago, Enron Corporation, one of the biggest energy corporations, ended up being bankrupt because of a scandal of trying to cook the books, trying to be bigger than they actually were, okay? You've had people, fashion moguls, that have also succumbed to issues of integrity. At the end of the day, you need to be in alignment with both your purpose, your principles, and your virtues. And so I end with you with a reflection from the great Miles Monroe. Miles Monroe said, many people think, boy, we're in the wealthiest place in the world, the diamond mines of South Africa or the oil fields of Iraq. But no, my friends, the wealthiest place is in the cemetery, because therein lies the uncultivated growth and potential, unclaimed dreams, unadopted potential. So what is your potential? Where's your wealth and where's it cultivated? And I leave you with a simple quote from great Dr. Seuss, who as a child, 2 years of age, I read this and I still remember it to this day. You have brains within your head and your feet within your shoes. You can direct and steer yourself in any direction you choose. My friends, I love you. I care for you. I am so proud of you.
Thank you. Oh, fantastic, Dr. Higgins, and very inspirational. I have just one question. I know we're running late. Thank you, everybody. Thanks, everybody, for your patience. Dr. Williams, there's one question that asks about your thoughts on the change in the scoring of the USLME. Step 1, to pass, fail, and how it might affect the match rates for IMGs. Dr. Williams, Valerie Williams is still on the chat. Okay, I think he might have some problems unmuting, but maybe he could just type the answer. And I'd just like to mention that I know we've been saying a lot of things about UWI, but really and truly, the institution has graduated, I think, something like about 500 medical doctors from it started in 1948. But we will not downplay the contribution from other medical schools, non-traditional medical schools, and
5,000.
I'm sorry?
That's important. I'm unmuted now.
Okay. Go ahead, Dr. Williams. Maybe you can quickly just answer the question, and then we'll just take a 2-second stretch and move to the next
Yeah,
section.
I think it's an important question. Listen, we're going to go from an era where we could differentiate candidates who had 230s and 250s to an era where we really are now just faced with pass and fails, which is going to make programs who were rigid or tough to break and penetrate into more, even more tougher. I mean, because you can't demonstrate academic excellence and forge that opportunity. That prioritizes, that even puts more weight into what I'm talking about in terms of UE developing a clinical outcome center. I could have said a research enterprise, but the reality is to take biomedical sciences and try to develop that across UE. That's a decade, or if not a generational aspiration. Clinical outcomes across UE is a 2 to 5 year doable plan. Particularly in conjunction with an established outcome center on the state side, with the aspirations of moving to a solo center, because that they're going to have to be other distinguishing features for your application. If you can't outscore the American candidate and no one knows that you're better clinically because they haven't seen you, then the only other thing on the application that's going to differentiate you is the research. And classically, I think, we got to look at that space and move into that space aggressively. This is not something that we can soft pedal, because these changes are going to impact the pipeline. There's no doubt about that.
Great advice.
Thank you for that question.
Great advice. And also to remind everybody that ECFMG is a requirement for certification of programs. If you're not in a certified program by 2024, you will not be able to enter a residency program in the United States. And I see from a previous presentation too that ECFMG is also the platform being used in the UK. So everything is being centralized. So everybody needs to be sensitive about that. Take a 2-second stretch for me, please. And I'm going to hand over now to Dr. Sabri Butler-Pinder for the next session. And I apologize for the late start. Thank you very much to all our presenters. You did a fantastic job. Sabrika, whenever you're ready to start the next session, please.
I'm going to take over from Sabrika. I wanted to recognize that she lost her partner a couple of weeks ago, and she's still trying to regain her strength to a normal activity as much as possible. And so I'm going to be taking her session. Dr. Holliday, could you load up the video for Dr. Dilep, please? I just wanted to know our next speaker.
Program organizer.
Let's put it on. Yeah, good. Just keep it on hold for me. Our next speaker is really has emerged in a very short period of time as a leader in academic medicine and in the university in Trinidad. He's won awards from the West Regional Health Authority and the Medical Association. He is a university examiner in surgery over the last 3 years. He heads the Department of Surgery at St. Augustine, and he's president of the Trinidadian chapter, American College of Surgeons, and the Caribbean Obesity Society. So Professor Dan has many accolades to his name, but most prominently, he's come as one of the senior and top laparoscopic and bariatric surgeon in the region. So he gave his apologies. He was not able to make it in person, but he definitely set forward his video to be very much a part of the session. So without any further ado, Darren, could you please set the video?
Good morning. Program organizer, Dr. Robin Roberts, specially invited guests and speakers, colleagues, residents, students. It is really a great pleasure to speak to you today on the postgrad options for training at the St. Augustine campus of the University of the West Indies in Trinidad and Tobago. When asked about this talk, Dr. Roberts asked me to speak on the spectrum of the postgrad programs available, the pros and cons, the challenges to being enrolled in a program in Trinidad in terms of immigration, medical counsel requirements, acquiring a job at an RHA, postgrad enrollment exams, and interviews, etc., as well as fellowship opportunities. Now, before I get started, just want to go through the structure of the public healthcare system in Trinidad and Tobago. We have a population of about 1.3 million, just under 2,000 square miles. The Ministry of Health controls is the central governing body, and there are 5 regional health authorities. There are 3 major hospitals, Eric Williams Medical Sciences Complex, the Port of Spain General Hospital, San Fernando General Hospital. These are hospitals with about 500 to 1,000 beds, with greater than 85 to 90% occupancy. The 3 smaller hospitals, Sangre Grande Hospital, Tobago Regional Health Authority Hospital, St. James Cancer Center, and then there's several new facilities, Couva Children's Hospital, about 300 beds, the Arima facility, the Roxborough and Point Fortin hospitals, and these are about 100 bed each. Now, the 3 major hospitals are the ones that are used for training. Rotations are arranged in the others when applicable. We are creating a national system of rotation of residents so that there is ready movement from within an RHA and from one RHA to the other. The 4 new sites are being accredited for some programs and aspects of some programs. UWI lecturers and associate lecturers are available at all sites once a program exists there. And just to point out, and I have a feeling the pointer is not going to show this, but the Port of Spain General Hospital, the Eric Williams Medical Sciences Complex, and as we head east, the Arima facility, and then the Sangre Grande Hospital. And south from Port of Spain, we have the Couva Children's Hospital, San Fernando Children's Hospital, and then the Point Fortin Hospital. And then if you go to Tobago, Scarborough Regional Health Hospital, and heading further north is the Roxborough Regional Hospital. Now, instructor of the DM programs, they consist of 2 parts generally. Some programs have 3, but part 1 is the basic science here, which students take an exam at the end of to move forward to the part 2. The part 2 can vary from 2 to 5 years or 1 to 5 years based on the program that is being done, and generally includes a research project, a case book of either 10 or 20 cases. And some programs have an elective year as well, in or outside of the region. At the end of the part 2 exam, candidates, at the end of the part 2, the candidates sit an exam, which is a written exam, an oral exam, and in some cases a clinical exam. As mentioned, some programs do have 3 parts. Upon graduation, the candidate is expected to be an independent specialist in the area. A year or more fellowship training outside of the program is highly recommended. These fellowships are facilitated by supervisors at UWI and can usually be done in Canada, Australia, United Kingdom, South America. Then they are open, there's the open market for them in the Caribbean. Now, what are the DM programs in Trinidad and what is the duration? The anesthesia and intensive care, it's 4-year program. Anatomical pathology, 5 years. Emergency medicine, 4 to 6 years. Family medicine, 2 years. Hematology and blood banking, 4 years. Internal medicine, 4 years. General surgery, 5 to 7 years. Neurosurgery, 6 years. Obstetrics and gynecology, 4 years. Ophthalmology, orthopedic, otolaryngology, 6 years. Pediatrics, 6 years. Psychiatry, 4 years. Radiology, 4 years. And neurology, 6 years. What are the DM programs that are not offered? Pediatric surgery, but there is a proposal and hopefully we shall start this program in 2022. Cardiothoracic surgery, plastic surgery, oncology, which is this has been approved but is on hold. There are a few diploma programs in family medicine, emergency medicine, and HIV, and one fellowship program in cardiovascular medicine that is available. Now, just to look back at when our program started, the number of graduates, and the current enrollment. Anesthesia started in 1985 with 63 graduates and 32 enrolled. Anatomical pathology and blood banking and hematology are new programs starting in September. Emergency medicine and family medicine, 36 and 33 and 33 graduates respectively, with 31 and 11 enrolled. Internal medicine, 20 graduates with 11 enrolled. General surgery, 17 and 27 enrolled. Neurosurgery is a relatively new program with started in 2016, so we expect our first 2 graduates in 2022. Obstetrics and gynecology is one of the oldest programs, 1979. 22 graduates with 9 enrolled. Ophthalmology, we started in 2003. The program had to be aborted, and we restarted in 2015, and we now have 5 enrolled. Orthopedic surgery, 15 with 8 enrolled. Otolaryngology, 4 and 4. Pediatrics, 44, 22 enrolled currently. Psychiatry, 40 with 24 enrolled. Radiology, 41 with 17 enrolled. And urology, 11 with 6 enrolled. Several of our programs have graduated residents who are outside of Trinidad, Guyana, Barbados, Jamaica, to name a few of these, and Bahamas, to name a few of these facilities, countries. The requirements to enter the DM program, each program will have some separate and specific requirements. However, most require a 1-year experience in the specialty. They need to have or be eligible for registration with the medical board, must have employment at one of the 3 major RHAs, and they apply through the UWI online. Interviews are conducted, applicants are shortlisted and selected, and the number of accepted candidates can vary with program, and also can vary year to year within a program. The entry is usually in September, October, and January for a couple of the programs. Now, the cost for a local candidate in Trinidad is about 31,000 TT, just about 4,000 US, and for a foreign candidate, it is 6,000 US per annum. Immigration requirements for CARICOM nationals with a SME certificate. They will get a Trinidad and Tobago equivalent certificate from the Ministry of Foreign Affairs. They have 30 days to acquire upon landing, and the RHA is to provide them a letter, and UWI will also have to provide an acceptance letter with details of the study for this to happen. For non-CARICOM nationals, they require a work permit, which is valid for 3 years at a time. Ministry of National Security will provide this. It is obtained through the RHA, by the RHA on behalf of the resident or of the student. UWI will have to supply, obviously, an acceptance letter as well. And these are the websites for these bodies. The medical board, again, the website is listed here. And the requirements are clearly outlined on the website for perusal. In terms of the pros and cons of doing a program in Trinidad, one clearly is the Caribbean locality. It's a wide range of pathology. We have 16 DM programs to choose from. We do have excellent staff, multiple facilities with varying opportunities, and students can rotate among facilities so they get the best of all worlds. The medical technology is readily available, and at the end of residency, we do graduate a very sound, capable doctor. There's easy access to and from the countries within the Caribbean, and the fees are relatively cheap. Now, the cons of doing a DM program in Trinidad and Tobago: getting a job at an RHA as a foreigner is hard. Getting a job at an RHA as a local is extremely hard. It does require also some traveling among the facilities in Trinidad, so one may have to acquire some form of transport. It's a Caribbean island, hence considered low volume compared to the US and others. The very high-end robotic surgery, medical procedures, ECMO, etc., not readily available. And we also do not have all the DM programs that one may wish to consider. Now, challenges, again, the biggest hurdle is getting a job at an RHA, and sometimes even the CSME certificate is a little difficult to get in terms of delays. However, if a resident can get funding from the home country, they can be supernumerary in the system and can function as well, as happens very often with students from Bahamas, especially in radiology. There are also self-funding opportunities. Now, what is the advice for post-residency fellowships? Only cardiology fellowship is offered in Trinidad. It is strongly advised to do a 1 or 2 year fellowship outside of Trinidad and Tobago in a high volume center. Places used by our graduates have been India for oncology, for hepatobiliary, and Canada for breast nephrology, Australia for vascular surgery, the United Kingdom for the wide spectrum, Italy recently for hepatobiliary, Malaysia for breast. The USA is a bit tough for our graduates because they require licensure, which requires USMLE 1 and 2 and so on, and so fellowships programs in the US are a bit tough, except for research fellowships. Similar challenges to overcome in terms of getting a fellowship, in terms of funding sometimes, and registration in the country, but these are not insurmountable. So this brings the presentation to an end. I want to take the opportunity to wish each and every student here the best of luck in terms of obtaining a residency program and in their future endeavors, and also to assure them that once they are happy with what they do, or once you're happy with your choice, your life becomes very simple, and any hurdle becomes easy to cross. So thank you again, and we'll take questions.
That's a great picture, Kelsey. Yes, I don't know if I don't think Professor Dan is available for questions at this point in time, but one of the things I want to add is that as a graduate of UWI, all of those preliminary exam requirements are out of the way, and so that makes it much lighter on your pocket. But there are times when you want to travel throughout the Caribbean and get to see the other part of the region. And so I think it's very important for us to be aware of those programs. And just to add on to that, I want to bring on our next speaker, of that great class of 1980. I tell you, I just looked at that picture just a while ago. Well, we all looked a little different as we get a little older. But I want to welcome Professor Denise Eldermeyer Sherrill, whom we all know, who has been almost like I don't want to say a fixture, but really has been a pillar of strength in the university, particularly in the field of administration management and in her field where she has really been pioneering in public health and aging. This is really a strength, and she's done extensive work and continues to do so. She is currently examining the responses needed in the primary healthcare system to deal with the aging population. And she's very sensitive to the ethics involved in such research. I know that I just would in the time.
Sensitive.
Thank you very much for coming and joining our program. Please take over, Professor Sherrill.
Thank you very much. Yes, Robin, in those days I had a long ponytail and it wasn't as gray as now. I hope you can hear me. I'm actually in the middle of a vaccination center. We have a blitz this weekend for the over 60 population, which we are in fact running up here at the Mona Center. So it's a bit noisy around me. But I was committed to this. And as Robin says, I feel very strongly about postgrad training. So a lot of what I would have said was in Professor Dan's presentation, because we are one university, we therefore all programs cooperate, and when we introduce a program, it is usually universal across the 4 sites. However, I'm going to ask my assistant here, because I'm of the age group that is not technologically savvy. So I'm going to ask for help here to bring up the PowerPoint.
One of the things about our age group is we are not shy to ask for help.
Not at all. Not at all. Yeah, I'm trying to share and we're having, they are having, I'm not, I'm sitting watching. Are you seeing it now?
Yes, we are. Yep. So just pull up on the presentation mode. Wonderful.
Thank you very much. And I hope it's not too noisy. I apologize, but I don't really apologize, because yesterday we did 300 and odd seniors and we have now started doing academics. So we did 156 UE people. Today I'm supposed to do 700. Let's see what happens. So I'm going to talk about the Mona experience, stressing that much of what has been said would apply to us as well. We do common exams. I think one of the things that's important is that the DM exam is a common exam that is sat on all campuses at the same time. So curricula, etc., are similar. So my outline is, what are the considerations, what are the programs, and some of the requirements. As has been said previously, we do run the DM program and we do have 23 DMs, the most recent being dermatology. Interestingly enough, the DM program started from surgery, because surgery introduced individual departments and individual programs right from the beginning in 1967, which is when the DMs started at Mona. They weren't called DMs at that time. And interestingly, again, the DMs in surgery and the DMs in O&G were one DM, O&G at the time being considered a surgical specialty, until they went onto their own. So you actually had common courses and exams. Medicine in recent times has gone between the fellowships, which are below. So you have a number of fellowships and actual DMs. So the latest DM is in dermatology, and they chose to go the DM route rather than fellowship. But I have to start with where my heart is, and which I think is part of every program, DMs or not.
I therefore start with the Masters in Public Health, which is now 35, 36 years old. And we now have 4 tracks within the Masters of Public Health. Many of our DM students, particularly in psychiatry and in pediatrics, do the Masters in Public Health, which can be done in 1 year during the elective year. So you have a number of DMs that also have a public health degree. We have found a way for persons to be able to register for the public health while remaining in their DM program, which is critical because you want the night duties and you want the benefits of a good income, and especially as the public health is one of the self-financing, therefore there is a cost. There are 3 other master's programs which DM persons find beneficial, is the right word. They're run out of what was the TMRI unit, now called CARE. Increasingly, persons in the DM programs who see themselves as future academics are doing the MSc in epidemiology to prepare them for the rigors of that academic writing. But many clinical people are not, when you enter clinical teaching, I don't think all of us at the time that we enter when we're young and going to save the world recognize that we're also going to have to start off immediately writing 3 papers, 6 papers, whatever. So persons who are being mentored towards the academic life are being encouraged to do that MSc. We have started, postgraduate diplomas used to be common when we started the DMs. The part 1 used to in fact be a diploma, and we see the legacy of that in family medicine. However, in recent times, we have started to reintroduce them. The clinical geriatrics was introduced, a diploma, postgraduate diploma in clinical geriatrics was introduced this January. We do have a participant from the Bahamas, very active participant. And only last week, I saw the advertisement for the diploma in accident and emergency, geared towards people who don't want a career in A&E, but in their jobs, whether rural areas, will have to deal with it. You have been given a list of the DMs by Professor Dan, covering most specialties, and the same here. And as I said, the new one, which is dermatology. Fellowship training started about 5-6 years ago, no, maybe a little more, because it was before I went to grad studies. So it started probably 9 years ago. When the US tightened up on the Caribbean after 9/11, and persons were not able to go as easily and practice up there, starting with renal, not surprisingly given the diabetes, etc. in the Caribbean, they started the fellowship in renal. That has been followed by neonatology, obstetrics, there's one in maternal. There are actually now 9 fellowship programs. Not all are active. The child and adolescent psychiatry is not active. And as said in the previous, the cardiology is in Trinidad. At Mona, we also promote with our clinical candidates the research degrees, again an option for persons choosing academia. And after part 1, you can use the research that you're doing, not only for your part 2 exam, but to set the foundation for a PhD. Again, if some people are interested in research, but others want an academic career. The degrees that have lent themselves to this are pathology and microbiology. There are also research degrees in public health as well. More recently, we are being asked, and it has been approved, we have not yet had the first candidate, the combination degrees, which include an MBA. So the persons interested in this, interestingly, are the surgeons that expect to be running the hospitals and therefore have to understand their finances. And I expect to see more persons doing the combination degrees, whether a DM, MBA, I think that's the one that's going to be the one to take off. When I was director of grad studies, I was often asked by persons, got asked only yesterday right here in the Blitz Center, how do you decide which postgraduate qualification do you want to do, and which, how do you do it? And I think the previous speakers have really answered that question. But I think what I say to persons asking me this, where would you like to see yourself in 10 years' time? And what have you enjoyed and see yourself spending your life doing? Yes, money, earning money, living comfortably is important. But once you choose your postgrad specialty, as I did now, 41 years ago, and I knew from the start I was going into public health. I think people, Robin and them, will remember that I did not like night duty. And if I was not in bed at night, it had to be by choice. And I knew then that I was going to do public health. I also saw public health as community-based and being able to make a contribution to prevention. So I think you need to be, I knew I couldn't do pediatrics because I knew I couldn't do children. So I think that as you decide on this, you need to be honest. When you are 40 or 50 and you've set up your family, you've set up your life, you have to spend the next 30 years doing what you're doing. So you need to think about that when you are making your decision. Of course, what is available? Geriatrics was not available when I chose geriatrics, which was alongside public health in '83. And I was offered a fellowship. I went to the States for the first couple of months of the fellowship, and I decided that I couldn't do it there because we didn't have MRIs in Jamaica at the time, and everybody who came in had to have an MRI. And I said to them, well, let me go back home, let me do short courses, you bring me up here from time to time, and we develop a geriatric program that is suitable to the people in the country in which I work and the country which I knew I was going to stay working. But as has been said before by several speakers, what is affordable and what are the funding opportunities will also help you decide what you want to do. Much of this is the same, and I know we're running behind time. So Caribbean, we're one region, CARICOM rules apply. So I think if you're going to study a clinical program at Mona, you need to investigate the entrance requirements of the program. Because we are now graduating somewhere in the region of 250, 270 doctors each year, and the consultant posts in the public sector have not been increased since we started the DMs, as I said, back in the late 60s. Jobs and spaces are still what they were. Therefore, increasingly interviews are being held. Also, our experience with the DMs and the performance of the residents over the years has led us to recognize that some of the things I said on the earlier slide, commitment, interest, are sometimes much more important than your academic track record, because you can have somebody that will get into a DM based on their academic who really isn't committed to that or doesn't really want to do it. So are you qualified to register with the local medical council? All UE graduates are. However, I'm not sure about the others, but Jamaica has had a number of programs of scholarships over the years. Hungary, Cuba, and Russia, I think, are the ones that jump to mind. Such persons are required to do the local CAMC exam, and they may even have to do an internship. So you need to find out, are you qualified? It is a requirement of any clinical program that you be registered with the medical council in the country. The immigration requirements were spoken to. All it requires is your acceptance letter, and then UWI will assist. If you are accepted directly to a MONA DM, you will have a job because the acceptances are based on an available post. In fact, you will get a temporary or provisional offer at first, and then you will get your confirmed offer once the hospital has confirmed that there is a post. Increasingly, governments are sponsoring people, and hospitals love this because they get an extra pair of hands. Therefore, governments pay the salary, but you become an honorary resident and you will get the allowances. More and more, some of the programs, family medicine, the clinical geriatrics, all have online components, but because it's a clinical program, there has to be a clinical component, and therefore, yes, you have to have a post. So I think that brings me to the end of what I wanted to say and to allow for some discussion. And I don't know how to stop sharing, and oh, I see it. And they've left me. You see, they've left me now. Okay, I'm out.
Yes, thank you, Denise. That was an excellent overview. And as I say, we are home. So I almost feel as if we're trying to say, please come on inside. So do you have any questions? I'm looking to see if there's anyone. I see Ariel Knowles. Would you like to ask your questions? Your hand is up.
Good afternoon, everyone. Thank you for this opportunity to get more information on postgraduate training. Who was the contact person for the UWI MONA dermatology program? Previous attempts to get in contact with Dr. Jonathan Ho have proven to be unsuccessful. Just like to know how to go about getting more information about pursuing dermatology at UWI MONA. Thank you.
If you are having problems, as you obviously are, I shouldn't say if, since you're having problems getting Dr. Ho, I would suggest you write to Professor Minerva Fame, who is the Director of Graduate Studies, and ask her to put you in touch with the relevant people.
All right, thank you very much.
Not any questions. Thank you. Our session was very much in time. We just happened to be a little bit behind time, but I think it's going very smooth. I think we can catch up and be well within our limits. So thank you, Dr. Thank you, Denise. I hope you get your 700. We are looking forward to continuing with our vaccinations in the Bahamas. We are behind you, but we are trying our best. I think at this point in time, I just want to, for our colleagues, we mourn the passing of our dear friend, Dr. Fong Chong, a couple of days ago in our class and in the Bahamas. So that was unfortunate. So thank you all so far. So we'll move on to the last section in the program. And one of the things we always want to bear in mind that we sometimes tend to think that everything good comes from up north. Well, you know, increasingly we're beginning to find that there are some very good things down south. I always have very important that we include training and opportunities from our graduates who have traveled in that direction. And so I'm very pleased that we have Dr. Springard, one of our lecturers, who is going to do that section. Dr. Sinkwi made it clear to me she felt that I was very biased that everyone on this section. Indian vaccines too, which is better than all the other vaccines. Always.
Sorry, 1 second, Dr. Roberts. Can you unmute yourself?
Sorry about that. Yes, it's good if you didn't hear me then. I just wanted to say that most of the times we tend to look up north, and there are times when we begin to realize that there are equally great things down south. And so I felt that this section of the program was very much needed, and to share the experiences of some of our graduates who have gone down south, and they felt that they did get the experiences that they wanted to have. And so I'm very pleased that we added this section, and I will let Dr. Shrinkard, our lecturer in surgery, take over. Dr. Shrinkard.
Thank you, Dr. Roberts.
Good morning still, everybody. Dr. Roberts took my initial statement and basically introduced that these rest of the speakers for the rest of the symposium have all chosen a different pathway, and they have all traveled south of the equator or to the far east, and shown that if you are motivated, that you can get to do whatever your end goal is, you can always reach there. I'm going to first, there's a slight change. I'm just going to let first Dr. Terrell Humes, who is a consultant general surgeon and bariatric surgeon at the Rand Memorial Hospital in Freeport, Bahamas, to go first. Dr. Humes, and the common thing with all of these presenters are that all of them were either are all UWI graduates, and they worked in the Department of Surgery. Some of them trained here and then moved on for other greener pastures. Dr. Humes graduated from Kingsway Academy in Nassau and has an undergraduate degree in chemistry from Fisk University. He then went on to finish his University of West Indies at St. Augustine campus and completed his MBBS in Nassau. And then he finished his general surgery DM in 2016. He further went and did his fellowship in bariatric surgery at Mohawk Bariatrics and Robotics in Indore, India, under Professors Matthias Phoebe and Mohit Bhandari between 2018 and 2019. He's currently setting up bariatric surgery in the Bahamas with the aim of starting a weight loss center. So we're going to hear from Dr. Humes first.
Fellowship in India. Hello, good day. I would like to thank Dr. Robin Roberts for allowing me to share my personal experience in Indore, where I did a one-year fellowship in minimally invasive bariatric surgery. I completed general surgery at the end of 2016. I was interested in bariatric surgery through residency and after rotating in Calgary, Canada, doing a bariatric and upper GI elective. Now, after my elective was done, I was offered a spot in Canada. However, it wouldn't have been available until 2019, 2020 due to the match. To further my interest, I attended a bariatric endoscopic workshop in Cleveland, Ohio. I was advised by my mentors, Dr. Francis and Dr. Shrikant, to expand my options and consider other countries other than US and Canada for fellowship placement. I looked at multiple countries, Australia, UK, Brazil, and I finally found a program in India. Now, all this was done virtually. I was impressed with the amount of cases they did and the workload being done at this center in India. Now, after learning more about Mohawk Bariatrics and Robotics, I was further impressed. They were voted best bariatric center in India for 4 years in a row. I went and learned about the directors and how prestigious they were and how respected in the bariatric community they were. The application was initially on the internet, and after passing their preliminary acceptance, I sent in my degrees and references. A Zoom interview was arranged with Dr. Malphoebe, and I was informed 2 weeks later that I was accepted. I believe that the number of cases that I would have been exposed to and the mentorship would have allowed me to commence a program right here at home. I'm not going to bore you with the data behind bariatric surgery. I just want to add that these procedures cause significant long-term loss of weight, recovery from diabetes, improvement in cardiovascular risk factors, and a total mortality reduction from 40 to 23%. The celebrities in these pictures were actually done by Dr. Malphoebe, the guy in the top left corner of your screen.
Now, about the admission process to Mohawk. The DM degree obtained from the University of the West Indies is highly recognized around the world and highly respected, so I had no problem with eligibility. As stated, the interview process was quite smooth and done via Zoom before COVID made Zoom very famous. I had registered with the Indian Medical Council, which was a smooth process as well. My previous degrees, MBBS, DM, made me a candidate to work basically anywhere in that state. The accommodations were on campus. A 2-bed, 2-bath apartment was given that I furnished, or semi-furnished. These were usually given to the professors who lectured at the medical school, dental school, or pharmacy on campus. It was definitely an experience of a lifetime. It allowed me to see Taj Mahal, the Burj Khalifa in Dubai. We traveled to Singapore, Kenya, and the UK. After which on the way home, I did a 1-day exposure at Advent Health with one of the bariatric surgeons that Dr. Phobie arranged. With COVID the way it is, not sure if travel will ever be the same. So yes, it was worth it. Here's one of my patients I did last year. She had a laparoscopic gastric bypass surgery, one of the first, if not the first one done in the Bahamas. And she's doing well, losing a lot of weight, still very healthy. Now, throughout the year, I was exposed to over 1,000 bariatric cases and multiple conferences around the world, Dubai, China, and Calcutta. I published 2 papers and co-authored 5 more and contributed to a chapter in a book that is yet to be published. Now, these cases range from initial, revisional, robotic, and endoscopic surgery. I was also exposed to some of the giants in the field of bariatric surgery, in the field of general surgery altogether. Like I said, we don't know whether travel will be the same. So some of the challenges, which were few. In order to get my correct visa, my passport had to be sent to the Indian consulate in Jamaica. All of our passports were sent and it just returned a little late, almost not in time for me to start my program on time. I also took my wife and 2 kids, a 4-year-old and a 7-year-old, for the experience for the whole year. So all 4 passports had to go to Jamaica for the visa. Traveling with a 4-year-old is not fun by any means, especially a 15-hour flight with stopovers in New York and Mumbai and Delhi. Needless to say, we were very tired when we reached our destination. And the next thing was the language barrier. Now, in the hospital, all the healthcare professionals spoke fluent English. However, most patients in the surrounding city, Hindi was their main language. Definitely had to learn a little to get around. But with the way technology is, it made it so much easier. The rideshare apps, the meal apps, shopping apps, all helped. And they were very user-friendly. Now, the hospital was very advanced. It had a Da Vinci robot in one of the operating rooms, which we had a lot of exposure to. The food in India was different from what we were used to. The different flavors and spices were definitely a high for the most part. I could also take the experience from being there for the whole year, traveling through India, traveling around the world, and the tutelage from the mentors and my peers. I can take that throughout my whole life. I could take it with me. So I can say that excellent surgical experience and training can be anywhere where there is the expertise and motivation. Now, if you have any more questions or comments or concerns, please don't hesitate to email me. I still have connections in indoor. If you want to know more about indoor and doing a program in India on the whole, please just shoot me an email. I'd like to thank you for your attention.
Thank you, Dr. Humes, for that excellent presentation. Dr. Humes is unfortunately not available for questions, but as he has given his contact information, he's more than available to give questions about it. As his experience bears out, volume is one thing that cannot be replicated in a lot of centers, which majority of these places in the southern and especially East China and India have. So another place that has a similar kind of volume is South Africa. Gonna invite Dr. Olu Tinubu, again, a proud MBBS graduate from UWI in 2006, who worked in the Department of Surgery at Princess Margaret Hospital to 2009. Then he joined the DM program, but then he decided to pursue a postgraduate training program in South Africa in 2009. And then he completed his residency in 2016, when he became the Royal College of South Africa's surgeon. Then has been working in the department. From that time, he came back and he's been working in the department. He was recently granted fellowship of the American College of Surgeons in 2020 and became a SAGES member. He has an interest in trauma, acute care surgery, and critical care, and takes a very active role in the Department of Surgery's teaching rounds. And he's recently become a tutor in surgery. So I'm really proud to invite Dr. Tinubu to share his experience of his training in South Africa. Dr. Tinubu.
Good afternoon. I want to thank Dr. Roberts and the School of Clinical Medicine to allow me this opportunity to present on postgraduate training in South Africa. I would first start off by mentioning the regulatory body in South Africa, which is the Colleges of Medicine of South Africa, or the CMSA. It describes itself as being the custodian of quality medical care in South Africa. And it's unique in the world in that its 28 constituent colleges represent all the disciplines of medicine and dentistry in South Africa under one roof. The CMSA in its final form was founded and financed in 1954, and there are two facilities in the Twin Cities of Johannesburg and Cape Town. And CMSA is the only route to specialization in South Africa. And the specialization in Africa, in contrast to other places, is actually called a fellowship. So once you complete postgraduate training or a residency, you're considered a fellow, and you are conferred fellowship in the relevant college. So in my case, I would be a fellow of the College of Surgeons of South Africa. The specialist qualifications, as I just mentioned, are called fellowships, and they're recognized throughout the world, particularly in the UK, Australasia, which is Australia, New Zealand, and Canada. And the CMA's key function is to act as the national examining body for medical professions in South Africa. Having all 28 constituent colleges under one roof, it allows for a uniform examining body, and all the constituent universities take the same exam at the same sitting at the same time. The Health Professions Council of South Africa is also instrumental in specialist registration and is regarded as the statutory regulator of healthcare professions in South Africa. And we'll get back to the CMSA and the HPSA in a little while. What are the entry requirements for postgraduate training? I think these are the basic entry requirements to most places outside of the US and maybe including the US. You must be a graduate of a recognized medical school. And I think South Africa recognizes the ECFMG list as their list that they go to. They want you to complete an internship year, and they prefer you to have at least 1 year post-internship experience. You also must have active registration in your home country with the medical council, and you must have a valid study visa, which is gained upon acceptance to the university in South Africa. There are 6 universities that offer postgraduate specialty training in South Africa. The University of the Witwatersrand, or WITS, where I attended, the University of Cape Town, or UCT, Stellenbosch University, University of KZN, University of Pretoria in the Free State, which is in Bloemfontein. The last 2 are Afrikaans-speaking only institutions, and I think as of about 2015, the University of Pretoria offers English and Afrikaans instruction, but as of the last time I checked, the University of the Free State in Bloemfontein was Afrikaans only. So if you want to study at those 2 universities, you have to be somewhat fluent in Afrikaans. What are the programs that are offered for postgraduate study for foreigners? You have anesthesia surgery, dermatology, emergency medicine, general surgery, and as you can see from the list, it's basically the 28 constituent colleges of the Colleges of Medicine South Africa. They each offer fellowship training for foreign medical graduates. To work in South Africa, the easiest route and the most direct route for a foreign medical graduate is to become a supernumerary registrar. They work in university-affiliated hospitals under supervision of the department heads. They are designated registrars, but agree to receive no remuneration from the university, the department, the hospital, or the Department of Health. So essentially, you're functioning as a South African, but you're not paid. What is the application process for a supernumerary registrar? You have to submit a paper or online application along with the supporting documents. You have to have endorsement from the Foreign Workforce Management Program, or the FWMP. You must have an application endorsed by the ECFMG, which is the EPIC, the Electronic Portfolio of International Credentials. The relevant applications mentioned in 1, 2, and 3 are then forwarded to the relevant head of the department to which you seek admission. And if the head of department approves it, he sends it to the hospital CEO. And the hospital CEO grants approval for a supernumerary post. Once you get this approval, the Faculty of Health Sciences actually takes over your application and submits for endorsement from the SWMP and the HPCSA. And only once the applicant is fully registered with the HPCSA can they commence duties with the relevant clinical department. The fine print. Most clinical departments only hire you as a medical officer initially. And the medical officer is actually the equivalent of an SHO in the Bahamas. You usually get a numbered training spot after you complete part 1, which is called the primary, and in some competitive specialties after you've completed the intermediate or the part 2. Straight off the bat, I think in general surgery, you can get in after you complete your primary, but other competitive specialties such as orthopedics, ENT, they usually take you after you've completed the intermediates only. And this also goes for South African graduates as well as international graduates. South African graduates, whether you be international or not, are required to pass a 3-part fellowship exam in their respective colleges within the CMSA. And during the training, one rotates through various hospitals and obtains a wealth of hands-on experience while rotating through different clinical rotations. For example, in general surgery, you have a junior and a senior rotation in trauma, general surgery, hepatobiliary, colorectal, and the list goes on. And thank you. And any questions, I'll be happy to answer.
Thank you, Dr. Tinubu, for that presentation. Now I'm going to invite Dr. Ricardo Hamilton, consultant surgeon from Australia. Dr. Hamilton was, and actually this is midnight for Dr. Hamilton, and I'm glad that he's still awake.
2 o'clock in the morning.
2 o'clock in the morning. Okay, great. So Ricardo was one of the first interns that I met when I came in here. He worked in the department, he completed his MBBS from UWI and then worked as an intern and then worked in the Department of Surgery. He worked with me in plastic surgery. And then suddenly he decided he was going to up himself from Bahamas and decided to go all the way to Australia. His journey matches similar to me in terms of that I came all the way from India to Bahamas, and he always used to ask me, what brought you here? And I guess something in that must have clicked in him and he decided to do. So I'm eager to listen to Ricardo and his travails and travels and his opportunities. Take away,
Great.
Dr. Hamilton.
Thanks, Ricardo. Can everyone see my screen? Because I'm not.
Yeah, we
my
can see.
screen?
We can see.
Okay, great. I'll just start. Good morning, all. Thanks to all to invite me to this talk. And as Shrikant said, it is now, 2 o'clock in the morning. So I hope I don't sound too groggy. So as the topic says, opportunities for postgraduate medical education going south. So for me, as you can see, I took that as a challenge and went as south as you can go. And I decided to leave my island home in the Bahamas, which is a relatively small island, to move to a much bigger island. But just to give you a perspective, Australia is not as small as people think. And if you can see it, it's actually superimposed over the United States. It's a very big island. Most people live on the coastal area. And as he said, there's a lot of dry land in between, but there's a lot of opportunity for regional training. But as you know, all of our big training hospitals are in our cities. So just to clear it up, I did my postgraduate training in South Africa. And as you can see, there's a picture of Dr. Knowles and myself. And then I came to Australia, returned to Australia, and I explained what that means. I did a few fellowships here, and then I went through the specialist assessment in Australia and eventually got the fellowship here. I show these pictures not to show my ugly face, but just to show you that one thing led to the next. One opportunity, and with one degree, was able to get another one, and then training opportunities open. My journey was very long. I left Nassau in 2003, and I went to Queensland to Gold Coast, which is quite a fair distance, as you can see. And a year there, and after working with a few South African doctors, at least my initial plan was to try to get onto the training program in Australia. One of the restrictions was, or still is that you had to be a permanent resident or a citizen of Australia. That was being debated at the time. And so I knew Australia had different parts in their training. And one of my advisors said to me that if I went either to the United Kingdom or to South Africa and got their part one, I would have been able to come back to Australia and pretty much halved a lot of my training. And so I got that bug in my ear, and I took my family from Nassau to Australia. And then the same family, where we added on when we were in Australia, we went all the way to Johannesburg. And what was planned to be just 6 months ended up being 5 years in Johannesburg. And then after that, I came back to Australia again for a planned 1 year, and I'm still there since. So my goal in 2003, a few things. I wanted to see the world, and I had trained, and I said train, I did my undergraduate degree in the United States, and I lived in the Caribbean, obviously. I wanted to see the world. The UK was my option. Australia was another option. I just decided I'm going to go as far and as wide and do something a bit different. But I had a strategy to it, and I wanted to go and train and learn in places that I can get 3 things from. I needed to have the volume, the variety, and the value. And by that, I mean, I needed to get my hands dirty, learn as much as I can, be as marketable and as skilled. But when I came back to the Bahamas, I needed to have a degree registered me as a specialist in the Bahamas. And I remember Dr. Sinkwe said to me, when you go, make sure you come back with a specialist degree in hand. So that was an advice that I always had at the back of my head. Why Australia for me back then? This was around about 2002, 2003, and I scoured all of the different websites. I saw that these, well, I call it the Big Seven, these colleges of surgery, they readily accepted training from the other countries, and they recognized or regarded their training to be on par with their own. And I've actually listed it there. I don't know what it is now, that number is probably bigger, but I called that in my head the Big Seven. So I said I wanted to train in one of these places, and obviously I could cross-train in either one and then go and do a fellowship in the other one, and ultimately come back with a solid degree in my hand to train in the Bahamas. And just to clarify, this is not a marker of worth. This is just a marker of people who have allied themselves together. For me, the golden ticket was my degree in UWI. I recognize, and I'll say that, I said it loud, because with my degree in UWI, at the time when I decided to go off, UWI was still able to get automatic registration in the GMC. And that's not because, and that has changed, but that was not because UWI has changed. That was because the start of Brexit. And hopefully once Brexit is going away, maybe this will come back. But at the time, only thing we needed with our UWI degree was to take this English exam, IELTS. So at the time, the British Council in Jamaica offered that exam. So a bunch of us organized it, and the British Council came to Nassau. We wrote the exam in Nassau, and just sending my UWI degree and results from that, I was able to get full registration with British GMC. And then I remember going to Birmingham, England, and I sat down with the interviewer from Australia, and initially said to me, Caribbean, we don't know what anyone from the Caribbean. And I said to him, but I'm fully GMC registered. And I remember the gentleman literally just pushed the paper aside and pulled out a map and said, okay, we have these 12 hospitals. And the conversation completely changed. I was then completely offered I could work anywhere. And then I was able to go, as I said before, I did a additional 1-year training in Australia. And that GMC registration also opened the door for me to get registration in South Africa. I put this slide up because of one of my mentors always says that successful people always look at where they want to be and then work backwards to ask themselves, how do I get to each of those steps? So there's one or two options. I want you to consider that when you have this degree in hand, have this specialist degree, when you go back to your country of choice, where you're going to live and you work, you need to ask yourself, okay, is this a degree that's going to get me registered as a specialist? And I put up this little slide here because this is pretty much how it works here. If you train in one of the Big Sevens, obviously those are the ones that most countries are familiar with, and obviously registration is a bit easier. I put brand familiars because in the Caribbean, UWI, India, Cuba, all those places you get great training. They may not be as familiar in places like Australia. And the other unfamiliars, yes, you may be able to get registration in, say, the Bahamas, but it'll be harder to get registration in Australia if you train in places that our college and our registration body is not familiar with. But with that in mind, you may be able to take the second option. When you've trained in whatever place, that might open the door for you to either train or have your training accepted by Australia or assessed by Australia. And eventually you may be able to either write the exam or be granted that fellowship from those one of those places. And then, as the previous speaker said, you'll be able to have different in hand. In terms of the access routes to Australia, there are 4 ways to get here. And I put them all down. And this not only just talks about people trying to get into general surgery training, but even if you want to do subspecialty training here. And that's either as an accredited trainee, an unaccredited trainee, again, as you want to do subspecialty fellowship, or you just want to attain what's called the Fellowship of the Royal Australasian College. This is a requirement for all groups. You will be entitled or be required to do an interview. It's Australia's far, so most of the interviews are done via the phone or even now virtually. And you need to sell yourself. The key part of selling yourself would be with your CV. That is your biggest sale pitch. And I'll actually speak to you and show the next slide what the sort of things that we look for on your CV. Most people will have a logbook. Logbook is very important. That's probably more so important if you come to Australia like a specialist like I did. You need to be assessed by Australia. That is absolutely important because that's what they use to determine if you are or your training has been on par with the Australian experience. This is how your CV has to look. This is the requirement we have in Australia, not only for those wanting to get on the surgical program, but for everyone who wants to work. And I'll quickly speak through some of these. The first thing, whatever jobs or rotations you do has to mean something. You need to do jobs that are hard. What I mean is, if you want to work in general surgery, you can't do, say, something that has nothing to do with general surgery. You need to pick those jobs, the trauma, the HPB, the ones that are hard, to show that they are weighted jobs. I often say to my trainees here, even the ones who are not on training programs yet, unless you are doing community service or humanitarian work, service jobs are a waste of your time. Initially, you need to choose a job. And you must say to the people who you're going to work for, I need a piece of paper from you. And that piece of paper is not money. The piece of paper you need to look for, I need to get a higher degree, I need to get publications from you, or I want you to put your recommendation down on paper for me. That's what you need to get, because that's the only way you're going to advance your career. Just working and sitting down and not advancing your career is a waste of time. Those are sorts of things when you do after you have your degree, then you can decide to work anywhere. But you must be focused on how am I going to advance my career? Everything I do, time is money. In terms, not money, but my time is actually need to be dedicated towards being publication in the Australian environment is absolutely necessary. You need lots of public. By lots, I mean a minimum of 5. You don't have to have some grand, level 1 multi randomized trial, but anything you publish will be counted towards you. But it is a must. You must have done presentation. In terms of higher degrees, in the Australian environment, if you don't have a master's degree, you're wasting your time. Even everyone else has one. And so that's something that we value quite highly. Teaching experience, people often write on their application, oh, I've done ward rounds. Everyone does ward rounds. So that does not count. By teaching experience, I mean, you need to have a formalized teaching position. So when you work at UWI or whatever else, you go to them and knock on the door, say, appoint me as a tutor, appoint me as a junior lecturer, conjoint lecturer, call it whatever you may, but I need to have an experienced teaching position. Community service, same way. You need to go out and do something and have it documented. Leadership positions and your references, as I mentioned before. So I'll start with the 4th group. If you are a qualified surgeon looking to come to Australia to obtain the fellowship of the Royal Australasian College, these are the things you need. And this is the pathway that I took, I qualified in South Africa and I had my FCSA in hand. And I needed to sit down with the college. I'd worked here a few years, and after decided my family and I were going to stay here, the college needed to assess everything about my prior training. And then the college then makes a decision, and you are one of the 4 things. The first one, they call you either fully comparable, and unless you have been working in the field forever and you're world-renowned, no one gets that. Who've been there forever. I got the second one, substantially comparable, having trained in one of what I call them the big 7. Did 1 year, well, actually 18 months of oversight, did not need to rewrite the exam here because I had trained in one of those big 7. The other ones from the grand unknowns, where the college is not so familiar with them, same thing. You can do 2 years of supervision, and you can write the college exam. And I want to point out, you can actually do your fellowship. So if you have done general surgery and you want to come here and do HPB, that time in HPB counts towards this. So at the end of your HPB experience, you can then also, through this, get the fellowship at the Royal Australasian College. Unfortunately, there are some people who the college assessed that is not comparable, and they are being required to do their entire training again if they want to work. For those who already, again, as qualified specialists and you want to do a subspecialty fellowship here, this is you at the middle, and I put it like that because all of these things need to happen at the same time. You need to find a job, and there are different ways of finding it. You go through a recruitment agency, as I did initially when I came here. All of these jobs are eyes on our national websites, and probably the easiest way is networks. People who know people, people like myself who know people, and jobs coming up. Obviously, our college has to endorse it. You have to prove that you can speak English. Yes, in the Bahamas, I only speak English, but I had to prove that I can speak English. I was required to show them my past results from the IELTS. But the good thing was, because I had done a degree in the United States and South Africa, I proved to them that I could speak English, and I got exemptions from needing that. But if you do that route, you'll only get a limited registration in Australia to work in your hospital along with your trainees. So that includes private hospitals also. And like everyone else said, your credentials must be validated by the ECFM. The second group, if you are an unaccredited trainee, this is meaning that you come here as an intern, you see SRMO or the career medical officer. This is not geared towards getting the fellowship. In other words, this is not geared towards getting a specialist degree. It'll give you training, great hands-on, what you do during that time. And this is the time where you will use the work to get your research paper up, to get your hands dirty. But remember, those things are purposeful. You're not just doing service jobs, you're doing jobs to do things to beef up your own personal experience, but to make your CV more competitive. Same thing applies. The only thing that's different, Australia and New Zealand, even though we share a similar college in terms of surgery, our registration processes are different. Most people, well, if you work in Australia, you have to go through the AMC, and if you go through Australia, to New Zealand, sorry, you have to go through their NZREX program. There is a written and a clinical exam, but here's the thing. If I had to do it all over again, I now realize the value of the USMLE, because even if you don't plan to go to the United States, USMLE will allow you to be registered in most countries. In Australia, it wouldn't give you full registration, but at least it'll exempt you from the written part of our registration exam. The clinical exam, as you would mention, is only done here in Australia, so you then have to travel. But once that is done, you will get full registration in Australia and New Zealand. To that first group, those who want to do accredited training in Australia, the great thing about that, you are then called a SET trainee, or a surgical education trainee. You are then able to, and probably will be required to, train in both Australia and New Zealand. Again, things are similar, but the application is through the college, and it's very competitive. And things you would need here: your CV, your higher degree, your research and prerequisite courses. Training is 5 years. There is an exam at the end of it. There is a research that you must do. But here's the catch, which may be a bit of a sticking point. You have to then be fully registered or general registration in Australia or New Zealand. If you are able to work in any state or any part of Australasia. But to get onto the program, you must be either a citizen or a permanent resident of Australia. That's not as hard as it seems, because the permanent resident visa, which is a bit of tweaking to do, and I can speak to people offline about that, but that's pretty much just a visa that allows you to stay in Australia for as long as you want, provided that you don't leave the country for more than 5 years, else that'll be wrong. So my highs and lows of journeying down to Australia, the highs are, well, compared to South Africa, after spending 5 years there unpaid, it was a joy to come to Australia and actually have a paid training job. Your spouse can come along with you and they work on your visa. The other thing, not only specific to Australia, but just leaving the Bahamas at all, you become an ambassador for your country. That's one of the things I realized. I was the first one to go to South Africa and the first one to come here. And I realized if I did well, they would say, oh, good on you, Ricardo, and et cetera else. But had I done badly, they would have said, you know what? All those Caribbean people, we don't want none of them back. So I had to make sure that I worked hard, but at the same time worked even harder, not only to show myself to kind of be considered as equal, not better, but equal with the people who I'm working with, but I needed to set a standard so that people after me would have it easier to come by. The process here is very transparent. Everything, it's equal opportunity. Doesn't matter where you come from. You just need to make sure that these things are put in place. You have to have general registration. And of course, Australia's standards are similar to the United Kingdom and to the US, Canada, whereas you have to train from certain medical schools and et cetera, and to meet their registration requirements. Australia is very focused on work-life balance. Of course, surgeons tend not to abide by that, but when I first came here, it was a bit of a come down, having working 100 hours in Nassau, and then coming here and being told you will only work 4 to 5 days a week. Go out and do something for the next 2 days. It was great because then I got time to spend with my family. In terms of the lows, Australia is far. It is on the other side of God back, as we say back in Nassau, and it's far from families. And oftentimes it's not as easy if things happen to get back home. The Australians love paper. There's a heap and stack of paperwork that you have to do, but once it's done, things run rather smoothly. Australia is an island, and they think like such. They isolate everyone. So I think not just from an academic point of view, but if you want to work in Australia in a health environment, there are very strict health requirements for you, more so you, not your family, but there are those translate into visa things you need to have. So in concluding, just everyone has said things, and I think there are lots to learn from it, but I can wrap up the things that I've learned. Your work ethic defines you. By that I mean, people see how you work. I learned a lot of that work ethic in Nassau, and I must say, I remember working with all of the doctors there, and that was a good training ground, because when I went to Australia, I went to South Africa, all those different places, I didn't stand out just because I did research and all those things. I stood up because despite not getting paid in one place and despite being the foreign guy, I was working, to me, seeming harder than everyone else, which was just the normal PMH working thing. And people noticed that, then opportunities open up. The second thing is be prepared to move anywhere. In Australia, I was in Nassau, there was an opportunity to go in Australia. I took it. It was a leap of faith, crazy me. I took my whole family and dragged them along with me. Working in Australia initially in 2003, and someone told me, oh, you can work in the trauma center in South Africa. And I applied to the guy who happened to then be the head of the trauma department. And he said, come along. And again, grabbed my family and we went along. And so you need to be able to just willing to go to places where your training will be available. But keep in mind, value, volume, and variety. No service jobs. It has to be something that's going to advance your career. The third thing I said, prove that your passport works. I mean, I said it because you know how hard I've been trying to tell my family, your passport is valid for more than just Miami. Go elsewhere. Be that North America, wherever else. As long as you're getting those things that are going to make you a more skilled surgeon, and you have a degree at the end of it that is of value, you need to just jump at those things. And there's an old South African proverb that says, traveling helps you to see. And by that, I mean, I think everybody, no matter whether you end up in the Bahamas or not, I think everyone at some point in the medical career, and I've said this through all my medical students, I think everyone needs to spend at least 6 months of their surgical and medical career outside of the country where you plan. Because you see things differently. See things that you can bring back home. See things that you can change from home. See things people do elsewhere. You know what, I'll never do that. But I think then you learn the value of what medicine is as a global experience. And that's it. Thank you.
Thank you, Dr. Hamilton. I mean, the last statement that you say, you be passionate about it. I always have your passion. Me, Monroe, we get crazy emails and WhatsApp messages from you in the middle of the night. You suddenly think of something and you say, why can't we do this at PMH? And it's been an enlightening journey of yours. And you've been really a pioneer. You opened the door of South Africa for not only for yourself, but for a lot of other graduates. You know, Dr. Shani Knowles, Dr. Edison Thompson, Dr. Anna Green, ophthalmology, Dr. Pinto, Dr. Tinubu. I can go on and on. So thank you for that. And thank you for your passion that you always still have. It just feels like yesterday that you were talking. So thank you. I'm going to invite our next and the last speaker. Now, we always say that save the best for the last. Dr. Alfred Dawes, one of my favorite surgeons who came to Nassau to start his training. Now, he took a different approach. He's a Jamaican, and he finished his MBBS training in Jamaica, started working there, but for whatever reason, he chose an opportunity to come to Nassau, and he started training here in Nassau as in the DM program. He's actually our first DM graduate, even though he went back for his final year training to Mona to complete. It was because as his lecturer at that time, I had the initial trepidation of seeing through my first graduate, DM graduate. So I made him go back to Mona so that those people in Mona see what he was trained here for the first 4 years. He's done that. And subsequently, he chose another option of going south, this time southwest, which is going down to Brazil for furthering his training in bariatric surgery. And then he came back and set up and became a senior medical officer at one of the local hospitals in Jamaica. And then he also became a member of the American College of Surgeons, and presently is the medical director of his private practice. He is huge on media. For practitioners who are setting up his practice should actually have a talk with him how to promote yourselves, which is an American thing, but he's doing that successfully in the Caribbean. With that few statements, Dr. Dawes, we welcome you.
Thank you, Dr. Shrikant. You left out a lot of the details about the fights we used to have, at least it being one-sided, where you were really going to town on me when I wasn't pulling my own weight in the surgical program in Nassau, but it's all good. I appreciate you and the team for that. All right, so today I want to speak a little bit about fellowship in Brazil. This is not one of the areas that you would hear about normally when you consider going overseas. It's always north that you end up, and I'm really happy that you guys included this presentation where the Southerners can have a say as well as to our experience. So that's a brief background on the Federated Republic of Brazil. It has a population of about 205 million people spread over a large area. It's quite an expansive country. Most of the towns and cities are along the coastline, though, because of the history of Portuguese colonial settlements. They were a major seafaring nation in terms of trade, and a lot of the population were settled along the south with the plantations and mines on the inside. The main language is Portuguese. There are what we would call one of the almost developed countries, the BRIC nations, and their population really is concentrated in the major urban areas. Sao Paulo, one of the largest cities in the world, Rio de Janeiro, from Carnival. I was more in the south, in Curitiba. It's not one of the cities that you would hear about a lot. It's quiet, has a population of about 2.5 million people. It's cold, there are not a lot of beaches, so there are very little distractions when you go down there to study. The life expectancy is 74 years, which is similar to what we're seeing in the Caribbean. And they spend about $87.3 billion US on healthcare. Now, their expenditure, as healthcare expenditures related to GDP, has actually been falling over time. And it's actually one of the things why you can consider Brazil in that it has a similar resource setting. One of the things that drew me to Brazil, it was actually just looking out to somewhere to do an elective after one of the battles with Dr. Shrikant. And I looked at India, I looked at Brazil, and I said, let me go somewhere different and closer to home. So myself and Lauren Charles, who is a consultant in gynecology, we set off for a 5-week course. Lauren ended up spending a few months after I came back. But what had really sold me at that time during that elective was the experience of the surgeons. Not only were we seeing huge volumes, I mean, sometimes we would be doing 10, 11 bariatric cases in one day, and this is one surgeon. So there was a lot of experience in terms of the patients in the public sector as well as the private sector. The other thing that really drew me to going back for a fellowship was the techniques that was there. No, there was not a lot of technology in terms of the robots and staples, etc. So there was a lot of hand sewing going on. Simple things like with hernia repairs, it wasn't the tacks, it was learning how to sew these meshes in with the tip and the tap. So these were, I think, transplantable techniques to lower resource settings, as in the Caribbean. So I figured that it would be good to learn from these persons who had mastered these technical aspects rather than going for a reliance on the technologies with the glues, tacks, and staplers. The wide training background of the surgeons who I was exposed to was also impressive. It was a nice mix of persons who trained in Europe, as well as those who were coming back from North America, as well as the homegrown surgeons. So there was a lot of cross-fertilization. There were those who had the European approach to disease management and control and their surgical skills, and that often spawned lively debates with the North American trained surgeons. But at the end of the day, the system was a nice hybrid of European medicine and North American medicine. And I think that, because we have such a dogmatic approach to surgery, depending on what continent you're loyal to, this was a pretty good way to get exposed to different viewpoints and accept best practices from either sides of the Atlantic in this bipolar world. So I'd mentioned the resource settings, and just to explain a little bit more into that, the Brazilian healthcare system is one of the better healthcare systems in the world, in spite of criticisms, because there's a universal health coverage through the SUS, the Systemic Universal de Saúde, which is your universal healthcare system. This is a government system that allows public access for most of your surgical procedures and general healthcare. Now, the government insurance not only covers the public hospitals, but there's also an overlap with the private hospitals where they pay to the private hospitals and doctors to perform patients from the public system. What that allows is that the volumes in the public hospitals and the private hospitals are very high. They have to do this for economic reasons. Of course, you have to make some money by doing large volumes of surgery. So a gallbladder surgery might cost $1,000 if it's a SUS patient. So you have to make sure that you're doing at least 10, 15 a week in order to be competitive. Then there's also private insurance, which covers public hospitals as well as private hospitals. Of course, that would offer better coverage in terms of the co-payment required, and because of that, most persons would go to their private hospitals. There's pretty good insurance coverage, and that explains why you would be getting a lot of volume, because almost everybody can access surgical care. Being that SUS is such low paying, you cannot depend a lot on technologies, hence why they have to do these surgeries in a resource poor setting, and hence the reliance on technical skills, fast track surgery, and other means of decreasing costs, which I believe are what we need in the Caribbean. So it is because of that hybrid system why I think that I was able to get so much exposure in techniques that are transplantable to the Caribbean. My training fellowship program, the the elective as well as the fellowship was done through LapSurge at that time, International Institute of Endoscopic Surgery in Curitiba. They operated out of a private hospital as well as the government hospitals, because the different surgical teams would move from private hospitals to government hospitals, several of the private facilities all around the city. So we'll be moving from theater to theater, and it would be a lot of cases being done in different facilities, but it will be the similar groups of surgeons. They work with the IGPA groups and Positivo University. The chairman, James Skinowski, Professor Skinowski is one of the senior departmental professors in Positivo University, and he has quite an international following in terms of his books. He has done a lot of translations of English surgical texts into Portuguese. So he's widely respected, and he has quite a team surrounding him. The other person I worked with a lot was Dr. Alcides Branco. He's not an academic, but an exceptional surgeon. As Lauren had said, he was, at that time, Ronaldinho was the best footballer around. Charles was saying he was a Ronaldinho of surgery, and quite rightly so. His technical expertise, I am yet to see another surgeon come close to what he's capable of. So the fellowship program at that time lasted 4 weeks to 1 year, and there are options: gynecology, urology, laparoscopic surgery, and in particular bariatrics. So bariatrics was done open and laparoscopic. In the public sector, it was done open. So I was privileged to be able to see a lot of open bariatric procedures, which is something that we don't see a lot of with laparoscopic surgeries. As a matter of fact, it has reached the stage now where a lot of the procedures in the US, I understand, they call in the trauma surgeons to expose for the laparoscopic surgeons should they need to convert. So I thought that was a pretty good thing to get the open as well as laparoscopic experience in the bariatric. So just in case you need to convert. There was an associated cost with doing the fellowship. It is not a paid fellowship. You actually go in and pay them for the privilege of working alongside them. And depending on the course, what you're doing, then that would vary, as well as a personal relationship. At that time, they were really getting started. But now that has really evolved into a worldwide network of surgeons, the HTC Surgical Society, that has members from right across the globe, forming a network where they share ideas, they share fellowship experiences. And right now, how it is set up, you can actually pay a membership fee of, I think, $50 per year. And with that, you can choose any one of the member surgeons who are all noted surgeons in their field to do a 15-day fellowship with them. Additional fellowships can be arranged all over. So it is a pretty good way to not just get exposed to surgery in Brazil, but to other areas where you, in Europe, Asia, Africa, South America, and there are some in North America as well, where you can get access to leading surgeons in the different fields. And they have actually evolved the LapSurge program into HTC Training Center, where they've actually been looking at acquiring a hospital and then to set up a surgical training center specifically for international graduates to come in. I lost some resolution with it, but they're actually offering courses now, so you can go down and learn bariatric surgery, suturing courses, hernias, colon surgery, etc. And all of these would be taught by master surgeons from across the world. I think Dr. Humes met one of the guys I trained with in India, Dr. Manuel Galvão. He is he flies all over the world conducting training sessions in endoscopic bariatric surgery, endoscopic suturing, etc. He's one of the faculty members in this club. So the big question is, was it worth it? I spent a little over 6 months there. I found that the transition to surgical practice in Jamaica was really good because it's not that I was heavily dependent on technique. I learned a lot of suturing. I got very comfortable with that. I was able to do hernias, total extraperitoneal mesh repairs without the use of a balloon dissector, using techniques where you do the dissection only with the instruments. Of course, without your glues, fibrin glues, and other hemostatic agents, you have to learn to manage bleeders, which are some of the major causes for conversion in laparoscopic surgery. So you learn how to control bleeders with suction, gauze, compression, and suturing. And these are that once you are comfortable with controlling bleeding laparoscopically, then it gives you a level of confidence. You're able to take on cases where other surgeons around you may not have the advanced laparoscopic skills to be able to assist. One of the things they also learn to do is how to help you to make your assistants better. So a lot of times when you'll be fighting with the cameras or you'll be fighting with the assistants, you learn exactly what the assistant needs to do, what the cameraman needs to do to make your life better. And these are some of the things that were pointed out explicitly rather than you concentrating on being a surgeon. So there are different steps in how you conduct your procedure, and a lot of emphasis was spent on having all the team members up to speed. So that inspired a lot of confidence in me, and that was a big part of the reason I was able to come out and pioneered a few advanced laparoscopic procedure in Jamaica and in the public health system where others were doing it in private already. Of course, the experiences in travel cannot be discounted. I was able to travel a bit in South America and throughout Brazil. It's an amazing country across several different climate zones. Everybody knows about Rio Carnival. It's something that once COVID is done, we really ought to be looking at expanding our horizons in terms of traveling and gaining new experiences. So not just the entertainment part of it, but the beauty of the landscape. And the people are amazing. It used to be a lot of jostling and rearranging of schedules to go to the feijoas and feijoadas, the different barbecues that they would be inviting you at their houses. They're very interested in Caribbean culture. They take every opportunity to try and practice their English with you. So you may have some difficulty trying to learn Portuguese because everybody in the hospitals, at least, and in the circle, the academic circle, they want to speak English. But of course, when you go outside, there is a language barrier. Do not think that because you know Spanish, you can know Portuguese. That was a mistake I made. But luckily enough, I was able to grasp quite a bit of Portuguese while I was down there. There are Caribbean students. They're from different countries. I found a lot of Jamaicans on that side. They are studying medicine, dentistry, engineering, various other social sciences. So there is a network of familiar faces that you can bond with, and they can help to take you around. But overall, a language barrier can be difficult if you are interacting with persons outside of the hospital. The other thing I found, which I probably think has been a little bit more structured now, is that you get out what you put in. So nobody's going to say these are the surgeries for today in this hospital, that hospital. You can pretty much decide if you're going to slack off, or you can put in as much effort as you want to go. And the other teams that are there are pretty much open. So I would be at one hospital and I see a colonic surgery going on, and you discuss, there's a different technique. That team is more than willing to have you in their room as well, sometimes scrubbing in. So it's pretty much what you want. You can get out of it. You can get to exposure to as many procedures as you want. So it takes some effort not to be overwhelmed with all of the opportunities that exist. Of course, the travel to get there, long haul flight, you'd have to go through to Sao Paulo, and then from Sao Paulo to Curitiba is another flight again. They don't have a very good taxi service. The bus system is pretty good, but you'd have to get familiar with that. And again, the language barrier is an issue. Knowing that you're not earning a salary at that time and you'd have to be paying into the fellowship, for the fellowship, you have to factor in your accommodation costs, which can be expensive for a good hotel room. They have short-term rentals at different price points, but that's some of that's something that you'd have to factor in if you're going without an income in terms of having enough saved up. The cost of the fellowship and courses, of course, will cut down with time as more persons get involved. But again, it's flexible. There are people that you can speak with to work out certain deals. So overall, I would strongly recommend exploring Brazil as an option for your fellowship training in surgery, especially in minimally invasive surgery, because of the advantages of practicing in a system that is close to what we work with in the Caribbean. So that's pretty much a bit of my experience, and I'm always available to lend more insight. My contact details are pretty easy to find, and Dr. Shrikant and Dr. Roberts as well are in contact. So thank you all, and I wish you all the best.
Thank you, Dr. Dawes. Anybody who wants to find Dr. Dawes just has to go on Instagram. He's constantly uploading his latest exploits, surgical exploits there. But it was a fantastic presentation by all the presenters, showing us different opportunities available. The floor is open for questions. Are there any questions? Anybody who wants a question can actually unmute themselves and ask a question. As we wait for the questions, one question I have, Dr. Dawes, and to Humes, but Humes is not there, so maybe I can answer that myself. But what are there opportunities for postgraduate training? I know we are talking about a lot of fellowship training, but would there be opportunities for postgraduate training? Would it be easy for one of our MBBS graduates to break into the Brazil system?
That would be very difficult, because how their system is set up, you would have to do their national certification exam, which is in Portuguese. So that immediately is a major barrier right there. Once you can pass the exams and do the training, though, you would be a member of the Brazilian Association of Surgeons, which is recognized on several continents. But the big deal breaker is doing that local exam.
Yeah. Similarly, Dr. Humes is not there, but I could probably say something about India. There are postgraduate trainings available, but the deal breaker is that there is a national entrance exam to sit for the postgraduates and then there are some seats that are reserved for foreign medical graduates, but it is pretty intense competition. And the exam is English based, so it's kind of available for Caribbean nationals or for Bahamian students. But again, remember that there are different levels of training, so research is very important in looking for India. Dr. Hamilton, what would be your experience in trying to get postgraduate training in South Africa? If somebody wants to get there straight after, because I hear this from a lot of my students, we are looking to South Africa. What is it that they need to do to be able to get to South Africa and get a residency spot in training?
Yeah. My experience in South Africa, in Australia, you have to apply to the college. In South Africa, I applied directly to the hospital. And so all of the selection is done by the hospital. South Africa is similar to the United States in that one university runs all of the training in one city. So in Johannesburg, even though when I left it was 7, it's probably like 9 or 10 training hospitals.
Yes.
That's all run under the umbrella of the University of the Witwatersrand. So you have to apply to the heads of department there. And as Olu said, An application is more of an invitation for us to come and assess you. So you are on the program, but then you go there and you work in, usually like the surgery, you work in the trauma department, and they watch you for 6 months. Take the exam, but they watch your work ethic. I said it because I worked with other people from other parts of the world who at the end of the 6 months was told to leave. Even though on the program, they said, well, you're not up to standard, not because you don't know, because you work as if you're here as a guest. So please leave. And South Africans are very blunt, and which I appreciate. And at the same time, if they think you've done well, you obviously go through the formal process. You interview with the university, and it's very structured. So thereafter, once I've written the first exam, I was able to get on. You know, the challenge is you have to go there, you have to work hard, but work purposely. You have to pass your exam. And I found it slightly easier. It's easier to get in, extremely hard to get out, because their exam, in my opinion, is one of the hardest ones to pass. It was a lot easier. The challenge is going there.
Okay. No, I asked you specifically the question because Dr. Tinubu went to South Africa, but he had a in-service award. And I know, but that doesn't change, right, Dr. Tinubu, that the expectations of you to succeed or how to succeed were still equally the same.
Yes.
Yeah, yes, it was. I mean, you are hired as a supernumerary, which means you don't get paid. And I have to give credit to Valron Grimes. Initially, the South Africans got a 90% discount when they went through the red strap or the postgraduate process. And she was successful in getting equity with the South Africans. So all foreign medical graduates going now pay 90% of the fees, pay 10% of the fees, and we're subsidized 90%. So that works out to be about $1,200 to $2,000 a year that you have to pay, when initially it was $6,000 to $8,000 that you had to pay. So that was a big deal at the time. So cost-wise, it's not that expensive, but there's still some costs associated with it.
All right. The one other question that I have for both of you from South Africa, no, I don't see other questions, is that, is the training equitable in all the hospitals?
You want to go, Olu?
Yeah, I'll jump in first. I would say yes. The universities, the 6 training universities, we all sit the same exam at the same venue. And certain universities and certain hospitals have certain strengths. So even within the system of the University of Witwatersrand, you were trained in a heavily service hospital like Baragwanath, where you have volume. Or you could have a hospital that has a lot of academics where the caseload is not so big, but the focus is on teaching rounds, et cetera, et cetera. Then you have a mix where you have the private hospitals, where you have the top of the technological spectrum. Then you also have rural hospitals where you function relatively independently as a trainee. So you have a wide spectrum of training opportunities at all the different institutions by going to the different types of hospitals.
Okay, thank you. I have one question for Dr. Dawes. Dr. Dawes, in the initial presentation, Dr. Roberts mentioned the number of postgraduate training programs that we have and the number of trainees we are training here. What has been your experience as a non-Bahamian, a Jamaican coming in here and training in Nassau, and then you went back for a year to Jamaica? So you have a unique experience in terms of your training. What would you tell to the students about training in Nassau? I mean, you not only did surgery, but you had good friends. You were very popular with all the other department colleagues. What would you say in general about the training that we offer in Nassau, as if somebody is considering all other options, but Nassau is something that they want to look at?
Well, I can say without any doubt at all that I was extremely lucky to have had my postgraduate training in Nassau. And I did not realize that until I came back to UWI in my chief resident year at Mona, when I realized how much competition you would have getting experience in the operating theater, as well as the attention of the consultants. when you are in a smaller hospital and you have access to consultants around you every day, and you learn from consultants rather than residents who have just finished an exam or completed a year, and that makes them senior to you. It is a world of a difference. And that is something I will always be grateful for, because it was consultants who taught me to cut. It was consultants who showed me exactly what to read, what is relevant. That was something different that I had seen in my time at KPH before I went to Nassau, as well as when I went back to UWI. And I think that made the world of a difference in my training. The other thing is that you are not bogged down with too much of the trauma that besets work at KPH, and you get more volume in terms of the procedures than at UWI. So it was a sweet spot for me. And the other departments were pretty much open, where I was able to go in on their procedures. So ENT, I could go in whenever they're doing their neck dissections, whenever they're doing their thyroids. And that helped a lot for me to be more comfortable in managing my own trauma surgery involving the neck, as well as thyroidectomies, something that a lot of newly minted general surgeons do not do. Gynae was always calling for assistance. I was always quick to go. I was encouraged to go. And again, that helped to be familiar with the pelvic anatomy. So overall, I would rate my experience at 9 out of 10, only because nothing is perfect. The life in Nassau as well, I had really great friends. I didn't experience any xenophobia. I know everybody's experience might be different, but I felt very welcome. And the entreaties to stay in Nassau actually made me consider it, relocating from Jamaica. And in fact, I did temporarily when I went to the RAND, where the welcome mat was really rolled out for me there as well. And we started to do some pretty good laparoscopic procedures there. We did the first VSG in that hospital. We did some adhesion lysis, colectomy, and so on. But overall, it was very welcoming. And the interest of the consultants is something I must always go back to, because that is a huge difference in Nassau compared to when I was where I am in Jamaica.
Thank you. I see no more questions. I have no more questions. I really want to thank everybody. I really want to thank Dr. Hamilton for staying up late, participating with us, all the speakers. Finally, I will turn it over to Dr. Robin Roberts, our director, to have a final say. I also want to plug in that all these sessions have been recorded and are available on the sunshinerlearner.com. The enrollment key is there, Educate. There is also a YouTube channel for us that these videos are available. And I'm pretty sure everybody has gotten lots of information. And also, we also have direct access to all these speakers for further inquiries and suggestions and help. Thank you. Dr. Roberts,
Thank
your
you.
final closing words.
Yeah, no, we have one final speaker whom I felt would be the wrap up for the session.
Oh, sorry.
And so we are a little behind schedule, but actually not that behind schedule. But I just really felt, looking at this agenda, that one thing was missing, and that was someone who has been through this on one end, trying to find his way through postgraduate training for Mona and the challenges that they had, and then was able to move up the ladder in his field as a neurosurgeon in Halifax, to head a department, to being recognized as the senior examiner in the Royal College in Canada, and one of the leading neurosurgeons, probably every accolade that could be earned in Canada with regards to neurosurgery. And I can definitely say he has been my mentor and my big brother. He was very instrumental in the success of our school. He took a year sabbatical to come when we needed a director, and we were looking when we first started. And he is also being a consultant in our system. And I would say that he has had a major hand in advancing the careers of and getting quite a number of us, including myself, in the postgraduate training, not only in the USA, but worldwide through his contacts. So when you talk about wanting to know someone who knows someone with influence and can get something done and can get you into somewhere, get a patient into somewhere, I couldn't think of anyone better to have give his final words, and one who is a true Caribbean man, despite all his years abroad. He has been one in the diaspora who has returned home and continued to make major contribution. And so I say without reservation, welcome home, brother. Professor Ren Holness. Ren?
All right, so you can hear me. I've had a major issue here this morning because you may hear outside there's rain pelting down and it's messed up the internet completely. So I've just got it back and heard part of the last talk, and I miss all the great talks before that. I hope that I can actually see these videos that Srinath referred to, because I'd love to have heard what went before, but I just have been unable to. It's a major problem here in Montego Bay. When it rains, the internet goes out, banking, everything. It's crazy. But I'm here now, so let's. I also like to say before I start, it's fantastic to see Ricardo after all these years. I knew that he had headed to different directions, and I'm so happy to see him after all this time. You know, I've been, as you know, I was really close to all the students at the Nassau campus when I was there. And I must say in reference to some of your remarks that there are 2 Jamaicans training in radiotherapy in South Africa at this time. Both are close to finishing. So I know for sure that they're getting excellent training, and they did comment that the exams are very difficult. So in keeping what you just said. So I'm going to give a talk which may or may not be relevant to what has gone before. So I'm sorry I haven't heard what went before, but at any rate, Robin promised me I'm going to have access to those videos. So can I bring up my talk? Yes. And let's see if I can share the screen now, because that's going to be a little problem here. Let's see, can I share screen?
Yes, you can. It's all up. It's all open to you.
Yeah, can you see my talk there?
Not yet. Yes, coming up now. Great.
All right. Is it the? Let's see.
You can hit present it to you now.
All right. Okay. I'm gonna do this. You can see that. Okay.
You're straight. Yeah. Move on. You're straight.
All right. So what I'm going to do is start off by saying that, well, who better to say this? And the reason why I put that up is that I went to a course recently on postgraduate training, and these are the factors influence a choice of specialty. And all of us have various degrees of these factors when we make our choice. But nothing here says about giving back. So to proceed then, I will say that the comments I'm making are relevant to the whole diaspora. And some of the islands have different methods than others and different processes, and more of their residents and may go to North America or Europe or other places, but still it's very, very similar. So there may be people listening who are not at the level of most of the speakers. So there may be students, postgraduates at different levels of their training, those waiting for a spot, those are post-residency. So my remarks may be taken by some of these folks. and for them to know that there are online resources available. The AMA and the CARMS Canadian give you all the information you want about the application and the statistics and the statistics related to foreign graduates, et cetera, et cetera. I strongly recommend both sites. So most of my remarks are going to be those planning to return home. I know there are people in the group who have attempted to themselves to us here in the Caribbean. There are major warning that my internet connection is unstable. I hope you can still hear me.
Red, what you might do is
I will give you some of my.
Why don't you just turn off your video?
What?
Turn off your video while you're speaking. That might help.
Oh, I see. Okay. So you mean you're not actually seeing me?
Yeah, so we don't need to see you. But that usually gives us a little free bandwidth. Not your talk, just the video to the bottom of the slide. The bottom of the slide.
I'm not seeing that choice on my Mac.
You should.
It's not giving me adaptive.
Okay, yes.
I'd have to hear me. I'll continue.
Okay.
I will disclaim that some people may be discouraged, but my intention is just to give you a dose of reality, because that's what there is here in the Caribbean, reality. No, just to repeat, if I click on the video, maybe I could turn it off. I could stop the video. Okay, I've stopped the video. Is that better? Okay. You can still hear me?
We can hear you.
You can hear me.
Continue. You're fine. Great.
Okay. All right, good. All right, so let's go back to this one. Oh boy. Let's see. I'm not used to this.
Okay, great.
All right, just to repeat, most residents that train in the Caribbean do a period of about 2 years abroad as part of their program. And some go via the European system still, but most, I'd say, do extra fellowships after residency. There's a major problem with funding that if you don't have a sponsor, I can tell you about Jamaica. If you get into a program and you're not sponsored by your region, you're not going to be trained. I have a candidate that came from Guyana who was in the program but was not sponsored, so he had to stop. He had no money. So a major problem is the whole system of getting by the region. If you're not sponsored, you can't be trained on the specialty, but many others do not. For instance, there's a limited number of consultant posts in neurosurgery at the moment. I can tell you, there are 3 graduates who don't have jobs. They are unemployed since their exam is over, and the university will not keep you on if you don't have a job. You have to leave at the end of your residency. So that's a major problem, overtraining and not enough sites that do your particular specialty. So what has happened is there are a group of young consultants who are out in private practice, beating the bushes. That is what has happened. If you're not a consultant when you come back, I think everybody here knows that. You join the ranks of post-BM, where you can do private practice, but you're essentially a senior resident awaiting a consultant post. This has certain benefits in that you can earn more money than the consultant by your call schedule, but you're still not a consultant. Whereas in Canada and the US, as soon as you finish your residency, you can be a consultant wherever. The other thing is that people are not aware that each of the hospital boards have this policy that jobs have to be advertised. Comes in, is made at an administrative level, quite often with very little input by the clinical service concerned. So it's not uncommon for, and my colleagues here will tell you, to arrive and find there's somebody working with you who was employed and you were never involved in the interview process. That is one of the things I understand is something that we've inherited from past years. Then finally, there's a disorganized manpower plan. They talk about manpower plummet, but the fact is in Jamaica, and I know in many other places, the Ministry of Health has complete control, despite what they talk about regionalization, where like in Montego Bay, we're a Western region, but everything related to our employment is controlled from Kingston. And I know it happens in other countries because I have a young colleague, a very excellent neurosurgeon trained in Cuba, who has been back home in St. Lucia for about 5 years, and he has been unable to get a government employment, yet he's doing neurosurgery. He has to do most of it privately. So this type of thing exists throughout the Caribbean. And unless there's some major revolution in how medicine is administered, it will continue. And it's the kind of thing that will turn off some of the young people who have gone away and done fellowships and want to come back and give. Certain specialty areas are lacking. This is not an all-inclusive list, but I can tell you, there are only 3 or 4 neurologists in Jamaica versus 22 or 25 neurosurgeons. There's no electrophysiology except one person does, like EMGs and EEGs, etc. Physiatry, physical medicine and rehab, only 1 qualified specialist in the country. There's minimum pain management expertise. Critical care, ICU, IMCU is a figment of our imagination, because what happens is that all of the severely ill patients are managed in the few ICUs by anesthetists, and the idea of being a critical care consultant depends totally on the availability of ICU beds. There is a great need for pathology and its subspecialty. I have a young fellow who spent his internship with me, an excellent fellow who is doing his pathology residency in the States. He wants to specialize in a sub-area of pathology, and he is in the process of trying to get back, and I am warning him that he has to apply for general pathology, otherwise he's not going to get the subspecialty appointment, although there's only one such person in the country. In my instance, I often have to wait for 6 weeks or longer for a pathology report. So it's very hard to plan treatment if you don't have the pathology right there. Psychiatry and all its subspecialties are sorely needed. Radiotherapy, we have 2 very good government units run by 2 very good guys from India, and hopefully we'll have some people back here, but I'm sure it's the same problem in other parts of the Caribbean. And just to point out, I'm particularly interested in pituitary surgery, and there is a dearth of endocrinologists. Primary care, which is so important, is not looked upon with great pleasure by a lot of the students, but the fact is one of the most important areas that needs to be enhanced for our particular rural areas to benefit. So you can see there is a wide range of needs that could be addressed as you train abroad, and I'm addressing everybody, not just the surgeons. Just to point out that in terms of Jamaica in comparison to the Caribbean, our disease pattern is very similar to North America and developed countries. As you see the ranking of the causes of most deaths, it's still cerebrovascular disease, diabetes, ischemic heart disease, chronic kidney disease. AIDS has gone way down because of the great work of the people like Professor Figueroa and the people in public health. But what causes most premature deaths is still the same group of diagnoses. And similarly, disability is a bit different, but a lot of low back and neck pain, a lot of effects of diabetes, migraine, musculoskeletal problems. Depression is common, and anxiety disorders. Look on that, I mean, and we have a lack of psychiatrists. And then finally, in death, diabetes, again, the same group. So our pattern of disease is very similar to North America. And if you look at the WHO projections, These are the 10 leading causes of disease burden in developed countries last year. And we are very similar, in fact, as you look down the list. In other words, if you train in North America or in Europe, you are well placed to come back home and give back in many ways. It's not going to be a big difference, except where maybe a slightly higher incidence of infective disorders. Now, neurological disorders are a major area. Now, what do we have available for all of these sick patients? Why is it, for instance, right now in Jamaica, our death rate of something like 40,000 positive COVID patients, we have lost over 600, whereas Cuba, with 12 million people, have only lost 400. And they are getting 1,000 new cases a day also. You know why? You don't have to guess why. We don't have IMCU, we don't have ICU. If you're really sick and you need an ICU, you're dead. And we just lost 15 patients yesterday and 16 the day before. So this is a problem I've been pointing out to the government for years. We do not have ICU beds, we don't have IMCU beds. If you look at the United Kingdom, we're way below there. We're as bad as sub-Saharan Africa. So that's a major problem for those of you who are going to depend on critical care in your practice. Trauma. Despite these signs, trauma continues to take away from the resources. And head injuries, as well as other injuries, continue to be a very common thing in this part of Jamaica. I think Dr. our colleague in surgery just spoke, will tell you that Savlamar produces quite a high volume of this trauma that comes to Montego Bay. So the crime trauma continues to bother us, and the guns, and all parts of the Caribbean are in the top murder rates, not just Jamaica. So that's another thing you have to if you're going to be here, you have to realize a lot of our resources go into trauma treatment, not much in trauma prevention. And we have similar problems to the rest of the developing world with a low per capita income, devaluation. When I came back here, it was 1 to 80. Now it's 1 to 145 JA to US. So you can imagine the poor people, how they suffer. Of course, with COVID, our tourism has declined as in most parts of the world. We continue to have an educational brain drain, particularly of nurses. And we have all kinds of technological advancements and all of that. But for the poor, the fast food, the theft, the larceny, all of these things make life very complicated when you are practicing in a public hospital setting. And so that's why a lot of young people opt to go out into private practice or go back to the first world. So these are the things you have to face as you decide to come home. And you have to realize that Jamaica's spending for health is really a small percentage of our GDP. There is a National Health Fund which was established, which helps with certain drugs for diabetes, etc. And their government makes a good effort to try and help the poor that way. But the fact is that our total health expenditure compared to the average is very low, and that goes throughout the Caribbean. So as a result, you have a patient in hospital who is a public patient, but he can't afford drugs. So somebody with a ruptured aneurysm that needs nimodipine, the family has to buy it. It's not available in the pharmacy. And that's just one example of what you have to put up with as you go through your daily day-to-day practice. And of course, the University Hospital and the University of West Indies with its beautiful medical school continues to be a very important area for us to refer patients. But the University Hospital is not a public hospital any longer. It's a private hospital. It is not uncommon for patients to come back from University Hospital with a $1 million Jamaica bill for being a public patient. So and the university is in serious financial trouble also, if you have been following the news. So it is really important for all of the general hospitals in the Caribbean, in Jamaica in particular, where I live, to be independent of Kingston if possible. And this is where help from people who train abroad and who can help us is going to be important as time goes on. There are private hospitals. There's an excellent one here in Montego Bay called Hospiten. There are a number of private hospitals in Kingston, the Cardiac Institute, Maxillofacial Center, and others in Savlamar, Ocho Rios, Negril. The fact is, though, if you don't have medical insurance and if you don't have moolah and you're poor, you have no access to these institutions. But it is a way in which we can give back by having some practice in private as well as to boost our public practice. But we are really not well developed as far as the private hospital setup is concerned, as we could be. The beaches and all that are lovely, but that doesn't take away from the everyday stress of practicing in an underfunded system. So just to give you a quick review of what happened to me, I was, my former colleague and good friend Ken Ball convinced me to come back, and Dr. Frey, who is to my right, was the SMO at the time, and the Minister of Health was very supportive. And so I was able to come back 11 years ago to start a service which didn't exist, and patients had to wait on Kingston for patients to be transported, head injuries, brain tumors, etc. Very similar in other specialties, but other specialties have developed well also. So what happened is that the Colonial Region was all well organized. And unfortunately, since then, as you may have heard, it collapsed. The hospital was victim of a sick building syndrome, and for the last 3 years, it's been closed, and the hospital has metastasized in multiple buildings surrounding the hospital, including containers. And all of the major surgery is done in Falmouth, 20 miles away, which has made things very complicated. In terms of the population of Jamaica, it's very similar to breakdown to other parts of the Caribbean. As you see, there is a population collection in various parts, and that is matched by the major hospitals, which are in the red dots, give us access to the public, access to medical care. Concentrating on neurosurgery as an example, here is where the problem in manpower planning is brought really to focus. So you have 3 neurosurgery centers. You have Montego Bay, which we established. You have Kingston, which is Mona, and KPH and Children's. And you can see from the breakdown here that there are a certain number of neurosurgeons per breakdown. And currently there are quite a few neurosurgery residents in training. The problem is at the end of their training, there is no plan as to where they're going to go. They're going to stay as residents. So what you'll find is a lot of people are looking to do fellowships abroad and possibly stay there because there's no movement here. And I think that we're not the only specialty that has that problem. So I would exhort people who want to come back to do a careful investigation of the situation before you commit yourself. In our case, for instance, I'm a neurosurgeon, and I'm seeing a lot of neurology because there are no neurologists, there are few neurologists. So here's the lady on your right, the lady with the thing on her eye. She has myasthenia gravis, which was been completely misdiagnosed for 6 months. I had to make the diagnosis. The lady on the right has motor neuron disease. There are no neurologists. There are not enough neurologists to serve the population. There's no planning. The radiology services are similar. There are some very advanced radiology services, but a lot of them are just private. So you can see where the main radiology services are there. And if you look at what's available, MRI, CT, angiogram, there's one private PET scan, one linear. There are now 2 linear accelerators, public and one private for radiotherapy. But here is where it's it's broken down. And if your specialty depends on radiology, you better believe that you're going to have a lot of the radiology going to be done privately. And unless the patient has medical insurance to pay $50,000 Jamaican for a MRI, you would take away 3 months' salary for the average poor person. So as a result, we have a lineup of people waiting for MRIs who have spinal disease. And the ones that can afford to get it done, the ones who can't have to wait. The government has a new program where you can get MRIs done through the government service, but it takes a while to arrange and multiple forms to be signed, and it becomes a real hassle. You have to be the patient advocate. If you are not prepared to be the patient advocate, there's no point coming back to Jamaica. We have a lack of interventional radiology, which is important in many fields. But luckily, we have somebody who was trained and is back, and another one who's coming back as well. And here is our major pediatric hospital for the whole country. No CT, no MRI in this institution. All the children have to go out to get their investigations. It just boggles my mind how that can be allowed to happen. But who makes those decisions? It's done through the Ministry of Health. And right now they're overwhelmed with COVID. The Sir John Golden Rehabilitation Center, which is the brainchild of Sir John Golden, who actually operated on my knee about 3 times, is a fantastic institution that does great work, but it's the only one. So if you have a patient that needs rehabilitation, they just have to wait in line. Despite all of this, I just give me a list of some of the things we're able to do as I came back. We're able to do most intracranial operations that had to previously be sent out. Tumors, pituitary tumors, trauma, which again dominates. This is just our initial operations that we did in the first part of 2010, and it expanded to 15 to 20 cases a month. The pattern is slightly different from North America in that luckily we don't get carotid stenosis or vestibular schwannomas. Those are rare, but the rest are common, just like anywhere else. And discitis and infectious disorders, very common. Intracerebral hemorrhages, in this particular case, one of the few that we can do something about in the cerebellum. So we're able to do this, but patients still come very late. Person on the lady here with growing meningiomas on both sides eventually expired without surgery because there's no ICU bed. A patient who came with a third nerve palsy, misdiagnosed, sent home, came in dead from a ruptured aneurysm, although we all learned in medical school that that's an aneurysm until proven otherwise. This kind of thing continues to happen. Massive meningiomas that present with blindness and headache, and others that present with metastasis. Very common to see malignant meningiomas. So we're able to do a lot of this, but it's still there's a long waiting list, no ICU bed. We can't get to do major cases until there's an ICU bed. Technology, we inherited an old microscope that was mainly for ophthalmology and ENT, and I was able to bring home a modern microscope from Halifax, which had been retired, but which is still in very good condition. This is Franz Spencer, who is one of the guys that I trained and spent a couple of years in Halifax as well. And this has opened up a completely new world for us over the last 10 years. We've been, without boasting, I can tell you what I've been able to do despite all of the frustrations. We're able to set up a neurosurgical service, but only because I brought all the instruments. The government has yet to buy one instrument. They are broke and COVID has wiped them out. We actually get donations from local business, Sandals, Rainforest, and others, particularly those two though, and Doctors Cave Beach. resident training. We train neurosurgery residents through the UE program, other residents from other programs, and interns and SHOs. But COVID has closed that down largely at the moment. Everything is done online. We teach the second year neuroanatomy course, which has again closed down because of COVID, but we're doing that for the last 10 years, as well as teaching third to fifth year medical students. UWI exams, because of my experience, I was involved in setting the exam for the last 10 years and arranged external examiners. Arranged neurosurgery resident electives in Canada and Australia. And I've been able to train 3 recruits who have taken over from me here. And there's a 4th who came from Mona. So I'm now retired from the government service. Just as important is the facilitation with my contacts abroad of fellowships. There are 4 neurovascular fellowships I was able to arrange in London, Ontario. One is a radiologist who is back, and a spinal fellowship in Australia. And we also have had the opportunity of having visiting surgeons from time to time. So it's a constant fight, a constant keeping in touch with people that you make contact with abroad as well as here, fighting with the local bureaucracy. You have to live with your other colleagues, say in the operating area, where all of us are fighting for the space. Now there's only one neurosurgery list every other week because of COVID. You can imagine trying to treat the volume of, I have about 40 people with brain tumors on the wait list that I've left for the young guys to try and see if they can do. It is a real battle. It is a real hassle, but in the end, it's worth it. But I have to tell you that I tried to come back when I finished my residency and I was unsuccessful because, as is commonly the case, it is very difficult when you're coming home to sift through the politics and the obstructions that should be not there for young people who want to come home. I had to wait for 37 years to come home, although I was ready to come home when I was finished my residency in 1977, but it was blocked. I have another friend from Trinidad who was the head of neurosurgery in Vancouver for many years. When he attempted to go back to Trinidad, he was told, oh, you're FRCS, we'll send you to Tobago to do general surgery. A neurosurgeon. He immediately got on the plane and went back to Vancouver, where he still lives. So these are stories I can tell you from, and in every specialty, there are stories like this. Certain specialties have been much more open and progressive. I think there have been a very good proliferation, for instance, of urologists and of gynecologists, fellowships in gynecologic oncology. A lot of things have developed over the years since I've been here, but there's still the problem of the young person who has a fellowship, who wants to come home and there's no job. So it's very important for people in that position to have advisors and mentors, to have short and long-term goals, and to keep in touch when away or on return, because you don't know when the opportunity will arise or when you will be told that there's no opportunity. So make your way wherever you are, but you have to keep in touch. Communication is the key. When you do come home, try to establish contact with industry, people within the hotel industry, people that can help you. I have one source who helps me get CT and MRs on patients, as well as instruments for the OR on a regular basis. And I don't overstay my time with this company, but they have helped me tremendously. I will tell you, don't burn your bridges. If you have an appointment where you are, don't burn your bridges, because you don't know when you're going to be having to go back. And don't come home unless you have established links that you can depend on if you have to. And when you do finish, don't expect thanks. I can tell you a story what happened here, because what happens is that the government has passed over the decision of recruitment to a set of bureaucrats who work in administration. And I can tell you of several examples recently, including mine, where an application was made to come without my knowledge. And I was asked to interview this individual who's a good person, but it was done without my knowledge, and the person was appointed without my approval. In other words, you might give everything you want and you have plans for the future, but it's overcome by a completely disorganized administrative system that has no relationship to what's needed. And at the end of the day, you have to be happy that you've made a difference. So those are my comments. I think that I've painted a real picture, but I've illustrated that you can give back whether you are abroad working or whether you're home working, as long as you keep your links and keep communicating. And that in the end, you can only say, I wonder if Robin recognizes that. That's a sunset at the, where I lived for a year as the dean. That's a sunset at the Sandals Island in Bahamas. So I'll close with that. I don't know if people have any questions. That's what I have to say.
Well, Ren, I can feel your heart as you give this talk. From the time you join medicine to the time you are slowly moving off center stage. But there are quite a lot of pearls and quite a lot of lessons, but more importantly, as you said from the beginning, it is about reality. And sitting as the chairman of the National Health Insurance Authority in the Bahamas, I can tell you that your talk was one which touched me tremendously, because the focus at the end of the day is the challenge that we all face in our developed countries in the Caribbean. And that is, we inherited a healthcare system that the British government got rid of from 1948, over 70 years ago, and we still holding on to it. And until we find a better way of funding our healthcare system, until we appreciate that healthcare is a fund, or we accept the philosophy that healthcare is a fundamental right of all people, it's a public good. And until we have healthcare which is accessible and available and affordable to all the people, where they don't have to worry about paying for it at the point of delivery of care, such as what we talk about, universal health access, universal coverage, we're going to continue to have that problem. And unfortunately, it is one of the leading factors why we have individuals, when they go off to train and they want to come back home and they can't. Those are the stark realities. And so there we are. So I think that your talk was right on with regards to giving us a complete spectrum of the whole issue of postgraduate training, where we go, our plans are coming back, and if we come back, what do we do? If we don't come back, how can we help? And also bear in mind that as time goes on and medical care develops and there are new advances, every phase of your life differs. And so with that, unless someone has some burning, can you close out of your screen share, Ren? Okay, I'm trying to. Yeah. Click to exit. No, yeah, okay, good, yeah, okay. So, so does anyone have any questions they would like to ask Ren? We are well over time. Anyone has any questions you want to ask Ren? Going once, twice? Well, while you're thinking about it, first of all, I want to thank all of the participants from all over the world. This was truly a global event. And I think it was most enlightening, and more importantly, it was most inspiring. I think that all the speakers today gave their heart and in terms of the advice they wanted to give. And I'm hoping that I'm so pleased to see that we've recorded this So for those who, and I'm sure that our students will from time to time visit this and I think gain the wealth of information, but more so I like to say the wisdom. I particularly wanted to also thank the Higgins brother for their motivation in this talk. They really brought a different part of it as well. Kevin yesterday was most exciting in terms of his experience, and it's good to see Ricardo again from this other side of the world, and Jean in England and Upton in Canada, and well, as usual, Professor Mallory Williams gives us a stellar performance. So I really want to thank all of you for participating, and for those who stayed the weather and held the course and stayed on to the end. I want to thank you as well, and all the. Also want to thank the chairpersons for each session, Dr. Williams and Dr. Shrinkan and Dr. Sinqui. Wonderful and excellent job, and looking forward to when this is probably done again in a year or two. But we also will have these videos which will continue to be that way for quite some time. And so, gentlemen, I allow you to go. There are those of us who are trying to get to that funeral this afternoon or want to see that as well for Dr. Nain. And if anyone wants to make any comments, I give them we'll have 5 minutes for any comments that anyone wants to make.
Hey, Dr. Roberts, Kevin, yeah.
Kevin.
I just wanted to make a comment. This was an excellent forum, and I really appreciate the opportunity you gave me to present. It's very interesting to hear everybody's different experience, and the performance of our people, our Caribbean people across the world, is exciting. So I would love to see this continuing, and I definitely want to continue to be a part of this if you allow. So thank you again, sir. I really appreciate everything.
Oh, great. Thank you, Kevin. I'm glad you came back on. I didn't know you were back on. Anyone else wants to make a comment before we close out?
Robin?
Jane, you're still there.
Oh yes, I've stayed here the whole time. It was absolutely brilliant. It's really good, and I'm thinking that medical students in the final year or so, this is something that would be good to guide them, to tell them what they can do, tell them the options. And there were some really inspiring talks from people who said, "Oh yes, I went on, I did this route, I came back here, but you have your eye on a goal, and that's so important." But it was absolutely excellent, and I enjoyed it, and I hope that your students, the final year students, learned a lot from it and, are able to decide what they want to do.
Great. Okay. Well, thank you all, and have a pleasant afternoon. I'm going to have me a glass of sherry now. Okay. Good evening, all.
Nice seeing all of you.
Okay, great.
The ones that I haven't seen for a while. You all look pretty good.
I leave. Darren, please leave. I say that we are officially finished. So for those of us who want to continue talking, we can continue talking. So let's move that. For those who want to move out, we can still continue to talk for quite some time on the airways. Jean, how things are going?
Fine.
Robin Roberts, cheers to the chair.
We're in mourning, as you know, because His Royal Highness Prince Philip died, as you know.
Yes.
So all you can hear on all the stations, televisions, everywhere is about Prince Philip. Some people complaining now because they said everything, is all about Prince Philip. Prince Philip want other programs, etc. But we're going all right. Sorry to hear about Eleanor and everything, sort of very sad, Another of your colleagues. Ren, did you know Eleanor?
Eleanor who?
Fong Chong.
You know her. I met her once, and actually it was her friend in Nassau who called me, and I arranged for her to be admitted to a COVID unit a couple of weeks ago. I didn't realize she had died.
Yeah, she just a day before yesterday, and her sister apparently died, who was also about 2 weeks prior with the COVID.
Yeah, and my high school group from my era and even younger have been decimated Yesterday we had about 16 deaths, of which 5 were people who had gone to school with.
My gosh. We are hoping to